check. Hello. Check. Hello. Hello. Hello.
Bara?
Hello. Hello.
we are going to start our session. Requesting all the delegates and faculty members who are in the breakfast area to kindly come in Hall A as we are going to start our session soon. Thank you.
Good morning, everyone. So requesting everyone, please come inside the seminar hall so that we can start without any delay our today's event. Requesting all to please come inside the hall so that we can start the event. Already we are late. So there is no engine that can pull against a heart. There is no force in the world which can pull against a heart. Put your heart into your work and nothing can stop you. These great lines by our respected inspirational person Swami Vivekananda ji. So ladies and gentlemen, good evening to all. Like this unstoppable way, today we all are here for attending the 10th annual conference of ABCD 2024. I am Shumali, your host for the day. I am honored to address you all in this great event of learning journey. Before starting, this is my kind request to all of you to please keep your mobile in silent mode. Requesting everyone, please come inside the conference hall so that we can start the event on time. Already we are going late. We will start our first event by welcome note. I would request Dr. T.N. Banerjee sir to take the dais.
Respected President Dr. Subrata Bhattacharya, Organizing Secretary Dr. Somay Bhattacharya, my dear Dr. Gupta is the Organizing Secretary, fellow members, distinguished guests of the dais, ladies and gentlemen. Good morning and welcome to this 10th ABCDCon. I feel privileged and honored to be present before you for getting this opportunity. You see, you all know that last couple of decades, maybe more, the medical science has grown up and every day there is change. And it's very difficult for busy practitioners like us to keep in track. It is our endeavor to update the local physicians to be updated and keep in track with the update of these medical sciences. And you know that this meeting is not a just get-together. It's just a confluence of trailblazing ideas with transforming insights. And you know this year we are going to celebrate the first decade since we start our journey. And we have tried to include some specific subjects which are being neglected, such as that we have introduced what is the fate, what is the light ahead of us, this diabetic epidemic. Can we prevent? So we have introduced one subject, one topic, that is the primordial prevention of diabetes, and what our target in 2047 that at the centenary years of we'll celebrate, and we'll see that whether the diabetes has come down to a lesser extent. We'll try to infuse some ideas. We have introduced psychiatric subjects. Most of the physicians, you will agree with me that they come across psychiatric problems, functional disorder very commonly. Mainly 30 to 40% of the attendance of the patients belong to this group. So we have tried to introduce this, this topic. We have tried to introduce another thing which often neglect, that is the diabetic retinopathy. We often forget to transfer these patients to the this ophthalmologist, and you know this different data have shown that it is a tragedy if a diabetic patient becomes blind without consulting ophthalmologist. 90% of patients with diabetes you can prevent this diabetic retinopathy. So we have tried also this to give you information about the what is happening in the pulmonology. We have introduced some topics in concern with the tuberculosis. We will try to update you. And so we have got a lot of topics apart from this diabetic cardiometabolic syndrome. So let us join and feel this warmth of this conference. I think you will be richer at the end. We have also introduced nearly 6 hours of this credit covers to this for the first time, and 6 hours, huh? 6+ hours. So those everyone will be benefited from that. And last of all, your engagement, your fruitful engagement will bring success to the conference. We also have taken care of gastronomics. You will feel the what we have prepared this lunch. You will lunch and dinner. You will see the sea changes we have also done in this case. You will enjoy everything. I welcome you. Hopefully, you will enjoy this meeting and carry on sweet memories. Thank you very much. Jai Hind.
Thank you so much, sir, for the lovely welcome note. By this, we will going ahead for the next event, or next speech, rather, the medical ethics and professionalism, and how we will learn about this. For this, I am requesting our chairperson, Dr. Abhijit Das, to please come on stage and take the chair. Dr. Abhijit Das. And Dr. Jayantu Rana. I would request Dr. Jayantu Rana, Dr. Abhijit Das, Dr. T.N. Banerjee, please take the chair, and we will start our fast medical sessions on medical ethics and professionalism.
So good morning. Again, this is the new topic we have introduced, the medical ethics. We, in the very first year, we have also learned this, what is medical ethics. Now things have changed. It has got more importance. And what is the importance you are going to learn from our learned speaker, Professor Aditya Prasad Rai. Please welcome Professor Aditya Prasad Rai. Aditya Prasad Sarkar, Aditya Prasad Rai.
A very good morning to all. At first, I would like to thank the ABCD for calling me, giving me an opportunity to present in front of the August gathering. So let us start with a film. I think everybody has seen this film. What is the film? Can anyone say? এটা কেউ দেখেননি? আচ্ছা, নামটা বলতে পারবেন তো যে হু ইজ দ্য অ্যাক্টর? চার্লি চ্যাপলিন. হোয়াট ইজ দ্য ফিল্ম? আচ্ছা ঠিক আছে, দ্য গ্রেট ডিক্টেটর. ওকে, দ্য গ্রেট ডিক্টেটর ওয়াজ Hitler, as you know, and he wanted that only Aryan blood should be there, all others should be abolished. And at that time, thousands and thousands of patients were used for so-called scientific research, but which was mostly unethical. Somebody was put on the, say, ice slab to find out what is the effect of hypothermia. Somebody was put in a chamber and gradually the oxygen content was taken out and they used to see what is the effect of the lack of oxygen, like that. As you know, Hitler was defeated in Second World War, and ultimately in 1945 he committed suicide. And this is the picture of the Nuremberg trial. There was a trial of those doctors or so-called scientists who were engaged in these works to this Nuremberg trial. Nuremberg is a place in Germany where the Nuremberg trial was held in the 1947. And from the Nuremberg this thing, we had the Nuremberg Code. We'll subsequently discuss. Now this medical ethics and professionalism, as we know, all of us are practicing it, we know. But nowadays, the NMC, the National Medical Commission, they have taken a effort to get the students have idea about this in course curriculum itself. So we will discuss history of ethics, comparison of ethics, morality and law, which are very similar, and principles of ethics, attributes of professionalism, and ethics and professionalism in medical education. Now let us see the previous thing, down memory lane. There is Hammurabi was a king of Babylon, and he formulated what are the should be the behavior of the doctors. Thereafter Plato, Atreya Samhita was there, and Hippocratic oath, as we all know. We take this oath in after passing the MBBS examination. Nazi explanatory told, Nuremberg trial, Nuremberg Code. Ultimately, there was a Declaration of Geneva. In 1948, there was a World Medical Association conference of World Medical Association there, and there took some codes of this ethical codes. Now let us see some scenarios first. Mr. X has come to a doctor with complaints of fever more than 1 month and loss of body weight. Doctor advised blood examination. Mr. X was found to be HIV positive. The doctor asked him to bring his wife for examination, but he said that she is pregnant, and if it is disclosed, then it will cause loss of faith in his wife, and his social prestige will be lost. What the doctor should do? Secondly, Mrs. Y had attended one doctor's chamber with complaints of upper abdominal pain on right side. Subsequently, USG revealed that she is suffering from cholelithiasis, but she did not want to be operated, and she told that she will go to some faith healers for management. And this is the last scenario. That is, Mrs. Y had a breast lump, and her husband took to her doctor. The histopathological examination was done, and it was seen that there is a breast cancer, and the doctor said that she had the breast cancer and needed surgery, but her husband told her, please do not disclose it to my wife, otherwise she will get panicked. Okay. Now, all of this can be answered with the help of we'll discuss later on what are the principles of ethics. Then after we will try to what should be our answers. Now ethics, as you know, ethics is a science which is concerned with the moral behavior, with right or wrong, good or evil of human behavior. Basically, it is more related to morality. Ethics is study of morality, careful and systematic reflection on and analysis of moral decisions and behavior. What is morality? Morality is the individual code for to acceptable behavior. They arise from an individual's conscience. It is the individual behavior. Suppose there is while walking on the road, I see there is a bundle of the 500 rupees note seen on the road. Now, whether I will take or not, that will be decided by my morality. Next comes the ethics versus morality. In case of morality, the sense of right or wrong, there is a personal code of conduct, as we have told, and whether in case of ethics, that deals the right or wrong behavior to the society or community as a whole, not the personal one. Morality is related to personal one, and ethics is related to whole population. Ethics versus law, frequently it is asked how it is differentiated. Definition is ethics are the study what is right and wrong, whether law set a code of legal standards. If we follow the legal standards, it's okay, otherwise we will be punished. Subjectivity is that ethics are subjective, vary among individuals, cultures and religions, while law relatively objective and universal within a jurisdiction. Say how subjectivity law differs. Perhaps all of you knew about euthanasia. Euthanasia is nothing but the mercy killing, and this mercy killing is still now not law, according to law, it is not possible in our country, but they are trying more, but it is legalized in other countries. So thereafter, this thing among cultures it will vary, and law enforced by the government order, and ethics is done by the individual social conscience. And non-adherence to law leads to sanction of penalties, as you know, they punished, whether ethics leads to moral guilt or shame. Ethics কেউ পালন না করলে তার কিন্তু জেল হবে না, but that's a moral guilt or sin. And focus is law indicates what people must do, কি করতেই হবে, and while ethics indicate that what they should do, তাদের কি করা উচিত. There are several branches of ethics. I have mentioned few. That is the medical ethics, research ethics, publication ethics, and bioethics. I will mostly highlight on this medical ethics. Research ethics is the ethics we have to follow. There is a clear guideline of the Indian Council of Medical Research (ICMR) for conducting the clinical trials, and what are the ethical measures we to consider. Publication ethics is that whenever we will apply for the publication of our paper in some journal, there are some ethical issues also, and bioethics also. Medical ethics, what is medical ethics? It's the moral principles for registered medical practitioner in their dealings with each other. That's how we deal with our colleagues, with the patients, and at last it is state. So it is dealing with each other, their patients and the state. What are the components of medical ethics? There are 4 components. Number 1 is the physician-patient relationship. All of us know it. And a physician-physician relationship in between 2 physicians. The physician and the healthcare system relationship, and lastly the physician as a part. He has a great role in society. The physician and society relationship. Now these are the 4 principles of ethics. Buchamp and Shield Childress given in 2009. Autonomy, beneficence, non-maleficence, and justice. Autonomy, beneficence, non-maleficence, justice. What does autonomy mean? Autonomy means I have the right to take decision about myself. Beneficence means whatever I will do, that will for the benefit of the patients. And non-maleficence means what I do that will not cause any harm to the patient. And lastly, justice. Justice means it is not the legal justice in court, it is the distributive justice. That means everybody will be given equally the opportunities. So freedom to make decision about oneself, right to one's self-determination, as I have mentioned about this randomized control trial, in that you have to include the study subjects, but you cannot force anybody to include in this thing. If he or she, all of us know that there is a informed consent form is there, and if it doesn't give the consent, it cannot be included. Beneficence means I think they provided with the intent of doing good, and for providing this benefit, the doctor must be having current knowledge and proper skill, and updated their training, so that individual circumstances all patients and strive for net benefit. আমি না জানলে তাহলে কীভাবে বেনিফিশিয়েন্স করবো? আমাদের যেটা লেটেস্ট ডেভেলপমেন্ট হচ্ছে, উই মাস্ট বি নোয়িং দ্য ডোজ ডিফারেন্সেস। দেন non-maleficence মানে আমি কোনো ক্ষতি করবো না। The procedure should not harm the patients involved there. So there is a concern of primum non nocere. Primum nocere হচ্ছে ল্যাটিন কথা, এর মানে হচ্ছে যে first do no harm and sanctity of life, and be aware that doctrine of double effect. In case of palliative care, we know, as you know, there is a pain in the patients having malignancy, and that pain has to be controlled by with the help of centrally acting analgesics. And as you know, the central acting analgesic also causes nausea, vomiting, etc., etc. So we have to balance between these. Justice, as I have just told, that the picture also depicts, there is an equitable distribution of benefits and burdens. Now, there is a difference between equal and equitable. Equal means everybody is distributed same amount, whereas equitable means everybody is given as per his need. So, more is to be provided to the poorer section of people like that, and less will be provided to the rich people. There are two other principles, privacy and confidentiality. Privacy, as you know, we also try to maintain it. Desire of a person to control the disclosure by his or her personal information. Okay. Even it is said that if you cannot publish any picture in the journal without the consent of that person. So usually, perhaps we have seen that in case of that picture, there is a black band is there over the eyes so that it cannot be recognized. And any confidentiality, obviously, we have to make it confidential. We should not disclose it to others, any other. But it can be violated if the patient may indicate harm to themselves to others. Okay, if I hide this thing, they can probably problem of the others. And if the patient do not give permission for the information to be shared, that is sometimes we have to enforce it. Again, we are coming back to these three pictures. There is number one, the mixture X. What the doctor should do? Anything? Any your idea? Doctor ki korbe ei sense depends upon the patient. Okay. Yet the main thing is that the person is HIV positive and he is trying to hide this from his wife, is it not? And now, obviously, here the autonomy will not act, obviously. কারণ আমরা যদি তাকে ছেড়ে দিই HIV পজিটিভ বলে ডাক্তার বলে দেয় তাহলে তো he will continue with that behavior. So in that case you have to violate the autonomy. Rather you should tell her wife, and rather another thing important, that her wife must also be tested for this HIV, because that will have an implication on the pregnancy outcome. Next, the second part, that is the Mr. Wise attended at a main. There is a here also autonomy would not factor, because this by use of faith healers, we do not know how far scientific it is and how far it will be able to cure the condition. So doctor will let her understand that it should go to some registered practitioner, not the faith healers. And lastly, last term, that the breast cancer one, here it is also to be told to the persons. Often we see that various patients' relatives tell that, doctor, don't tell this information to the patients, they will get panicked. But this is not true. It has been shown that if you hide from this patient regarding the condition, so if by somehow or other he or she knows it, then your credibility will be lost. So another thing is that if we mention that this is your diagnosis, so he may be prepared for the outcomes. Now medicine is about can we, and ethics is about should we. Next comes professionalism. All of us have passed the professional examinations. First professional, part 1, part 2, like that thing. But whenever we take about profession, আমরা যদি বলি লোকটা প্রফেশনাল, ফার্স্ট আমাদের একটা কনসেপ্ট হয় যে প্রচুর টাকা চার্জ করে। We tell them that is a professional, but not so. Professionalism means something different. There are some attributes to professionalism. Profession কাকে বলে? It is a calling means occupation requiring specialized knowledge and often long and intensive academic preparation. All of us have passed through it. Who is a professional doctor? He should be committed to excellence. He should be ethical, responsive, and accountable to patients, community, and the profession. These should be the attributes of the professional doctor. What is professionalism? It is the attributes and behaviors and commitment, values, and goals that characterize the population. তাহলে যিনি প্রফেশনাল হবেন তার এখানে আমরা বিহেভিয়ার, তার কমিটমেন্ট, তার ভ্যালুজ দিয়ে আমরা বুঝতে পারবো যে তার প্রফেশনালিজমটা আছে। অ্যান্ড মেডিকেল প্রফেশনালিজম কি? It encompasses strong societal role and involves emotional component also. Now, domains of professionalism in medicine ki ache? Number 1 is the honesty and integrity. Each doctor must be honest and must be the integrity. There is always to tell the truths and he will be sincere. Accountability is of course there regarding the patient. Responsibility is also there, and respectful non-judgmental behavior. Now, non-judgmental, what does it mean, non-judgmental behavior? Non-judgmental behavior means we are not the moral teachers of the students, we are the doctors. So if a patient with HIV positive comes to us, we should not rebuke them, why you have been the very bad lifestyle, that's why you have got the disease, not that. We have to take it, each and every patient you have to take as a patient, not considering his these so-called guilts. Then there must be compassion and empathy. I think empathy, this word is very much famous nowadays. There is a difference between sympathy and empathy. Whether we are telling about sympathy, that means suppose I am going to the hospital, entering the hospital and seeing the an old woman is in this winter. Bankura thaki, Bankura in the Bankura is very much cold there, and he is chite kaapche. Come on. তা দেখে ফার্স্ট রেজাল্ট উইল বি দেয়ার হুইচ উইল বি সিম্প্যাথি, আমি বলবো আহা লোকটার কত কষ্ট হচ্ছে, বাট দিস ইজ নট দ্য অল। উই হ্যাভ টু সিম্প্যাথি মিনস উই উইল হ্যাভ টু প্লেস আওয়ার সেলফ ইন দ্যাট পজিশন। আমি যদি লোকটার অবস্থায় থাকতাম, হোয়াট এভার আই উইল নিড ইট, সেই ব্যাপারটা ভেবে আমাদের এখন এমপ্যাথি কথাটা খুব বেশি ব্যবহার হয়। কাউন্সিলিংয়ের একটা অন্যতম অংশ। স্কিলফুল কমিউনিকেশন, ডেফিনেটলি কমিউনিকেশন ইজ দ্য মোস্ট useful and most helpful for the doctor-patient consultation. And confidentiality and privacy, we are told, and self-directed learning and appraisal skills. That means that doctor should continue the education, that is a CME, continuing medical education. Medical professionalism is a contract between medical profession and society. It is nothing but the contract between medical profession and society. So the professional doctor should practice selfness, integrity, responsibility, accountability and respect. Respect and maintain professional boundaries between patients, colleagues and society. অনেকে ডাক্তারবাবু আছেন, they cannot maintain this boundary, and that's why various problems occurs. I have seen a doctor who, house staff of course, after he was so much acquainted with the close to the patient party that when the patient died, and he cried more than his relatives. Okay, so these things should not be done. Always you should remember that there should be a border between this patient and doctor, and he has to demonstrate the ability to manage an ethical and subprofessional conflicts, abide by prescribed ethical legal codes, not only the ethical but also legal codes, as you know, demonstrate a commitment to the growth of the medical profession as a whole. These are the role of the professional doctor. What are the barriers of professionalism? Number one is a high workload. Due to the high workload, doctor-patient communication is not being given or cannot be given for a proper time. বেশি পেশেন্ট থাকলে তাদের প্রপারলি আমরা করতে পারবো না। ইনঅ্যাডিকুয়েট ক্লিনিক্যাল মনিটরিং যদি হয়, ল্যাক অফ ইন্টার প্রফেশনাল কোলাবোরেশন, পার্সোনাল বায়াস থাকে অনেক সময়, ফাইন্যান্সিয়াল প্রেশার, সবাই জানেন এটা বলার কিছু নেই। বার্ন আউট ইজ দ্য স্ট্রেস, বার্ন আউট মিনস দ্য স্ট্রেস আউট অফ দিস সিভিয়ার প্রেশার, ওয়ার্ক প্রেশার, poor communication skill, lack of accountability, and they are not prioritizing patients' need over personal interest, and lastly, failing to maintain ethical standards. These are the barriers of professionalism. Now, relationship ethics with professionalism. দুটোকে আমরা একসাথে কেন দিয়েছি? Ethics are fundamental moral principles that guide behavior, while professionalism is the application of those behavior. Ethics is the behaviors, the moral principles that guide the behavior, but professionalism is the application of those ethical principles within a professional setting, essentially, meaning, and professionalism is the outward expression of ethical conduct in professional context. In simpler terms, ethics form foundation professional behavior, ensuring that a professional acts with integrity and responsibility in their field. তাহলে এথিক্স যখন হবে, এথিক্স আমাদের মডেল প্রিন্সিপাল গাইডলাইনগুলো দেবে, অ্যান্ড প্রফেশনালিজম সেখানে কিন্তু দ্যাট ইজ দ্য অ্যাপ্লিকেশন অফ দিস থিং, এথিক্স অ্যান্ড ethics and professionalism in medical education. Actually,
Sir, 2 minutes is left.
Actually, ethics, we have we know that we were not taught the ethics and professionalism during our undergraduate days. Okay, then how did you do it? We all don't know it. We have an idea about it. How did you know it? With the help of by seeing the seniors, by seeing the teachers, we used to imbibe all these qualities. But as you know, National Medical Commission, it has passed graduate medical education rules in 2019, and thereafter the competency-based education has been started, and there they have purposefully introduced one module called ATCOM module. ATCOM means AETCOM, that is Attitude, Ethics and Communication, and that are being taught in the class. Not only that is also question comes in the exam, that is also evaluated in there. Okay, so And another is that regarding professionalism, there is a course called in CBME called the foundation course. At the beginning of the first MBBS, whenever they are admitted to the medical college, they are for 1 month, they are given the various exposure to different ideas, different things like this. Professionalism on of that, they are also exposed to that. So this is the ethics and professionalism in medical education. Professionalism is not a label you give yourself, it's a description your hope others will apply you. নিজে নিজে প্রফেসর বললে হবে না, অন্য যে বলতে হবে। Thank you.
One thanks to our respected professor, Dr. Aditya Prasad Sarkar, and his very good deliberate speech, and already we remember our student life regarding that ethics, and all of my, there is the, all the delegates, they also enrich with that. So thank you very much. And there is any question from the audience, there are 2 questions have been, we are allow because to the professor sir, Dr. Aditya Prasad Sarkar, about the ethics.
Actually, the third case, where the breast cancer was there, third case, that is a breast cancer. Sometimes what happened, these sorts of bad news, how to break the bad news to the patient as well as relative. There is an art. This is basically art. To how to say that I am giving example. This particular case. What I used to say, your blood report is good, your X-ray, everything is good. There is no problem at all. But your FNAC from the breast, which is having some problem, but we have to look after this matter, and you may have to take some other medication from the specialist doctors. And some way you can convey the same message by the different way. That is called the breaking of the bad news. That used to happen in critical care setting. Patient is very bad condition. So Aditya, please.
Thank you, sir. Actually, the breaking of bad news is absolutely correct, you have told. And there are various models of breaking of bad news. How the bad news should be broken to the patients or the relatives. There are various models like spikes model, etc. Thereby we can deliver this bad news to the patient or the relationship also. Not that patient ঘরে ঢুকলেই বলে আপনার তো breast cancer আছে, not that. It's something we have to better, something else.
Also, one thing I like to say that nowadays this medical profession has gone this another way. In yesteryears, we used to see that cancer means moron. There is no way out. এখন বোঝাতে হবে পেশেন্টকে যে ব্রেস্ট ক্যান্সার ইজ ট্রিটেবল অ্যান্ড 100% ট্রিটেবল। যখন তুমি ব্রেক করছো যে হ্যাঁ তোমার ক্যান্সার হয়েছে, অ্যাট দি সেম টাইম তোমাকে বলে দিতে হবে যে ইউ আর গোয়িং টু বি রিকভার্ড, ইউ আর গোয়িং টু রিকভারি। সো ইটস ভেরি ইম্পর্টেন্ট অলসো সে দি হোয়াট ইজ দি প্রোগনোসিস অফ দি ডিজিজ।
ওকে স্যার, থ্যাংক ইউ স্যার।
Any more questions from audience?
অনেক সময় পেশেন্ট মারা যায়, আমরা ডাইরেক্টলি বলি না, তখন ঘুরিয়ে ফিরে কিছু বলতে হয়। যেন আমি পেডিয়াট্রিক্সের করেছিল যেরকম ডাক্তারবাবু বলছে আপনার বাচ্চা খুবই খুবই খারাপ, আমি জানি না কি, তবে আমি আমার চেষ্টা করে যাচ্ছি, আপনি আর আছে উপরে ভগবান আছেন, ভগবানকে ডাকুন, আমি যত রকম চেষ্টা করে যাচ্ছি। দিস টাইপ অফ মানে ডাইরেক্টলি না বলে একটাই বাচ্চা তার বাবাকে বা ওর মাকে না বলে এবার ইনডাইরেক্টলি বললে আমার বোধ হয় ভালো হয়। এটা আমি পেডিয়াট্রিক্সে যাচ্ছি দেখলাম। হ্যাঁ, সে বলতে হবে, কিন্তু ওরা তো বুঝে ফেলে, এবং অনেক অভিজ্ঞতা, অনেক ওরা আস্তে আস্তে বুঝে বলে আমার দেখে ওরা সব বুঝে ফেলে। হ্যাঁ হ্যাঁ, না না ভগবান না। আর একটা হলো যে আদিত্য স্যার যেটা বললেন যে অনেক সময় আমাদের ইয়েতে জার্নালে কিছু প্রকাশ করার জন্য আগে কিছু দিলে, ছবি টবি দিলে পারমিশন নিতে হয়, তেমনি আমরা যে কমিউনিটি মেডিসিনে ফ্যামিলি করি ছেলে মেয়েগুলো ওই সেই ফ্যামিলি ছবি নিয়ে চলে আসে। আমি তুই জিজ্ঞেস করেছিস? অবশ্যই জিজ্ঞেস করবি।
ওকে ওকে স্যার, স্যার জাস্ট
সময় কিছু বলবে? সময়
হ্যাঁ
হয়েছে?
হ্যাঁ স্যার,
ওকে, থ্যাংক ইউ, থ্যাংক ইউ অল।
Thank you. A big round of applause for our great speaker and great learning episode. And now there is a small felicitating episode, and I would request our chairperson to give the small token of respect and love to Dr. Aditya Prasad Sarkar sir. Audience, please give a big round of applause for that, for the nice sessions of ethics. So I would request our chairperson to give the token of respect to our speaker. So next, I would request our next chairperson. So please felicit our next chairperson. A big round of applause, please. So I would request our chairperson to give the So the next okay, fine. So our next
I want to make an announcement. If everyone can hear me, I am requesting all the pharma colleagues, delegates, and faculty members, those who have yet to have their breakfast, kindly take your breakfast as it will close by 10. Thank you.
So our next event, the topic is primordial prevention from primary preventions of type 2 diabetes mellitus, the step towards reality. For that, I am requesting the chairpersons, Dr. T.N. Banerjee and Dr. Abhinav Chaudhary to take the chair. Requesting Dr. Abhinav Chaudhary and Dr. T.N. Banerjee sir to take the chair for our next sessions. And just a small announcement that the whole sessions, it will take 20 minutes, the time given for that, and the 5 minutes for Q&A. So kindly follow that time. Thank you.
So once again, we are going to see that how important it is to know that everything is not this black in this management of diabetes. So we have tried to introduce what is the light ahead. Can we think that diabetes can be prevented? Here we are fortunate to have Dr. Hamadur Rahman, who is very known to us, is a son of the soil, and I am privileged to say that he is going to deliver this primordial prevention of diabetes ahead of primary prevention. And what is the target in 2047 when we will celebrate our centenary of our independence? Over to you.
Thank you, sir, for kind introduction. At the outset, I would like to thank the organizer of ABCDCon for giving me this opportunity to talk on this important topic, primordial and primary prevention of type 2 diabetes mellitus. As sir rightly told, with diabetes, some hope is there. Not only the medications, not only the insulin or GLP-1 analogs, injectable, nowadays oral semaglutide. So we have certain light of hope for our next generation. Maybe a less scope for our generations, but for our coming generations, we have certain hope to prevent the diabetes mellitus. We know the global prevalence of diabetes underscored the urgent need for prevention. If we know the figures of diabetes mellitus, then we would try to understand, rather than treating diabetes and its complications, what is the way out of preventing diabetes mellitus, rather than going for only treatment and treatment of the complications and ultimately succumb to cardiovascular disease or renal problems. Worldwide, an estimated 537 million adults aged 20 to 79 years have diabetes mellitus, and we all know the mostly 95% of it is type 2 diabetes mellitus. The rise in prevalence accelerated in this century. 74 million adults in India had diabetes in 2021, that is 1 in 12, and The ugly part is that more than half of the subjects of diabetes are underdiagnosed. We know the tip of the iceberg phenomenon for diabetes mellitus, for any chronic disease, any non-communicable disease, the tip of the iceberg phenomenon is there. Only part of the iceberg is visible and rest almost 9 out of 10 part is not visible. Similar is the case of diabetes mellitus. So the number of diagnosed diabetes is far less than the number of undiagnosed diabetes. And that's why we see patients with acute coronary syndrome in the emergency with very high blood sugar of 500 or 600. We see patients of stroke with HbA1c of 11, 12, 13. So those people are not diagnosed of diabetes mellitus for pretty long time. And the diabetes in India is associated with certain characteristics like earlier age of onset. They have certain phenotypic features. I'll be talking in detail. More than 90% of Indian patients with diabetes are estimated to have dyslipidemia, which is a deadly combinations for the coronary artery disease and other complications. There are recent publications by ICMR India study, and it basically depicted that prevalence of pre-diabetes is 15.3% and prevalence of diabetes is 11.4%. So the huge prevalence of diabetes and pre-diabetes, if we combine these two, it will be 26%, 26.7%. So every 1 in 4 people is having diabetes mellitus or going to have diabetes mellitus. And remember, the progression of pre-diabetes to diabetes in Indian is much more higher than the Western population. I'll be showing 2 studies, diabetes prevention study from West and diabetes prevention study from India. And the consequence of the high burden of diabetes is 8.5 million excess deaths, 42.7 million years of life lost, and 2.6 trillion of US dollars is lost in GDP. So concerning the trend emphasizes the need to urgently address the diabetes and its associated complications, how we can prevent rather than treating diabetes mellitus. And diabetes is not a single disease like pneumonia, like a wound, infections. Diabetes often invites other problems like heart failure, like coronary artery disease, like chronic kidney disease, like cerebrovascular accident, and like other chronic complications like food disease and all. The prevalence of diabetes starts increasing at a very tender age in middle income countries. If you see these 3 graphs, the orange one is the middle income countries, the blue one is for high income, and the gray one is for low income countries. See, at any point, particularly for the middle aged, for 40 to 44 years or 30, from 30 to 60 years, see the highest prevalence among the middle income countries. So when people are earning from 30 to 60 maybe, so that time diabetes is attacking in the middle income countries, so preventing them from basically highest output. The Asian Indian phenotype, what I am talking about. So they have a low BMI. The body weight is not that much high. Body mass index is not that much high, but despite that, they have high waist circumference. They have the abdominal obesity. They have the high waist-hip ratio. They have the high visceral fat content, ultimately leading to increased insulin resistance, high prevalence of atherogenic dyslipidemia, like small and dense LDL cholesterol. They have hypertriglyceridemia. They have typical low HDL, and they have early beta cell defect, and beta cell exhaustion ultimately leads to early initiation of insulin. And there are certain issues in the management also. The awareness level is drastically low. There is a high prevalence of undiagnosed diabetes, as I told, and unaffordability and lack of insurance coverage for OPD patients is a problem here, and unavailability of trained medical and paramedical personnel is another issue for managing type 2 diabetes mellitus. So why prevention is important? As I told, type 2 diabetes is not only a disease entity, it invites a cluster of diseases like cardiovascular diseases, like kidney problems, cerebrovascular problem, foot infection, diabetic foot, and retinopathy, neuropathy. So it encompasses a variety of diseases. So if we can delay the onset of diabetes mellitus, or if we can prevent the diabetes mellitus, then probably we are going to reduce the cost of therapy and morbidity and mortality. So there is the need of prevention. The good part is that if you see the evolution of diabetes, at certain point we have normal glycemia, then early glucose intolerance or early impaired fasting glucose, then impaired glucose tolerance or impaired postprandial glucose, then only we develop diabetes and later on the complications. So a long lag period is there before diagnosing diabetes. So if we are careful enough, if we are aware enough to take steps in these days, then we can prevent or delay the onset of diabetes, and we can prevent the complications of diabetes mellitus. So diabetes is preventable. It is not inevitable, it is preventable if we take care to that extent. Now regarding prevention, we have the primordial prevention, we have the primary prevention, we have the secondary and tertiary prevention. For secondary and tertiary, those are not prevention at all. For secondary prevention, we can prevent the complication. For tertiary prevention, we can prevent the death. So for primordial prevention, it basically speaks about the adaptation of strategies during the phase of normal glucose intolerance to stop the emergence of the risk factors before they have appeared. And the preventive measures comprise the maintenance of normal body weight through the adoption of healthy nutritional habits and physical exercise. So the nutritional habit and physical exercise are the cornerstone for the primordial prevention. If we take a breakfast like this, puri and dal chana and mithai, then probably we are not going to able to prevent the diabetes mellitus in our population. We have to change the attitude, and I would request the management if we can change the healthy diet attitude starting from the conference point, so that will take care. So we can keep all the options there. These are the healthy diet to prevent diabetes and chronic diseases. These are the diet those who don't want to follow. So we can keep both the options. So in medical practice, what is accomplished by screening for hyperglycemia and detecting diabetes in the initial stages of its accepted history recommends that impaired glucose tolerance is the stage for primary prevention of diabetes. Not only impaired glucose tolerance, impaired fasting glucose also, or early glucose intolerance, we can take as a target for primary prevention. For secondary prevention, those who are already developed diabetes, by good control, we can prevent the complications. That is the secondary prevention. And tertiary prevention is basically the prevention of the treating the complications and preventing further morbidity and death. So what is needed in primordial prevention of diabetes? That is, disease should not develop. We should be able to treat the risk factors like obesity, and we should take care of our diet and exercise. So this is a nice diagram. This is the primordial prevention. We can basically approach to the population or high risk obese subjects, and we can prevent the diabetogenic factors, diabetogenic risk factors. For primary prevention, we again have to approach to the population or high risk population, where we can target the pre-diabetes or early glucose intolerance or impaired fasting glucose. Here is the secondary prevention to have good control of diabetes, and tertiary prevention to treat the complications or end stage complications of diabetes mellitus. So one important thing is in primordial prevention is to prevent gestational diabetes mellitus, or those who are having gestational diabetes mellitus. If we can have very good glycemic control in those subjects, then we can prevent diabetes of those mothers later on having diabetes mellitus, and the offspring born out of that gestation, we can basically prevent diabetes mellitus later on. During gestation, it is the genetic programming that happens, and it is the hyperglycemia that basically sensitizes the cardiovascular system and central nervous system. Basically, they get insulted with the high blood glucose. So that genetic imprinting is carried by the offspring later on in the life, and they are basically developing diabetes mellitus later on. So we should prevent obesity, polycystic ovarian syndrome in our young females. So if we can prevent that, we can be able to prevent gestational diabetes mellitus. Even those who are having gestational diabetes, we can have good glycemic control during pregnancy. If we can have good glycemic control during pregnancy, then probably we are going to prevent the macrosomia during in the birth. So if we can have that, then we could have good infant, good offspring, and we can prevent obesity and diabetes in the youth. So gestational diabetes mellitus, or even before that, young females should be our target. If we can have a good healthy females, then we can have a good healthy nations. So women with gestational diabetes are an ideal group for primary prevention of diabetes. We have different guidelines for their diagnosis. We can target them. If we can address the prevalence of hyperglycemia in pregnancy, then we are going to succeed in this area. However, the Southeastern Asian regions have very high prevalence of gestational diabetes mellitus in comparison to others. And according to fetal origin of diabetes hypothesis, adult health and diseases are inextricably linked to gestational programming. So Liz Kingo rightly told that female gender the key to diabetes prevention. As I was talking about, if we can have good glycemic control during pregnancy or no diabetes during pregnancy, we can have a good healthy baby, and there will be no elevated risk for obesity, diabetes, hypertension, or cardiovascular disease in the later on, and thereby we can prevent the intergenerational transfer of risk factors of obesity and diabetes mellitus. So this fetal origin of adult diseases, as I was talking, gestational programming is a process whereby the stimuli, maternal fuels, or stresses that occur at critical or sensitive periods of fetal development permanently change the structure, physiology, and metabolism, predisposing individuals to disease in adult life. Exposure to the fetus to a hyperglycemic environment in utero is associated with an increased risk of developing impaired glucose tolerance or having decreased insulin secretion in adulthood. This risk is independent of the genetic predisposition of type 2 diabetes that the child inherits from its parents. Human pancreas begins to develop at 4 weeks after conception, and first insulin deposits can be found between weeks 7 to 8, and pancreatic islets differentiate at 10th and 11th weeks of gestation sorry, and recognize and respond to maternal glycemia from 11th week of gestation. And central nervous system and heart are among the most sensitive organs and are prone to be affected in utero insults. This is one study. It showed basically treating gestational diabetes mellitus. If we can have good glycemic control, then it will have no adverse effect in the outcome. See, the bar diagram, the gestational diabetes and non-gestational diabetes, basically there is no adverse outcome in the birth weight. Both the groups, they basically behaved similarly. If you see the pattern of glycemia in normal pregnancy, then we would see HbA1c levels measured at 8 to 13 weeks of pregnancy were significantly higher in women who developed gestational diabetes mellitus later than those who did not develop gestational diabetes. So at 8 to 13 weeks, if we can target and see whether the HbA1c is 5.3 or more or not, or even more than 5.1, then we can take care. We can sensitize them. You are going to develop gestational diabetes, and if you want to have a healthy baby, then start here, start now to prevent gestational diabetes mellitus. And the pre-pregnancy planning is ideal for a better fetal outcome. It is necessary to optimize metabolic control early in pregnancy and prediction of gestational diabetes, that is PP, postprandial blood glucose more than 110 at 10th week of gestation. If we can target those subjects, and we can advise them medical nutrition therapy, and if required metformin, then we are going to prevent the diabetes mellitus during gestation or later on for the babies. Now I am talking about primary prevention in two landmark studies, that is diabetes prevention program from West and Indian diabetes prevention program. Although this is published in 2002, there is no such study I could quote. So in this landmark study, 3,234 non-diabetic persons with elevated blood glucose, fasting or impaired glucose tolerance are randomized to placebo or metformin. See, metformin 850 milligram twice daily was used, or a lifestyle modification program. Lifestyle modification program was at least a 7% weight loss and at least 150 minutes of physical activity per week. The mean age of the participants was 51 and body mass index was 34, and there was 2.8 years follow-up. And the incidence of diabetes was 11% in the placebo group, 7.8% in the metformin group, and 4.8% in the lifestyle groups. So the lifestyle intervention reduced the incidence by 58% and metformin by 31% as compared to placebo. And the lifestyle modification was significantly more effective than metformin. So they concluded that lifestyle changes and treatment with metformin both reduce the incidence of diabetes in persons at high risk, in persons with pre-diabetes, and the lifestyle intervention was more effective than
Sir,
metformin.
2 minutes left.
Yes, sir. So another study from India, the Indian Diabetes Prevention Program by Mr. Dr. Ramachandran et al. From South. Basically, this is a prospective community-based study, and they basically show the progression to diabetes from impaired glucose tolerance or impaired fasting glucose, whether it could be influenced by interventions in native Asian Indians with IGT who were younger, leaner, and more insulin resistant than the Western counterpart. And they included 531 subjects and randomized into 4 groups. Group 1 was control, group 2 was advised for lifestyle modification, group 3 was treated with metformin, and group 4 was given lifestyle modification plus metformin. And the median follow-up was 2.5 years, and the 3-year cumulative incidence of diabetes was 55%, 39.3%, 40.5%, and 39.5% in group 1 to 4 respectively. So group 1 was basically plus control, group 2 was lifestyle, group 3 was metformin, and group 4 was lifestyle modification plus metformin. So the relative risk reduction was 28.5% for lifestyle modification, 26.4% for metformin, and 28.2% lifestyle modification plus metformin. Sorry. So the number needed to treat to prevent one incident diabetes was 6.4 for lifestyle modification, 6.9 for metformin, and 6.5 for lifestyle modification plus metformin. So progression to IGT to diabetes is high in native Asian Indians, and both lifestyle modification and metformin significantly reduce the incidence of diabetes in Asian Indians with IGT, and there was no added benefit from combining them. So there are certain primary prevention strategies addressing the high-risk approach, focusing the high-risk groups, involving individual counseling. 1 or 2 minutes more. This approach can also be used by the general practitioners while attending to patients and counsel the families for prevention of diabetes among the high-risk groups. And the high-risk groups includes basically pre-diabetes, those with positive family history of diabetes, aged more than 40 years, stressful and sedentary lifestyles, people with high blood pressure and cholesterol, increased body mass index, increased waist circumference, and women with history of high blood sugar during pregnancy. Again, the similar approach we can apply for our populations. This is a simplified conceptual framework that we can have. We can increase the awareness. We can have a screening program for our population for the high risk. We can have the primordial prevention, targeting population, eliminating the risk factors, public education, increasing awareness, and provision of access to healthy foods, and provision of access to exercise. In Newtown, there are certain provisions for exercise is there. Primary prevention, individuals with pre-diabetes, they should have structured program to reduce body weight, increase physical activity, along with a healthy diet. We can approach to our children who are less than 10 years, but severely obese, or children more than 10 years after the onset of puberty with overweight and obesity. We can go for the abnormal glucose metabolism is there or not. Certain guidelines to the doctors to display the charts and posters in their clinics, spread awareness. We can involve the nurse and assistants, For this, there are certain gaps in the type 2 diabetes translational research in India. There is lack of large-scale health surveillance, inadequate preventive efforts, audit and capacity building is low awareness in type 2 diabetes, and we need, there is a need for well-integrated translational research. Lifetime risk management for developing and managing type 2 diabetes, as I talked, those who are having increased genetic risk, they should have receive a counseling, and they should given the opportunity to reduce the risk. We should have primary prevention by eating healthy, engaging in physical activities. We can prevent diabetes by again reducing the risk factors, and we can manage and prevent the complications of diabetes by lifestyle and medication. So to summarize, prevention strategies and public health focus, diabetes prevalence is rising globally, but lifestyle changes can delay onset in prediabetes. Primary prevention of diabetes focuses on maintaining normoglycemia in at-risk individuals. GDM offers a chance to implement diabetes prevention strategies. Public health initiatives should improve maternal health pre and post-conception, and preventing transgenerational glucose intolerance requires universal screening and euglycemia in the pregnant women, and we should make accessible glucose testing for all pregnant ladies that supports the goal of a diabetes-free generation. Thank you all. Thanks for kind attention.
Thank you, sir. We have very little time. We can go for 2 questions. So, if anybody has any questions.
No question. It's an excellent presentation.
Thank you, sir.
Our appetite is fulfilled, and you have mentioned how this gestational diabetes, this pregnancy is important for the society. It's very important, and also this gynecologists should be also, obstetricians should be involved in this.
Yes, sir.
One more thing is that I like to highlight that our grandson, if you want to get rid of this primordial prevention, so you have got only 3 decades left. If your target is 2047, then you should start right from the beginning. So what is the target? Target is the prepubertal female. We should take care of their health such that during their pregnancy time, they are pretty healthy. There is no sarcopenia, there is no insulin resistance. So it is very important for these preschool children as well as this secondary, pre-secondary children to take care of this. I think the government is the best, the government can take best care of this, and the society also best take care. Thank you very much. If there is any question.
Thank you, sir.
No, thank you so much.
A big round of applause. And now it's a small session of felicitating our speakers and our chairperson. For that, I would request chairperson and speaker to the next stage. And now I would request Dr. Shubhamay sir for a small announcement.
Big applause, please.
A big round of applause, please, for the nice session.
আমি বন্ধ করেছি একটা ইম্পর্টেন্ট অ্যানাউন্সমেন্ট আছে আমি বন্ধ করেছি Hello, attention everybody. I have a rather bad announcement for our ABCDCon that Dr. Pratik Das, nephrologist, scheduled to speak at 2:50 in the afternoon, has called me just now. He is unable to come because of a serious fire in his house, and one floor is actually gutted out. And from the fire from the inverter, fire brigade has come and all these things are happening. So he has called me. So this session we are dropping out. That's the announcement. Thank you.
Thank you, sir, for the announcement. And the next session of the day, acute on chronic liver failure approach to diagnosis and management. For that, I am requesting our honorable chairperson to take the chair, Dr. Naga and Dr. Shubroto Bhattacharya, sir. Please come on stage. For our next session, acute on chronic liver failure approach to diagnosis and management. Dr. Naga and Dr. Shubroto Bhattacharya, sir. Requesting chairperson to please come. So we will going to start our next sessions. The topic acute on chronic liver failure, approach to diagnosis and management. For that, I would request our chairperson to announce our speaker name and welcome.
Good morning to all. I am requesting Dr. Saptoshi Vishnu to speak acute on chronic liver failure, approach to the diagnosis and the management. The subject is very vast, but Dr. Vishnu is an expert orator, so I think he will discuss the matter in this short time. Thank you, Dr. Vishnu. Please start.
Thank you, sir, for the kind word of introduction. As I always say, coming to ABCDCon is like coming home from home. So it's wonderful to be here with you. I'll start with the concept of ACLF. I plan to go into the definitions, the pathophysiology, the severity assessment in ACLF. How do we prognosticate patients in ACLF? What are the principles, not the details, but the overall principles in management of acute and chronic liver failure? And what are the advanced therapies? So I decided that since we are all clinicians here, so let's start with two clinical cases first. So first case is a 65-year-old male who is a diabetic, well controlled on OHs, who presented with abdominal swelling and bipedal edema for the last 3 weeks. On examination, he had pulse of 84, blood pressure was 126 by 84. He did not have any jaundice or pallor, but ascites was present, grade 2. USG showed that the liver has got a nodular margin, dilated portal vein, and ascites. Lab test showed hemoglobin 10.4, platelet was 1.2 lakhs, albumin was 3.45, bilirubin was just 1.8, ALT, AST were 39 and 42, and on endoscopy, he had small varices of 3 columns. The second case, I'm so sorry, I just copy-pasted it wrong. So the second case was a 35-year-old gentleman who was having alcohol use disorder, taking about 375 ml of alcohol every day. He presented with jaundice for 3 weeks, ascites for about 10 days, and he was having fever for 3 days. On examination, he was having pulse rate of about 126, blood pressure of about 100 by 50, respiratory rate was 28, his bilirubin was around 16, ALT was 45, AST was something around 223, USG showed hepatomegaly with ascites. He was also having upper GI bleed for the last 3 episodes in the last 3 months. And upper GI endoscopy showed large varices of 4 columns. So if you ignore the left-hand side, so if you take these 2 patients, who do you think has a better chance of survival? You see all these patients in your clinic on a daily basis. One patient coming with only ascites, one patient coming with jaundice, GI bleed, ascites, tachycardia, tachypnea. So anyone from the house, who do you think has got a better chance of survival? He is 35. He is having tachycardia, tachypnea, jaundice, ascites, and he has got large varices. He is a bleeder. Compared to that, the elderly gentleman has got only ascites and non-bleeder. So who do you think has got a better chance? So I thought I would end the this presentation here only, because this patient, the 65-year-old male who is on diabetic, surprisingly will have a better outcome than the 35-year-old person who is an active alcoholic and presents with SIRS, with sepsis, with organ failure. So this brings us to the concept of acute on chronic liver failure. It might seem counterintuitive that a person who is already grossly cirrhotic has got a better survival. So how is that? Now remember that both of these patients are cirrhotic. Why? Because both of them have got varices. So varices are indication of portal hypertension, which ultimately gives us the diagnosis of cirrhosis. So both of them have cirrhosis. Now we have to understand that cirrhosis is not a homogeneous entity. Cirrhosis has got various stages. It can be a pre-cirrhotic disease where chronic hepatitis and chronic liver disease may present. Then they have a compensated cirrhotic phase of about 10 to 12 years. Then what happens is, usually the first gentleman, the 65-year-old gentleman, he had what is called an acute decompensation. So what are the acute decompensations? It is ascites, GI bleed, encephalopathy and bacterial infection. The second gentleman, he is also having, by our definition, an acute decompensation, but he is having a more severe form of disease. He is having sepsis, he is having GI bleed, he is having tachycardia, he is having tachypnea, he has got some lung crepitations, he has got some infection. So that person is a worse kind of acute decompensation. This is something more than acute decompensation. He has got organ failures. So this involvement of the organ systems or systemic dysfunctions involving the liver, kidney, brain, coagulation, circulation. So when these happen, when these organ systems go into organ failure of the liver, kidney, brain, coagulation, circulation or lung, then we have something called acute on chronic liver failure. This is a worse form of acute decompensation. This happens not in all cirrhotic patients, but in some cirrhotic patients, and sadly the outcome or the mortality in these patients is worse, not because of the liver dysfunction, but because of the associated organ failures. The patient dies because of sepsis, the patient dies because of circulatory shock, the patient dies because of a bad pneumonia which we can't take him out of the vent. So these are the causes of mortality in the cirrhotic patient. So this is what the concept of ACLF came about. Now if you look at this, if we have something called a hypothetical hepatic reserve, we can't measure hepatic reserve as such, but suppose we have something called a hepatic reserve. Now this is a patient with decompensated cirrhosis who already has a ascites for a long period. So what happens is that if a patient with decompensated cirrhosis has a little bit of infection or a GI bleed or an episode of hepatic encephalopathy, his hepatic reserve will gradually decrease until at the end of his life, he will get admitted under us in some nursing home. You will see that he has got a raised creatinine, he has got a pneumonia, he has got hepatic encephalopathy, he has got sepsis, and ultimately the patient will succumb in this stepwise, gradual, decremental fashion. Acute on chronic liver failure patients usually have a better reserve. You see, in our patient, he was a 35-year-old gentleman. He is supposed to have a better reserve. His liver is not grossly cirrhotic or nodular. So he has got a better reserve, but it is less than a healthy person because he is alcoholic. The hepatic reserve is a little less. This is not 100%. This is somewhere around 80% or 70%. If that person has got another acute injury, for example, excessive consumption of alcohol or some viral hepatitis, what will happen is he will have a rapid decrease of hepatic reserve. And if we take some hypothetical and few thresholds for liver transplant and failure, so what happens is if we intervene in this short time period in these patients with acute on chronic liver failure, they will have a spontaneous recovery. They will not go back to the normal person or even to that pre-disease or pre-ACLF condition, but at least they will make some recovery and they will not go into liver failure, not go into multi-organ failure, and they will not die. However, if we do not intervene in this golden period, this opportunity will be lost and the patient will ultimately land up in multiple organ failure and will ultimately succumb. So the definition of ACLF came from all across the world. From the Asia Pacific region, they defined ACLF as an acute hepatic insult with bilirubin more than 5 and INR more than 1.5, complicated within 4 weeks. This is important. Jaundice, within 3 weeks, the patient has got ascites or encephalopathy in a patient who had a previously diagnosed or undiagnosed chronic liver disease. So the second patient, the alcoholic patient we saw, he was not having a cirrhosis diagnosis from before. But still, according to this definition, he had jaundice, followed 3 weeks later by ascites. So we can label him as an acute on chronic liver failure. The next definition came from Europe, where they showed that ACLF is a severe form of acutely decompensated cirrhosis associated with a high 28-day mortality and is characterized by the functional failure of one or more of the 6 major organ systems. I'll come to that later. And the North American Consortium for the Study of End-Stage Liver Disease, they said that ACLF is a cirrhotic person who has got 2 or more organ failures, who either requires dialysis, that is a renal shutdown, who has got a West Haven grade 3 or 4 hepatic encephalopathy, that is a neurological organ failure, who requires mechanical ventilation or BiPAP, that is a respiratory organ failure, and who needs vasopressor support, that MAP less than 60, that is a circulatory organ failure. So out of these organ failure, brain, kidney, circulation and lungs, out of these, if there is 2 or more organ failure, then according to the North American Consortium, we can classify that patient as having acute on chronic liver failure. So just to summarize, the Asia Pacific, it takes into consideration mainly the hepatic failure variables like bilirubin, INR, ascites. EASL, they take into combination both the hepatic and as well as the extrahepatic organ failures. And the North American, they take care of mostly the extrahepatic organ failure. So for our daily practice to define ACLF, APASL is APASL criteria of jaundice followed by ascites or encephalopathy within 4 weeks. That is a very good definition. For the purpose of managing the patients or prognosticating the patients or finding out which organ systems we should target, the ESL or CLIF-C criteria is very important, as we shall see in the subsequent slides. So pathophysiology of ACLF, I'm not going into much detail. Believe me, in my DM theory exam, out of 10, 8 questions were from ACLF, and I had to draw this picture maybe 8 or 10 times, so I got thoroughly fed up, and I really don't like this slide. But what happens is that in cirrhotics, there is a dysbiosis or leaky gut, so all the PAMs and DAMs, the pathogen-associated molecular patterns or the damage-associated molecular patterns, they go into the portal circulation, they cause acute insult to the liver, and they activate a chain or cascade of inflammation, which then spills out from the liver and goes via the circulation to various organs. So in this respect, it is not much different from our sepsis. What happens in sepsis is you have a focus, the kidney. So you have got a pyelonephritis there. So all the inflammatory molecules, they gather there, they form there, they have a positive feedback effect on each of the molecules, the cascade starts, and then it gets circulated into the lungs, into the brain, into the circulation, into the myocardium. So this is something, what happens in acute and chronic liver failure. So acute and chronic failure patients are very similar to your septic patients, for your frankly septic patients. So how do we assess severity in acute and chronic liver failure? So according to the Asia Pacific Association, they have got an ARC scoring system. So no need to memorize, just we need the total bilirubin, hepatic encephalopathy, INR, lactate and creatinine. Now these are all parameters that we have every day in our hands in our daily ICU rounds. We have total bilirubin, we can clinically assess HE, INR, we can find out creatinine, we can find out, and if you have an ABG machine which gives us lactate values, then we can do this scoring system every day for ACLF patients. The NACL organ failure we had already discussed. The most important is the CLIF-C organ failure. So what are the organs? They take into consideration liver, they take into consideration coagulation, neurology, hepatic encephalopathy, circulation by mean arterial pressure, renal by creatinine, and respiratory by PaO2 by SpO2 by FiO2 ratio. So according to each of these values, so there are certain points, we can add the individual scores to find out the CLIF-C organ failure score, and the CLIF-C ACLF score is found out by using this organ failure score here and the other parameters like age and WBC count. And the final Cliff C ACLF score will range from 0 to 100. So, can we move on? Yeah. So, to summarize, let us just do what our teachers used to do in school. So, what are the 6 organ failures? Start from brain. So, we have got brain, number 1. What comes after brain? The heart. So, it's a circulatory system. What is next to the heart? The lungs, the respiratory system. What is beneath the lungs? It's the liver, the 4th. What comes beneath the liver? The kidneys, the renal system. And the other thing that we must remember is the INR or the coagulation, because it is all over the body. So the 6 organ systems, just remember every day in our clinical practice, it is very easy to do. And you can take a picture of this QR code. It will link you directly to the efcliff.com, where you can find out, we can put in the parameters as we shall see here. So I took the screenshots, I put a dummy patient data here. So this is what the website looks like. Suppose you put in bilirubin of 15, creatinine of 2.5, encephalopathy of grade 3, INR of 2.1, mean arterial pressure of 66, PO2 by FiO2 ratio, we can put it here. And you can see that at the same time, they will give the liver failure, organ failure score. So liver score is 3, kidney score is 3. They will say that whether liver failure has occurred. The algorithm will automatically give you that liver failure, yes, liver failure is yes. Kidney failure is there. Coagulation failure, no, there is no coagulation failure. Circulatory failure, no, because MAP was 66. So this is not a circulatory failure. So this website will give you the entire data, and they will give you the total number of organ failures. For example, it is 3 here. What is the Cliff C organ failure score? They will give us. What is the grade of ACLF? We can find out. What is the severity of ACLF? And if we put in the age and WBC, we will find out what is the Cliff C ACLF score, which ranges from 0 to 100. And more importantly, it will match it against the normogram and tell you what is the chances of mortality in this patient arm. So if we put in the data of our alcoholic patient, as we saw in the beginning, so what will happen is we will get a sort of idea that how the patient is likely to progress or behave, and we can take measures like that, and we can prognosticate the patient and the patient's relatives. So this is a very useful tool in our day-to-day management. Coming to the principles of management, I will not go very deep. So first of all, so you can understand that ACLF has got 2 premises. One is the underlying chronic disease, which was already there. It might have been clinical or subclinical, overt or covert chronic liver disease. But then along comes an acute insult or acute hepatitis. It can be because of alcohol, it can be because of hepatitis B, it can be because of hepatitis A, it can be because of sepsis itself, it can be because of activation or flare of autoimmune hepatitis, it can be because of flare of Wilson's disease. So whatever be it, whatever be the cause, the acute insult comes and destroys the equilibrium of the already cirrhotic liver. So we need to treat the acute causes. We need to stop alcohol. If there is evidence of alcoholic hepatitis, we can give corticosteroids, but very carefully, because as I said, this is like a sepsis condition. So we do not give corticosteroids in sepsis very lightly. So we have to make sure that the patient is sterile, the patient is culture negative. Only then we can give corticosteroids. If there is hepatitis B, we can give tenofovir. If there is infection, antibiotics, and if the ACLF was precipitated by variceal hemorrhage, we should do endotherapy like banding and give vasopressors. So the principles of management of the chronic phase of acute and chronic liver failure, you can't do much about the liver, right? Because the liver is already damaged. But what you can do is you can target the individual organ systems, and this, ladies and gentlemen, is the cornerstone of management of ACLF. You do not see the patient as a whole. You do not see the INR simply the INR. You do not simply see you see the patient as a collection of organ failures. You write in your notes what are the organ failures, and then you write your plan of management according to each organ failure. So what to do for coagulation? So we should do CBC, P-time INR daily. We don't have thromboelastogram or rotating thromboelastometry in our clinical setting in Bardhaman, but probably someday we will be having in some ICUs. So the issue is that do not over-transfuse. Do not try to correct the INR. there is absolutely no role in giving vitamin K because the liver is already damaged. If you give vitamin K, the liver is
Only
not...
2 minutes, please.
Yes, sir. The liver is not going to synthesize the vitamin K dependent coagulation factors. So do not give vitamin K injections, either IV or IM. IM injections are likely to cause hematomas. IV injections are not going to be of any help. So you can give platelet transfusions only if you are planning some invasive procedures like some percutaneous drain or some interjugular venous line placement. And if the patient does not have severe coagulopathy, we can always give low molecular weight heparin so that the patient gets prophylaxis from venous thromboembolism. And if the patient is planned for a procedure without bleeding, do not give FFP also, because FFP has got a lot of infectious complications, immunological complications, which will tip the balance and make this patient worse only. For kidneys, we should assess the AKI as per the KDIGO criteria. If the AKI is stage 2 or 3, we should add 20% albumin. If there is type 1 HRS, we can add albumin as well as terlipressin and norepinephrine. And do not give NSAIDs, and we should also avoid unnecessary dialysis or early initiation of dialysis. So regarding the lungs, ABG should be done every day in these patients. Every day ABG should be done. Chest X-ray at the beginning, after interval of few days, maybe an HRCT will be helpful. So what we need to help the lungs with is with oxygen inhalation and lung protective ventilation strategy. I don't think in the post-COVID world we need any further elaboration on how to manage a patient of ARDS. So that is the principles of management of ARDS which will apply here also. The important thing is early intubation. If the patient is showing signs of respiratory failure, intubate early. If the patient has got hepatic encephalopathy grade 3 or 4, intubate early, because in encephalopathy we do early intervention for airway protection. For circulation, we should assess the hemodynamics at admission. The goal should be to maintain a mean arterial pressure more than 65. Echocardiography should be done to assess the IVC status. Norepinephrine is the first choice of vasopressors. If there is need for resuscitation, we can give crystalloids like ringer lactate, like normal saline, as well as 5% albumin. And if the patient has got spontaneous bacterial peritonitis in his ascitic fluid, then we should do a large volume paracentesis, remove as much of the infected ascitic fluid as possible, and give 20% albumin. And with regards to the fluid, we should always avoid using starch preparations like Hestar or Hetastar, and limit the sodium infusion in patients with ascites or anasarca. For the brain, we should evaluate mental status regularly, protect the airways, identify the precipitant, treat the precipitant, oral lactulose, even lactulose enema, like we do in patients of hepatic encephalopathy. Do not give deep sedatives or use benzodiazepines. Albumin administration in these patients has been shown to have a fairly short-term benefit, but long-term benefit of mortality has not been seen. There are other devices like the extracorporeal liver support devices, basically sort of liver dialysis, like what we do in renal replacement therapy. So there are extracorporeal liver support devices. Their names are Prometheus. So you see the blood is coming out just like in your kidneys. So what they do is there are a lot of filters and adsorbents. They take out the toxins and the lipopolysaccharides and the PAMs and DAMs, and then return the filtered blood. And this is something called ELAD device. Something called DiaLive is something which has come very recently. So DiaLive studies have shown that they have decreased the level of endotoxin, IL-6, TLR4 ligand, CLIF-C, ACLF score. But these benefits have proven to be cosmetic at best, because ultimately there is no clear answer whether these use of these costly devices will ultimately aid in survival. So the answer is not yet out. With regards to liver transplant, there is currently no consensus and what should be the optimal timing of the liver transplant. Even transplant surgeons are not very sure themselves. They're a divided house on this. There is some evidence that within 30 days, if you do a transplant in these acute and chronic liver patients, they will have a better outcome. But it is very difficult in our clinical practice to convince a patient that your patient has got jaundice and ascites and he's going to die, has got 80% chance of death in the next 6 months. So people won't believe that. They are very resistant to be referred for liver transplant. And predictors of poor post-transplant survival include comorbidities, uncontrolled sepsis, MDR organisms, fungal infection, respiratory failure, need for dual inotropes, and high lactate levels. And there has been talk that if your patient has got a CLIF-C ACLF score of more than 70, please do not send him for transplant at all, because such a sick, infected patient undergoing transplant is probably not going to survive the rigors of transplant or the onslaught of immunosuppression subsequently. So to summarize, ACLF is a distinct clinical entity. It has got a worse outcome than our normal run-of-the-mill cirrhotic patients. So if I put in a summary table to sum up today's discussions, DCLD is more about structural damage, ACLF is more about inflammation. The onset and progression of DCLD is gradual, or in ACLF it is abrupt. There are hardly any triggering events in decompensated chronic liver disease. There are triggering events in ACLF. The CVS and CNS events are higher in DCLD but lower in ACLF. And the prognosis depends in decompensated cirrhosis on portal hypertension complications and whether HCC has developed, whereas the prognosis in ACLF solely depends not on HCC, not on portal hypertension, but on the presence of organ failures. And following from that only, in decompensated cirrhotics, the treatment focus is on portal hypertension and the etiology of cirrhosis, whereas in ACLF, we should give organ support and maybe extracorporeal liver disease in the future. So ACLF does have worse outcomes, early recognition, and organ supportive therapies still remain the cornerstone of ACLF management. Thank you for being such a wonderful audience.
Thank you, Dr. Vishnu, for your nice deliberation. Only one or two questions can be asked. If there is, if somebody has any question.
PPIs are safe, sir. PPIs are safe.
Sarcopenia is one of the predictors for the outcome. So how is going to support this to prevent sarcopenia?
So sarcopenia, the first step you have to take for the ICU patient is to give him a lot of calories and proteins. Now, we were traditionally taught that if you give more protein, you are going to generate more ammonia and that is going to worsen the encephalopathy, but it is wrong. What happens if you do not give protein, the body will break down the muscles itself to gain that amount of calories by breakdown of proteins. So that will generate the ammonia, not the protein that you intake. So if the patient is weighing about 60 kilogram, the target is to give a protein of about 1.5 gram per kg per day. So the patient should take 90 grams of protein per day. And here what we make a mistake is we think that the protein is going to go through only the formulations, the various tins. But if you look into the composition of the tins, if we want to give 90 grams, almost 3/4 of the tin will go in a single day. No patient will be able to take it every day. It will cause a lot of bloating and it will cause a lot of osmotic diarrhea. Your patient is going to be fed up with you, you are going to be fed up with treating diarrhea, whereas it is only a osmotic diarrhea. If you put in so much of high concentrated feeds, it is going to cause a lot of diarrhea. So you have to give a lot of other proteins like egg whites, like chicken, like fish. So this is one. Number two is if you ask for dietary supplements, only N-acetyl carnitine in very high doses, about 1000 milligram to 1500 milligram, has shown some role in improvement of sarcopenia. Other than that, it is recommended for cirrhotic patients that those patients who are ambulatory, who do not have a huge ascites, it is recommended that they undertake at least 30 minutes of supervised exercise every day. Initially supervised, later on they can do it by themselves. So the target should be to improve their core strength, core muscle strength, like squats and planks they won't be able to do, but at least squats they can do. Other than that, balance exercises like holding a chair and just raising a leg to one side. So these are small exercises that we can teach our cirrhotic patients. If they do it, their muscle strength, their joint kinesthesiology, and their balance sense will be better. So they will have, if they will keep on using the muscles, they won't have disuse atrophy, and ultimately they will have prevention of fall and trauma.
Any more question from audience?
প্রোটিন দিতে পারি, কারণ প্রোটিন নর্মাল প্রোটিন হলো নর্মাল প্রোটিন 0.82 পার কেজি পার ডে। আমি কিডনি ফেলিওর থাকে তো ফার্দার কিডনি ফেলিওর হবে, তবে যদি হাই প্রোটিন দিই, কারণ লিডস টু ক্রিয়েটিন ইন হাই, দ্যাট লিডস টু।
So number one, in acute liver failure, both the liver and the kidney is fine.
তাহলে দেওয়া যাবে।
But even in, suppose in a diabetic patient who has got diabetic kidney disease as well as cirrhotic, I always push for more proteins, because as I see it, the protein is not damaging the glomerulus, right? Is the glomerulus is already damaged, so the proteins are leaking out. So I don't think nephrologists will also have any problem if I give higher amount of protein, because it is not the protein or the albumin per se which is damaging the glomerulus.
Okay, thank you. Please come to Felicity.
Thank you, sir. Thank you for the nice presentation. Now I would request Dr. A.K. Mukherjee, sir, for the felicitating episode. Please come on this second stage, requesting doctors. For the second stage, sir. Please. Thank you so much for the nice presentation. A big round of applause for that. And for the next session, I am requesting our chairperson, Dr. Soumitra Konar, and Dr. Sujan Sarkar, sir, to take the chair for the next session of the day. And the session is Role of Nebulized ICS LABA-LAMA in COPD Management. Requesting Dr. Soumitra Konar, sir, and Dr. Sujan Sarkar, sir, to take the chair, and announcing our speaker name for the next topic. Thank you.
Good morning. Our next session is on the role of nebulized ICS LABA-LAMA in COPD management. And the speaker is none other than Dr. Rupamta, who needs no introduction here. He is a son of the soil, and he is a Dean of Student Affairs at Purulia Medical College. I think we will get mighty educated by his deliberation. Dr. Ta.
Thank you, sir.
Respected chairpersons and dear colleagues, and today's topic is the home maintenance nebulization in COPD, role of long-acting beta-2 agonist, inhalation steroid, and LAMA, long-acting muscarinic antagonist. So this is a little bit of story, because we have heard many things about the liver as well as diabetes. It is a little bit of one story. Few months ago, I visited the two universities, one of the oldest universities, Oxford and Cambridge. Then we discussed, it is the important living university in the world who are working more than 1,000 years. So after discussion among us, among my family members, so immediately one Japanese tourist came. No, you are from India? Yes, we are from India. তখন বলছে যে এটা সবথেকে পুরনো ইউনিভার্সিটি নয়। পুরনো ইউনিভার্সিটি তুমি কি নালন্দা গেছো কোনোদিন? আমি বললাম না, নালন্দা, I didn't visit the Nalanda. বলছে Nalanda is the oldest university in the world, and though it is not active now, but somewhere it is renovated. But story behind it, why ধানভান্তে শিবের গীত, এখন কেন আমি এই কথাটাকে এখানে নিয়ে এলাম পার্টিকুলারলি, কারণ উনি যা বললেন গল্পটা, তারপরে আমি মিলিয়ে দেখলাম, ফ্যাক্ট চেক করে দেখলাম উনি অ্যাবসলিউটলি রাইট। কেন কি যে বলছে এটা your university is 2,500 years ago's university, And this Nalanda University, there is a hub of education of Buddhist literature, art, culture, astrology, everything. Even if in medical science also it is used to taught. That is one of the oldest university. How it was destroyed? At the point of time, more than 2,500 years ago, more than 3,000 years ago, that was this university was established by the Guptas and Gupta emperor. Then it came to the Buddhist monarchy, and at the time of Bakhtiar Khilji, Muhammad Bakhtiar Khilji, who destroyed? Anybody have any idea how it was destroyed? It was destroyed by burning. How? Why he destroyed? Generally, সেনাপতিরা কি করে? যুদ্ধের সময় কি করে? বখতিয়ার খলজি ছিল কুতুবউদ্দিন আইবকের সেনাপতি. Why he destroyed the university where there is a teaching hub of learning? Why? Because he was very sick. The Bakhtiar Khalji was very sick once upon a time. His disciple called many Boiddos, Hakims, everyone he called, but he didn't cure. Then his condition was deteriorated slowly. Then his disciples gave the idea to call Rahul Silbhadro, who was the principal of this university at that time. So Rahul Silbhadro, they asked Rahul Silbhadro, after seeing the Rahul Silbhadro, this Gerua Bashan, he told that his disciple, I will not take any medicine from him. So then without medicine, how will you treat these sorts of old and these sick people? So what he has some idea. He asks the holy book of Quran. He asks the holy book of Quran, and he does something with that Quran, and he has advised, you stop all your bad habits and read Quran, these 8 pages 8 times a day. After that, slowly the Bakhtiar Khilji was recovered. And after getting this recovery, he got some idea that how this man, our Hakim, amar Boiddo jeta jani na, amar Hakim jeta jani na, ei lokta kotha theke idea ta pelo to save the life. So he might have how to destroy. He has a magic chemical to destroy the world also. So he got the idea, and he found that the 3 libraries in the university, 3 libraries in the university are the source of male knowledge. Immediately he thought that if they are having, definitely they are having some chemical, so they can destroy our total samrajyo. So he immediately ordered their people to destroy, burn the 3 libraries, and it took 90 days and destroy the 9 lakh books in these 3 libraries. How the Nalanda, what he has given, what the magic has given by the Rahul Silbhadro. The magic was nothing that he stopped the smoking and his all bad habits. And he most likely, he pasted some dhatura stramonium chemical over these 3 pages of the Quran, and after inhaling that one, so he cured. Most likely, this is the theory they put forward. So you know that Samrajyobadira Sona Sampod loot kore, kintu ekta destruction of a university, which is a very important thing. So by how this has happened, I think many of you know the story. One case study after that. The 68 years male presented in the emergency department with the severe shortness of breath and productive cough and with greenish cough and chest pain. Is a known case of COPD for 8 years, smoker, 40 pack year, as a diabetes and hypertensive. Such a straightforward case of acute exacerbation of COPD. His reports are, is a high blood pressure, temperature high, heart rate, tachycardic and tachypneic, saturation low, and excess shows hyperinflation, and WBC is 18,500, CRP was quite high, and neutrophil is quite high at that time. CT also shows there is hyperinflation, and old excess shows also hyperinflation as well as tubular heart. ABG shows high carbon dioxide and low oxygen, that is type 2 failure. The straightforward diagnosis is the acute exacerbation of COPD, managed with oxygen, antibiotics, nebulization of the short-acting drugs, that is levosalbutamol and ipratropium, along with the other medications. And after sometimes 5 to 7 days, you are supposed to discharge. What type of medication you have to discharge? What are the criteria to discharge a COPD patient? When the patient is conscious, alert, hand and mouth coordination should be good, and he can able to walk and do his normal daily activity, you are supposed to discharge these patients. But what we have seen, the peak inspiratory flow rate, though we are discharged, all these criteria fulfill, peak inspiratory flow rate by which they will inhale, that is very, very low. Breath holding capacity is not suboptimal all the times. And comorbidity is also very important to deal with the COPD cases. So 1 out of 5 patients which we are discharging among the discharge criteria of COPD, they remain readmitted in the hospital in the month out of 20-25%, and around 50% also readmitted within 90 days. Because of the various factors of the patient-related factors, patient characteristic, male patient, prior hospitalization, prior performance status poor, and lot of comorbidities, patient's investigation, low FEV1, and high eosinophil count, and long hospital stay, ventilator, steroid, antibiotics, that can, long-term oxygen use, that can lead to the readmission of these sorts of patient of whenever we are sending the patient from hospital to home. So hospital to home, the exacerbation rate is quite high, where there is a chance of readmission and mortality in around 13.4% in COPD experience in the readmission and in 90 days, compared to those who are giving the adequate therapy to reduce the hospitalization and reduce the mortality. So normally what happened, actually this is the trajectory of the COPD: admission, exacerbation, admission, 2-3 readmission, followed by sharp decline of lung function and death. So you are, whenever the patient admitted in the ICU or in the ward for exacerbation, you are supposed to reduce the chance of readmission and re-exacerbation by anyhow means. So that way you can save the life. So prevalence of low inspiratory flow rate, whenever you are discharging the patient, have a low inspiratory flow rate to take the inhalers. So because at that point of time, you should not think the inhaler, you give home oxygen therapy, home nebulization therapy to decongest the patient and to save the patient for readmission. Need to transition of care. We used to say transition from the hospital, one environment, and to home, there is environment. Transition is in the COPD patients is if it is a good recovery, then chance of readmission will be reduced and mortality will be reduced. Nebulization therapy is very, very important. Some studies are there. We'll show you. Transition is very important with the home nebulization. Across the hand and mouth coordination, as well as actuation, inhalation, and the inspiratory flow rate, nebulizer will act all this. Whenever patient recover, then we can switch over to the inhaler with spacer or DPI if there is inspiratory flow rate is more than 60. 40 to 55, you can give the inhaler with spacer. Other than that, you have to go for the nebulization. So factors that influencing the prescription regarding the what type of medication, device related, disease related, drug related, and patient related. They are the four things are there to factor that whenever we are giving the medication for this patient during the discharge. What type of inhalers we are having? We are having specialized meta-dose inhaler with large volume and or breath actuated, dry powder inhaler, multi-dose, single dose, nebulizer. 3 types of nebulizer we have. One is jet nebulizer, which generally we are using. Another one is the ultrasonic nebulizer, and which is not available, that is the vibrating mesh nebulizer. Other than that, without propellant is the soft mist. They are also using for these low inspiratory flow rate cases. So drugs, after device drugs, the short-acting drugs, salbutamol, levosalbutamol, and short-acting muscarinic antagonist is the ipratropium bromide, long-acting beta-2 agonist LAMA this one is the formoterol and R-formoterol, steroids, budesonide, fluticasone, combination of the sabasama, that is the salbutamol, levosalbutamol with ipratropium. ICS is the budesonide with the formoterol, and mucolytics, ambroxol, N-acetylcysteine, as well as inhalation of the antibiotic, which is not really used for the not the home, but it can be used in the ICU itself with the adjunct with the antibiotic tobramycin and cholesterol. So guideline, in our guideline, the gold guideline, they have also given the drugs which can be nebulized. Even if lot of drugs are come, because of easy to deliver the drug to the respiratory tract. So that the comparison of the various three, this one jet nebulizer with formulation. Our nebulizer formulations are, they are the suspension as well as solution. Solution can be given to all the nebulizer, but suspension, mainly the steroids, who are all suspension, should be given with along with the jet nebulizer. Jet nebulizer is preferred. Is the schematic diagram of the jet nebulizer. Jet could be the compressed air, could be oxygen, but very important to COPD patient, don't give oxygen much. This is the ultrasonic nebulizer, this is the mesh nebulizer. So drugs which I mentioned, that salbutamol, levosalbutamol, sabasama combination, lava-lama R-formoterol and glycopyridinium, as well as ICS lava, formoterol budesonide, and the mucolytics N-acetylcysteines. Because in the COPD patient, they are having bronchoconstriction, there is a muscle contraction. So reduce the bronchoconstriction, mucor hypersecretion, and remodeling of the airway. We require give good dose of bronchodilator. Sometimes inhaler can give the 200 to 500 microgram, but nebulizer can give the 1 milligram up to 1 to 1.2 milligram of the drug to be delivered in the respiratory tract. So there are the studies of the nebulized LABA in acute exacerbation and the home as well as hospitalized patient. They are safe mostly. They are cardiac toxicity of the long-term formoterol compared with the DPI. They are also safe. Efficacy of the nebulized, they are also highly efficacious to improve the FEV1 and TDI, transitional dyspnea index, as well as other the recommended long-term use of the nebulized budesonide compared to the inhaler. They are also recommended quite safe, no cortisol suppression much. Inhaled anticholinergics are very useful for the COPD patient because they are having high cholinergic tone. Anticholinergic drugs, glycopyrrolate, which are available with us, M3 muscarinic receptor antagonist, and it is not available in the combination. It is separately, glycopyridinium is available in the nebulized form. So advantage of the nebulization. Advantage of the nebulization is the high dose can be given. There is no need of hand and mouth coordination. If the respiratory muscle also weak, they will act. But disadvantages are quite high. Possible toxicity caused by the higher dose. Oral deposition cause mouth ulcer as well as oral candidiasis. These vocal changes and hoarseness of voice. Transmission of the airborne infection. Nebulized typically require longer time than inhaler will take hardly 1 to 2 seconds. But nebulizer required at least 10 to 15 minutes and require regular maintenance, and power backup require, and maintenance also require cleaning of the. This is a solution as well as suspension, both are available. So clinical scenario where the maintenance therapy of the nebulizer is preferred, and whenever the patient recovered and hand and mouth coordination, good eyesight, and where there is a mental status improvement, immediately switch over to the MDI, metadose inhaler with spacer. The patient who are having the low flow rate, those who are having the cognitive impairment, visual acuity low, muscle weakness, and the patient is unwilling to take the MDI, they are habituated, poor hand and coordination, and patient is the breath holding is less than 5 to 10 seconds, they can prescribe this. Importance cleaning by the boiling water, you can clean the solution with 5 minutes, and you can soak over the 70% isopropyl alcohol for 5 minutes. They can be immersed 3% hydrogen peroxide. So how score to nebulize, which patient should be nebulized? If the score is there, scoring system, if the score is less than 15, you are supposed to use the nebulizer. And if the score is more than 20, if the score is more than 20, you are definitely has to use the nebulizer. Less than 50, you can go with the inhaler with spacer, and 50 to 20 patient and physician judgment. So case description. The case which we have discussed, there is an old 58 years old male smoker with a diabetic hypertensive, and who came with the diagnosis is group E gold. We are having three classification, A, B and E. E means exacerbated. Those are prone to exacerbation, prone to hospitalization. And gold grade 3 because of FEV1 is around 50 to 30 to 50, and diabetes. And quit smoking, which is a very important maneuver which we can reduce the decline of lung function. And diabetic diet, nebulized with formoterol budesonide 2 times a day until he recovered, and then switch over to the MDI with spacer, nebulize with the glycopyrronium 2 times a day, then switch over to the MDI with spacer, SOS nebulization, Savasama combination, vaccination. Now the vaccination of this adult vaccination is published by Government of India. Mainly the 2-3 vaccines are very, very important. One is the influenza vaccine yearly, then the pneumonia vaccine 2, one is conjugate vaccine followed by this polysaccharide vaccine. Then we can go for the herpes vaccine, hepatitis vaccine, then go for the other vaccines, and continue the RX for hypertension and diabetes. So take home message is that inhalation device is all are mostly equal. The drug deposition is equal, but you have to patient, you have to depend upon that. And selection of the appropriate inhaler device should be individualized and patient specific. Patient maintenance of the nebulization, we have to check regularly whether they are maintaining or not. Strict follow-up and cleaning. All the patients should be, whenever they recover, so handheld inhalers like DPI or MDI can be converted from this nebulization solution. So terrorists destroyed our twin lungs 2 to 3 hours violently. Smoking destroyed your twin lungs silently in 2 to 3 decades. Pursue your next patient to stop smoking to develop COPD. Thank you very much for your kind attention.
Thank you, sir, for your wonderful presentation. Sir, one question is there.
Yes.
Sir, if we, when acute exacerbation of COPD patient is admitted, after discharge, we very often advised about the low dose oxygenation in the home oxygenation. What is the guideline? What is the what duration the patient can use the oxygenation?
Oxygenation is very, very important, but no oxidized much more. So this nowadays the pulse oximeter is available around 500 to 1000 rupees. So ask the patient to purchase the one pulse oximeter during the discharge and see what is his saturation. Whenever the saturation is around 90 to 92%, up to that you can give the home oxygen with the cylinder oxygen, or you can give the our oxygen concentrator which are available. So 90 to 92 is the target to give the COPD patient when they are going to discharge. Don't give the oxygen high, because these sorts of patients used to live with the hypoxic drive, because they are having the high carbon dioxide. We are having 2 drive. One is hypoxic drive, another one is the hypercarbic drive, because they lost the hypercarbic drive. They are on with that hypoxic drive. If you give high oxygen, hypoxic drive will be lost. The patient will develop the drowsiness and the patient may die. So give oxygen judiciously. Oxygen is a drug. It has a dose. Don't write oxygen forever. Oxygen 1 liter per minute, 60 to 8 hours, which time of day you feel that his oxygen is come down. There is a guideline for the home oxygen therapy, but basic guideline is if the patient is conscious, able to walk, then you can stop the oxygen. Otherwise, go for a pulse oximeter. Your target saturation is up to 92. Don't go beyond 92.
Thank you, sir.
Hello, Professor Ta. Actually, I don't really question. I want you to talk about a few words about nebulized antibiotic and the scope of vaccination in COPD. These two matters are very important, I think.
Yes, yes.
In the ICU setup, we very commonly come across hypokalemia. In that situation, which nebulization you will suggest?
3 questions. তো তারকদারটাই প্রথম শ্রেণী, কারণ আমার কাছে এলডিটা রয়েছে। এখানে লো ডোজ একটা নেবুলাইজ পাওয়া যায়, লো ডোজ বোথ, যা সাবা লো ডোজ, সামা লো ডোজ। So here the low dose, when there is a chance of hypokalemia, hyponatremia, because nebulization can cause the, mainly salbutamol can cause the lower the sodium as well as potassium, mainly the potassium level. So low dose available. Whenever you require, give the low dose salbutamol and ipratropium bromide. Low dose available also in the Foracort also, formoterol also low dose are available. This require LABA or SABA SAMA require 3 to 4 times a day. LABA LAMA require only 2 times a day. So whenever possible, go for the LAMA LABA higher efficacious drug, so there will be chance of hypokalemia will be reduced. And go for the low dose solution. Low dose solution we have, so you can give the low dose solution to reduce the hypokalemia. If that is also not creating the problem of the hypokalemia, then go for the inhaler with metadose inhaler. Dry powder doesn't much cause this hypokalemia and hyponatremia. So low dose is available with us, so you can use the low dose of the solutions. LD, write down the Duolin LD, write down the Foracort low dose, so that will be available in the market, so reduce the chance of dyselectrolemia in the sorts of patient. Next question is the nebulized antibiotic. আর কিছু বলবো? Levosalbutamol is better than that of, it is an isomer, basically isomer of salbutamol. So levosalbutamol in that respect of side effect of the beta-2 agonist, heart rate, tachycardia, ulceration, levosalbutamol is less. Less means less than 50% chance. So levosalbutamol will be better than that of salbutamol. Even if low dose, also good. So next question is the vaccination. We have that Government of India published the adult vaccination like pediatric vaccination. Yearly, keep in mind, any diabetic patient, hypertensive patient, more than 65 years, so give yearly available influenza vaccine. Yearly available vaccine. Our in Bardhaman, it is the timing of the vaccination is very important. Which type of influenza is more common? Our vaccination time is around that May, June, July, August, up to September. Don't go beyond that, because vaccine will take time to produce the antibody. So in our place. And next is the vaccine of pneumonia vaccine. Pneumonia, we have 2 vaccines. If before the age of 65, below the age of 65, patient has to take the 2 vaccines. One is conjugate vaccine, 13 conjugate, I mean, naam bolbo na drugtar, available ektai ache, Pemnar 13. And another one is this polysaccharide vaccine, which is 23, that is polysaccharide vaccine, give after 2 months to 1 year, within 1 year. So antigenicity will be very high. Then herpes vaccine, herpes zoster vaccine. Then give the Haemophilus influenzae vaccine. These are all yearly vaccine. And adult pertussis vaccine. Amra bhule gechilam pertussis er kotha. Pertussis kintu cause exacerbation. And nowadays available adult BCG vaccine. So prevent the tuberculosis also. I will come to the next topic in the evening. There will be adult BCG vaccine has again rollover in India. So these are the vaccination. Other vaccinations are also there. Respiratory syncytial virus is rolling, but it is not in the guideline till date. Haemophilus influenzae, up to that it has come. Coming, definitely. This pediatric, it is available. But adult pertussis vaccine, and একটা ডোজ, সিঙ্গেল ডোজ, কিন্তু হারপিসের কিন্তু 2টো ডোজ, একটু কস্টলি আছে, হারপিসের 2টো ডোজ। ঠিক আছে। থার্ড কোশ্চেন ইজ দ্য নেবুলাইজ অ্যান্টিবায়োটিক্স. We have tried many a times to deliver the drugs. Even if one nebulized anti-TB drug is also now government is going to purchase nebulized anti-TB drugs. So nebulization is such a preferred way to deliver the drug. That the 3 or 4 drugs we are having. That is the tobramycin, colistin, and the amikacin sometimes we can nebulize. and levofloxacin, also nebulized, also there. So there, but you have to give it along with the injectable form. Injection along with the nebulized tobramycin, nebulized colistin, these drugs are there. Their guideline, till date there is no much guideline, it is not there. How long you have to give? You have to give the, in ICU setup, you have to give the intratracheal instillation, or in through the bronchoscopy, or to the nebulized through the tube from the ICU port, this ventilator port. You can give these 3 drugs mostly in that. I used to give the multiple antibiotic we used to give at a time. So very difficult to say that really these drugs are working or not, because patient used to improve with the giving the nebulized antibiotic, tobramycin, colistin, amikacin. But the role, some patient used to recover, but some patient also deteriorate. But till date, it is not well settled that singly we can give the drug to the intratracheal instillation and patient will recover without IV. Till date, it is a conjugate along with the this one IV or oral antibiotics. So any question? Yes. Oh, ha, tomar.
আমি নেবুলাইজেশন করলাম, রেসপন্স করলো না। তো আমরা আগে যখন আমি আরএমও হসপিটাল ছিলাম তখন আইভি হাইড্রোকোডিশন দিতাম, Can you allow this hydrocortisone?
Yes, in exacerbation, when the patient is having exacerbation, we can give the short course of antibiotic. 0.5 to 1 milligram per kg body weight, prednisolone can be given for 8 days. Even if 5 days will be suffice, it will not produce any this cortisol axis change. So this till it is there for the exacerbation and which require hospitalization. Definitely it is there. Even if not written in the book, the theophylline also sometimes can be given that save the lives. So steroid can be useful for the exacerbation, not routinely used. We are giving the inhalation steroid, ICS we are giving. So no need to give the IV. So only for exacerbation, when the patient is ventilated, then you can give that one.
In COPD, how long we use PPI?
PPI?
But on a reflux gastritis
is mostly more common in case of asthma. Asthma is good related with the gastritis as well as GERD. But in case of COPD, we can give the one PPI, or if you give the antibiotics, lot of antibiotics, you can give the suspension also. But how long, it is not there. It is not there. But in case of interstitial lung disease, which is very important, is that always give the PPI, because basal pneumonitis is very common with this drug.
Thank you.
So, PPI. SPX suppression.
Suppression, যেটা দেখা গেছে যে আমরা স্টেরয়েড যদি 2 to 3 weeks judiciously টানা ইউজ করি, then less chance of this HPXs. 7-8 দিন is quite good, but if needed, you can extend up to 2 weeks.
Up to 2 weeks, you can extend. But guideline says that up to 8 days is sufficient. No need to go for the 2 weeks. Guideline says, guideline and studies showing that there is no much extra improvement, extra beneficial effect up to 2 weeks. So 8 days is sufficient, even if they are coming with the 5 days.
Okay, thank you, sir.
Thank you very much.
Thank you, sir, for the nice presentations. And now this is time for giving the small token of respect and love. For that, I would request Dr. T.N. Banerjee, sir, to felicitating our speaker and our chairperson. Very nice presentation and learning session we have just gone through. Now our next session is Finerenone for the spectrum of patients with CKD and type 2 diabetes mellitus. Sorry, extremely sorry. Next session is management of MSLD in 2025. For that, I am requesting chairperson to take the chair, Dr. Shubhamoy Chatterjee, sir, and Dr. T.N. Banerjee, sir. Our next session is Management of MSLD in 2025. For that, I am requesting our chairperson, Dr. Shubhamoy Chatterjee sir and Dr. T.N. Banerjee sir to chair the sessions. Thank you.
So, our next session is Management of MASLD in 2025. Speaker is well known to us and he is very dear to our heart also. He is Dr. Amartya Shankar Chaudhary from Durgapur, a consultant endocrinologist from Mission Hospital, Durgapur. Thank you, Amartya, for coming.
Thank you so much. It's always a pleasure to come here because of the warm hospitality. Special thanks to the organizer, T.N. Banerjee sir, Shubhamoy sir, Joyantada, Dr. D.K. Gupta. So this is the first talk. I think I have 2 talks today. The management of MSLD in 2025. So we have been dealing with NFLD, MSLD for quite some time, quite well versed with the complications and the problem with MSLD. But again, new guidelines keep on changing. There are new updates every year which get on added. So I'll be highlighting those changes which have come probably in the 1 year or so. The new drugs have been approved for the treatment of MASH or MSLD. Now, it's definitely an elephant in the room. We have very low awareness regarding lifestyle diseases like diabetes and hypertension, and so also goes for MSLD. Public awareness is very low. Only 5% of patients with suspected NFLD are aware having the disease, and the prevalence goes on increasing. Something which is very concerning is that the Indian prevalence is higher than the world prevalence. 1 in 3 Indians are affected. More so, we are seeing higher rise in cases of MSLD or NFLD in children, especially children with obesity. Now, this is the entire spectrum of NFLD or MSLD. NFLD basically is an umbrella term. It was replaced by MSLD. I'll be coming to it in the later slides. So, from a normal liver, first is the steatotic liver disease or a fatty liver, which is usually identified by most of the imaging. And then it gradually progresses to steatohepatitis, various stages of fibrosis, and ultimately leading to cirrhosis. So, it is at this stage, the steatohepatitis or fibrosis, where we want to intervene so that we can prevent the progression of the liver disease and the patient do not become cirrhotic. Now, this is the latest nomenclature. This is already there for last 1 year. Basically, the stigma associated with the word fatty and non-alcoholic led to the meeting, the panel discussion, where the terminology was changed from NFLD to MSLD or metabolic dysfunction associated steatotic liver disease. So what does it include? Basically, there should be a presence of more than 5% of fat, that is a steatotic liver disease, along with a presence of a cardiometabolic risk factor, which are nothing but the components of the metabolic syndrome, elevated triglycerides of more than 150, low HDL defined as less than 39 in males or less than 150 in females, type 2 diabetes or prediabetes, obesity or overweight, and a high blood pressure of more than 130/85. Now, all fatty liver disease may not have metabolic component, and we need to rule out other causes. Now, if the patient is drinking alcohol, the patient has a cardiometabolic risk factor, and if it is a female taking more than 20 to 50 grams of alcohol per day, a male taking more than 30 to 60 grams of alcohol per day, then we designate this as MET-ALD, it's not MSLD. Now, if the patient is a heavy drinker taking more than 50 grams of alcohol for female and more than 60 grams of alcohol daily for male, then it is an alcoholic liver disease. If neither of these components are there, patient is not alcoholic, no metabolic syndrome, then we have to look out for other causes. It can be a cryptogenic steatotic liver disease or a drug-induced liver disease, and other causes like hepatitis C virus infection, rarer causes like hypobetaproteinemia, Wilson's disease, celiac disease, and even some endocrine diseases like hypothyroidism, hypopituitarism, there may be such steatotic liver disease. Briefly about the pathogenesis, because we have to understand the pathogenesis to understand the pharmacotherapy. Now, we have excess of fat in the body, patient is obese, patient is insulin resistant, and just hit a cascode, yeah, sorry. So patient is insulin resistance. So there is increased fatty acid flux to the liver. Excess of free fatty acids along with de novo lipogenesis increases the free fatty acid pool in the liver. Now these free fatty acids have two normal pathways rather. One is to undergo the beta oxidation, which provides the energy, or else it can be esterified into triglycerides and stored. And when these two pathways are overwhelmed, rest of the free fatty acids are converted into lipotoxic fatty acids, increasing the lipotoxicity. This leads to an increase in endoplasmic reticulum stress, mitochondrial stress, increasing free radicals, and ultimately leading to cell death or apoptosis. So once a cell death occurs, the scavenger molecules comes in, which are the Kupffer cells and the hepatocyte stellate cells. There is release of pro-inflammatory cytokines, deposition of extracellular matrix, collagens, and thus the fibrosis process starts. And then from this steatotic liver disease, we have fibrosis, which goes on increasing, and then later on cirrhosis. So if you decrease the insulin resistance, decrease the intake of carbohydrates, sugars, definitely we can reduce the chances of increasing MSLD. So whom to evaluate? Now, we do not go for mass screening. This is not yet advised because of cost constraints and it will increase the economic burden. But there are subset of patients who are higher risk, who should be evaluated for MSLD and to establish or risk stratify the stage of fibrosis, because it is only when the patient develops steatohepatitis or fibrosis where the drugs which are meant for MSLD can be instituted. So patient who are diabetic, pre-diabetic, obese, overweight, or patient having hepatic steatosis on any imaging study, be it ultrasound also, or having a persistently increased AST, ALT for more than 6 months should be subjected to further tests to prevent or to identify whether they are having MSLD with established fibrosis. Now, this is the first screening procedure, most easy and most preferred, recommended by all guidelines, the FIB-4 index. Very easy to use, online calculators are available, apps are available, only 4 parameters are needed: age, AST, ALT, and platelet count. And this can, with some good sensitivity, rule out the presence of fibrosis. The FIB-4 index also has a prognostic significance. Decrease in FIB-4 index leads to a reduction in liver as well as cardiovascular events. Increase in FIB-4 index predicts increased liver-related events and cardiovascular events as well. Now, this is the latest evaluation algorithm published in the joint EASL, EASD guidelines, which was published in just recently, September 2024. So this is the subset of patients whom we need to evaluate: type 2 diabetes, obese with at least one cardiometabolic risk factor, persistently liver enzymes. So first we go for a FIB-4. If the FIB-4 is less than 1.3, it is safe. We need to follow up these patients probably every 1 to 3 years. FIB-4 of 1.3 to 2.67 is the intermediate category. Then we have to subject the patient to other tests. Basically, most commonly what we do is a fibroscan or a vibration controlled transient elastography, or some blood test like ELF, enhanced liver fibrosis test. If the transient elastography score is less than 8, again we are not much concerned. We can subject the patient to diet, lifestyle, and control of cardiometabolic risk factors. However, if the LSM, the liver stiffness score on transient elastography, is more than 8, the patient needs further evaluation and management, and it is time we should refer the patient to either hepatologist or gastroenterologist for further studies. Now, so FIB-4 definitely has a very good sensitivity. If the FIB-4 is less than 1.3, then we can safely say the patient is not having fibrosis. But if the FIB-4 is positive, the specificity is not very high. Therefore, we need to subject the patient to other tests to really become sure whether the patient is having MSLD with fibrosis or not. Now, this is the machine which we commonly use, easy to available, less expensive. There are other tests like MR elastography. Then we have MRI, proton diffusion, fat fraction test. But these are expensive tests, cannot be used in routine use always. So this is usually advocated in most guidelines. We can measure the liver stiffness. We can see the control attenuation parameter to identify the liver fat as well. And these are the actually machine-based cutoffs to identify fibrosis. But again, different liver disease with different etiology have different cutoffs. The most commonly accepted cutoff in most guidelines nowadays is 8 kilopascal. Less than 8 rules out fibrosis. More than 8, there is high risk of fibrosis. Now, this is again a based on the recent guideline, a very interesting observation which they have given. Now we can identify fibrosis based on transient elastography, but now they say that even non-invasive tests like transient elastography can identify clinically significant portal hypertension as well. So if the liver stiffness measured by these transient elastography is less than 15, and the platelet count is more than 150 or 1.5 lakhs, this may be used to rule out clinically significant portal hypertension in patients. However, if the liver stiffness measurement is above or more than equal to 20, then the patient should be subjected to upper GI endoscopy to rule out varices. So this is a very useful non-invasive screening test, especially to identify patients with portal hypertension as well. Coming to the management, lifestyle changes, diet and exercise are still the mainstay of therapy. The weight loss has been shown to be beneficial in most patients with MSLD. Then we have to manage comorbidities like type 2 diabetes and obesity and metabolic syndrome. Then we'll discuss briefly about pharmacotherapy, and bariatric surgery is definitely a very good option in those patients where bariatric surgery is indicated. So coming to diet, a hypocaloric diet is recommended at least 500 to 750 calorie deficit than the ideal requirement. Mediterranean diets have shown a lot of benefits and promise. Food which is high in fibers, fish, high vegetables, fruits, dairy products, low-fat dairy products, olive oil-based diet, we have shown remarkable improvement. Coffee has been found, black coffee has been shown in some observational studies to be beneficial in patients with NFALD. So basically hypocaloric, low carbohydrate diets, Mediterranean diets, avoiding of ultra-processed food, avoiding sugar-sweetened beverages because these are the sources of the free fatty acids in the body. We have a lot of studies and trials on ketogenic diets, time-restricted eating, intermittent fasting, but as of now, according to the current guidelines, these type of dietary regimen have insufficient evidence as of now to be recommended in patients to lose weight or for prevention of fatty liver disease. Physical activity is again very important, at least more than 150 per minute of moderate or more than 75 minutes of vigorous physical activity, minimize sedentary lifestyle. Smoking has been linked to increased chances of progression of liver disease as well as development of hepatocellular carcinoma. It should be stopped. Alcohol again should be avoided and should be discouraged. So at least 3% of weight loss has been shown to improve steatosis. More than 10% weight loss by diet and lifestyle has been shown to reduce fibrosis as well. It can definitely go a long way to prevent MSCLD. Now coming to pharmacotherapy. So again, this is as per the latest guideline. So if we talk about dedicated MASH targeted therapy, the only FDA approved or guideline approved therapy as of now, as of 2024 is resmetirom. I'll be discussing resmetirom in the next few slides. This is to be used in non-cirrhotic MASH. Patients who have already developed cirrhosis, the pharmacotherapy is very limited. We cannot use these targeted therapies. Only in F2, F3 phases of fibrosis, non-cirrhotic MASH, resmetirom can be used. Other drugs which are again probably off-label as of now in patients of NFALD or MSLD, these basically are drugs to maintain or manage the comorbid conditions. So in type 2 diabetes, we have GLP-1 receptor agonist or co-agonist, the dual GIP, GLP-1, the tirzepatide. We have SGLT2 inhibitors, metformin, pioglitazone, and insulin. And to control obesity with again GLP-1 receptor agonist therapy. Weight reduction is the key to management. Statins should always be there to control dyslipidemia because these patients are at high risk of developing cardiovascular events. So resmetirom is now the approved therapy, should be used in non-cirrhotic MASH where it is available. We have briefly about the mechanism of action. Basically, we know that thyroid hormones play an important role in reducing liver fat. They reduce liver hepatic steatosis by stimulating hepatic lipophagy, increasing mitochondrial biogenesis, inhibiting hepatic lipogenesis. So I have shown you the pathogenesis slide. So thyroid hormones basically reduce the de novo lipogenesis, increase the beta oxidation pathway, which is the healthier pathway to generate energy. So thyroid hormones again also interfere with the fibrogenesis by inhibiting TGF-beta signaling. So now thyromimetics are being studied, selective for the beta subtype which is expressed in the liver, and resmetirom is orally active thyroid hormone receptor agonist with high selectivity for beta-1 receptor. Now mind you, most of the actions of thyroid hormone are because of T3 which is acting on the alpha receptors. So acting on the beta-1 receptors, we usually do not have the unwanted side effects of excess thyroid hormone, which can develop while stimulating beta-1 alpha receptors. So the phase 3 trial, the Maestro NASH study, showed significant reduction in NASH resolution with no worsening of fibrosis, as well as improvement of fibrosis by more than equal to 1 stage with no worsening of NFLD score with resmetirom, and hence it was approved. In the US, it is being used at a dose of 80 milligram when the body weight is less than 100, and more than 100 milligram when the body weight is more than 100. But the usage as of now, they have clearly mentioned it has to be done under supervision of gastroenterologist or hepatologist. Most common side effects are diarrhea, nausea, pruritus, vomiting, and these should be monitored. The GI side effects should be monitored, as well as the effects on thyroid hormone function should be monitored. These are newer drugs. We do not have long-term studies. Studies are of 52 weeks. So we need to know, we need to understand more how the impact of these drugs on the pituitary thyroid axis as well. Semaglutide has a lot of promise. The ESSENCE trial will be published soon in 2025. The interim results have been very exciting. Semaglutide once weekly 2.4 injectable has shown almost 62% of patients have shown resolution of steatohepatitis with no worsening of fibrosis. 37% patients shows improvement in liver steatosis with no worsening of steatosis. So, and hence, this is the latest. In November, the company has given an announcement of the benefits of semaglutide in improvement of liver fibrosis and MASH resolution, and Novo Nordisk is expected to file a regulatory approval for its usage in MSLD in very soon in early 2025. Similarly, tirzepatide, which is again a dual GLP-1 GIP agonist, has again shown remarkable benefits in the treatment of MSLD in the phase 2 studies. This has again been considered in the future. Probably it will again be a targeted therapy of MASH when we have more results to it. Other drugs which are in the pipeline, these are insulin sensitizer, the MSDC0602K. Basically, it modulates the effects of overnutrition at the level of mitochondrial pyruvate carrier. It has shown to reduce insulin resistance, blood glucose, A1C, liver enzymes, as well as NFLD activity scores are being studied in the clinical trials. Lanifibranor basically is a pan-PPAR agonist. We have PPAR alpha gamma, that is the saroglitazole, I will be coming to it. Now this is a pan-PPAR agonist, all the alpha gamma delta. Basically, the receptor agonist is lanifibranor. At a dose of 1200 milligram per day, again lanifibranor has, in the phase 2B clinical trials, has reached the primary endpoint of reduction of more than equal to 2 points in the steatosis activity fibrosis A score, and definitely it has promised in the near future. Galactin-3 basically are cytosolic proteins which are involved in the fibrosis inflammation pathway in MSLD. Belapectin basically is an inhibitor of galactin-3. Now, clinical trials with belapectin have shown some not very promising, yet there are some indications it might be a role in the future. Patient with non-cirrhotic MASH or early cirrhotic, non-decompensated cirrhotic, the belapectin has been shown to reduce the hepatic vein pressure gradient in patients who have not developed varices. Patients who have developed varices, there was not much improvement, but patients who have not developed varices, there was slight reduction in the hepatic vein pressure gradient. Now coming to the Indian perspective, we still do not have all these drugs available. Indian perspective, pioglitazone is still approved for the usage of people in type 2 diabetes who have developed MSLD. This is ADA guidelines. It has shown benefits in clinical results. And even though saroglitazone does not have an approval worldwide, yet the latest guidelines of ESL ESD does mention saroglitazone as being a drug which has shown to improve insulin resistant liver steatosis, liver enzymes, and it is approved in India for treatment of type 2 diabetes in MASH. Trials with liver histological endpoints are still ongoing. So saroglitazone was approved in India in probably 2020 for treatment of NFLD. It is a dual PPAR alpha and gamma agonist. We have a 52-week short-term biopsy-driven phase 3 study with saroglitazone, where it was shown that almost 52% of patients, there was a decrease in NFLD activity score of more than equal to 2 at 52 weeks, and the Indian guidelines, INASL, recommends the usage of saroglitazone for at least 1 year of therapy in patients with MSLD. Other drugs, there are some off-label drugs. Vitamin E has been shown in the PVENS trial to be beneficial in MSCLD in those without diabetes. In patient with diabetes, vitamin E probably is not beneficial. Then we have ursodeoxycholic acid, which reduces liver transaminases, but it has no action on liver fibrosis. Obeticholic acid has showed some promise. It is a farnesoid X receptor agonist, but due to some unwanted side effects of pruritus, hepatic dysfunction, hepatotoxicity, the usage has come down. There are a lot of other drugs in the pipeline, that, like the survodutide, the colatotide. These are all undergoing phase 3 clinical studies. Probably we'll have these drugs as well in the near future. Bariatric surgery definitely an option in patients who need bariatric surgery. The indications are met, has shown very much improvement in reducing body weight as well as improvement in MASH. And one category which I need to mention, probably there is always a confusion. We are always attributing MSLD to obese person. This is a category which have been identified as normal weight MSLD. Basically, patient is having MSLD, but the BMI is less than 23 as per HN standards. These people have a higher prevalence of insulin resistance, visceral obesity, as well as decreased muscle mass. And even a 3 to 5% weight reduction led to remission of MSLD among 50% of individuals in this group of individuals. And basically, the standard guidelines recommend at least 3 to 5% weight loss even in this subset of patients who are normal weight MSLD. Last one slide. Now, patients who have developed cirrhosis, the pharmacotherapy is very limited. This is basically a guideline to treatment of other comorbid conditions and development of nutrition. Dr. Saptashi had very nicely mentioned about the nutritional part in patients who have developed cirrhosis. Yes, a high protein diet is recommended to prevent sarcopenia, as T.N. Banerjee sir has raised a very important question. Sarcopenia is prevalent in patients who develop cirrhosis, and a high protein diet is very important. Among the drugs, metformin can be used in compensated cirrhosis, should be stopped once the patient develops decompensated cirrhosis. Sulfonylurea should be avoided because it can cause hypoglycemia. GLP-1 receptor agonists can be used. There are studies, evidence as of now in child A, less studies in child B and C. SGLT2 inhibitors can be used in child A and B cirrhosis. Statin can be used in all chronic liver disease because cardiometabolic or cardiac risk are very high and we need to control dyslipidemia. Final slide, this is the latest guideline of 2025 ADA. They have given a small guideline how to approach MSLD, early MSLD without fibrosis. We just treat comorbid conditions of obesity and diabetes with GLP-1, pioglitazone or SGLT2 inhibitors. MASH-directed pharmacotherapy is not indicated. Patients who develop MSLD with fibrosis, stages F2 to F3 diagnosed by this fibroscan and other tests. Thereby again treatment of obesity, diabetes along with the MASH-directed pharmacotherapy. It is resmetirom worldwide, and Indian context it is saroglitazole is approved, can be given. Compensated cirrhosis, again, no pharmacotherapy for MASH. We have limited pharmacotherapy for diabetes and obesity. And once patients develop decompensated cirrhosis, nothing is there other than lifestyle, diet, nutrition, and diabetes management is only based on insulin. With this, I end my presentation. I thank you all for your patient hearing.
Thank you, Dr. Amato. It's an excellent presentation as usual. We are very enriched and any question? I've got one or two questions. One is that is there anything going on, any study going on to convert white fat or white lipids into the brown lipid? Number one. Number two, we very often come across some reports showing that ectopic fat in the pancreas, ectopic fat in the kidney. What is your impression about this? Should we pay importance to this group of patients?
Very important question, sir. Basically, if I start the first question, because the second question, there are some trials, even our Shotinath sir has a lot of publications regarding this fat biology in his clinic. He has some PhD students also. He's published some papers and he has presented a lot of things on these, the molecular mechanisms of fat biology. So the concept of fat, starting from subcutaneous fat to visceral fat and now ectopic fat, is definitely has all important links with metabolic syndrome, cardiovascular disease, NFLD. Now, to say that any deposition of fat outside the subcutaneous and visceral fat tissue is ectopic fat, and most commonly associated with the fatty pancreas, which you commonly find in ultrasound. We have the NFLD, which is again a fatty liver. So we all know that subcutaneous fat is beneficial and the visceral fat is definitely harmful. And it is because of this excess of visceral fat, even in lean Indians or in this normal weight MSLD, there is even higher chances of progression to NASH, MSLD or cardiovascular diseases. This increase in visceral fat has high These are basically releases a lot of inflammatory cytokines, reduces adiponectin levels, increases leptin levels. These are all interconnected. Ectopic fats are, as I already mentioned, this is again deposition of fat in the areas where it should not be there, commonly the fatty pancreas. All of these we have seen, the advantages or the management of all these conditions ultimately is lifestyle, just akin to the therapy of NFLD. Weight reduction, improvement of insulin resistance, a weight reduction of almost 7 to 10% has been shown to reduce ectopic fat, even the pancreatic fat. And if we reduce definitely the pancreatic fat, there is increase in insulin sensitivity and decrease in insulin resistance, improvement in insulin secretion as well. Now, there are studies which have shown that excess of deposition of pancreatic fat can be lead to a condition akin to a pancreatitis, where there is very much decrease in insulin secretory capacity. The insulin beta cell mass goes down, also along with the increase in insulin resistance as well. So these are newer areas of research as well and intervention, where again lifestyle, exercise, diet, and these drugs, the SGLT2 inhibitors and GLP-1 receptor agonists, there are drugs which have shown to reduce ectopic fat deposition as well and probably will be beneficial in the long term. So conversion, there are studies definitely, but as of now I cannot truly say the exact the trial status, what is it as of now. But definitely I think they demands lot of interest and lot of studies needed in this field, because this is the area where we need to focus more on. Interconvertible.
I invite 2 questions from the audience. Only 2.
On the last day, গতকালকে একটা পেশেন্ট দেখেছি, মিডল এজের পেশেন্ট, dyslipidemia with ভুঁড়ি প্লাস and obese with grade 1 fatty liver. যেহেতু ডিসলিপিডিমিয়া, আমি ওকে একটা অ্যাটোফ্যাস্টিটিন দিয়েছি আর বললাম 40 মিনিট করে হাঁটো। আর কিছু আছে?
Dyslipidemia with bhuri plus and grade 1 fatty liver.
তাকে অ্যাটোফ্যাস্টিটিন আর কিছু দেওয়ার আছে?
Sir, weight যদি কিছু weight reducing medicines can be added, মানে non-diabetic. Non-diabetic definitely pharmacotherapy management of obesity যেগুলো হয়, the lifestyle and diet definitely is the mainstay to reduce body weight. And then the approved pharmacotherapy in obese patients, if the patient is affordable, যদি afford করতে পারে GLP, afford করতে না পারলে we have orlistat, to some extent is beneficial, around 5% weight loss has been seen.
আর এই লাস্ট 5 ইয়ার্সে আমি কিছু ইয়ং অ্যাডাল্ট মিন্স 18 to 30 ইয়ার্স, ইয়ং অ্যাডাল্ট বলে, সেই ইয়ং অ্যাডাল্টে ওবেস প্লাস ডিসলিপিডিমিয়া প্লাস গ্রেড 1 লিভার, এই পেশেন্টগুলোকে আমি অ্যাডভাইস করেছি 4 মাস 40 মিনিট করে হাঁটো।
Exactly, sir.
আর কিছু দেওয়ার আছে কে?
Very important, sir. Diet, lifestyle, I've already shown at least 10% reduction in weight can reduce fibrosis. So it has been proven in studies. So definitely a rise we have all noticed. Children, because of obesity, there is increase in childhood NASH, childhood MSCLD. So diet, lifestyle changes has to be impressed upon from very early childhood period as well. Parents have to be told, na আমার ছেলে মাই খাচ্ছে না, একদমই কম খায় আর এত তো খায়. So this is the psychology of parents have to be changed to prevent childhood obesity, I think.
I have a comment that for this childhood obesity and all, I don't know whether there is any Indian guideline is forming or not. Recently European Union and UK, I just came back from UK, and my daughter is an oncologist there. So they have literally banned the use of palm oil, which is they thought, or they have scientific evidence that it is causing lot of childhood obesity, and they have literally banned total. It is free of palm oil, that is written there. That is one comment. And one question from my side, that is the patients with this NAFLD along with diabetes, they have a lot of cardiovascular complications, sometimes CKD, and they need statin, as you have said. Now hypothetically, if the patient has an intervention, then we have to use statin in a very high dose. or if the patient has hypertriglyceridemia, which also we often have, then what is your recommendation in advanced NAFLD, how far statin or anything else like bempedoic acid or ezetimibe we can recommend?
A very important question, sir. Now, as of now, as long as the patient is early stage, advanced stages of fibrosis or even compensated cirrhosis, there is no guideline recommending any contraindication of statin. In fact, there are studies where statins have shown a beneficial role in reducing the liver fat content steatosis in liver disease as well, even though they do not have any proven studies in reducing fibrosis. So statins definitely are not contraindicated. Moderate to high intensity statins can also be given if the cardiovascular health demands. Second thing is that reduction of triglycerides. Again, there's a very important question. We have earlier you used to neglect hypertriglyceridemia unless it is very high, more than 500. We usually do not add a fenofibrate or other drugs because we have seen the fenofibrate probably do not have much cardiovascular benefit. The trials were bit mix and match. But now there are studies which have shown that even a residual hypertriglyceridemia in some patients with cardiovascular disease can be harmful. So the newer drug, the icosapentethyl, which in REDUCE-IT trial had shown cardiovascular mortality benefit when the patient has residual hypertriglyceridemia. Having said that, in some patients, again, saroglitazole is also a very good option whereby it will cover both the aspects, reducing hypertriglyceridemia as well as treatment for NAFLD. So if we give, if the patient has hypertriglyceridemia along with hyperlipidemia or dyslipidemia along with MFLD, saroglitazole is definitely a very attractive option. The only problem with saroglitazole is that we do not have enough long-term follow-up studies. The only study which is a biopsy-proven study is of 52 weeks. We still need more long-term studies to establish the safety of this drug regarding cardiovascular health, because the previous PPAR agonists like muraglitazar had a lot of cardiovascular toxicity effects. As of now, because of the lower PPAR gamma effect of saroglitazar, these side effects are less, but we still need very long-term studies. But otherwise, even in decompensated CLD, I am not aware of the high-intensity statin, but low to moderate intensity statin can be continued if the patient has cardiovascular disease.
Sir, just to add one point against what Sad was asking about case. Mostly the young adults who are presenting with obesity and dyslipidemia, many of the patients have even the normal liver function test, and what we actually screen for the USG to show a grade 1, the fatty liver and a normal LFT majority of the time, so maybe to some extent deranged LFT. But these are actually not the up-to-date investigation for this fatty liver disease. So we have to proceed with the FibroScan. So this is very, very important. One of the major studies are going on at NRS Medical College under Dr. Shumik Goswami, and they have found that in majority, almost more than 50% of the patients with type 2 diabetes with a normal liver function, normal USG, even have the high-grade fibrosis. That's only revealed by the FibroScan. So please proceed with the FibroScan. FibroScan is not a very common investigation nowadays, also not available, also very costly. But some of the pharmaceuticals are also helping by doing the FibroScan the OPD basis. But at least we have to do more establishment for the FibroScan to detect early this MSLD and to prevent the cirrhosis of liver.
Exactly.
Dr. Chaudhary has already said about that also.
My gut feeling, Dr. Chaudhary, this triglyceride we often neglect, but there is no physiology in neglecting this molecule, because this hypertriglyceridemia ultimately will be converted, will raise the LDL cholesterol, and you should target also the triglyceride. What is the guideline? The Indian guideline says.
Yeah. Very nice question, sir, because triglyceride is one aspect we are very much confused about. I have seen prescriptions just triglyceride of 202 of fenofibrate being added. Now, the trials with fenofibrate, I think, are not very new, quite old. So we have the field trial and other trials where fenofibrate have been seen. So the only, there were conflicting studies, conflicting results regarding the cardiovascular benefits. So unless the drug is showing a cardiovascular benefit, probably there is no point adding another drug. But the post hoc analysis of the ACCORD and the meta-analysis had shown that anybody who has a HDL cholesterol, low HDL cholesterol of less than 35 in some studies, less than 30 in some studies, and the triglycerides of above 204, then there is some benefit in adding a fenofibrate to reduce the triglyceride level. If the HDL cholesterol is high and the triglyceride is hovering even 250, 240, that study had showed that triglyceride need not be trivial. Having said that, once the studies of icosapent ethyl had come, these are basically the omega-3 fatty acid, icosapentaenoic acid, docosahexaenoic acid, the omega-3 fatty acid studies have come, especially the REDUCE-IT trial. There they have seen even the residual hypertriglyceridemia can have cardiovascular negative impact. So, and then studies with these molecules, not a fibrate, studies with these molecules, icosapent ethyl, I think it is available in India also nowadays. Only one pharmaceutical company probably can name, since only one company I think I can name the drug also, Biosia is there. So the dose is 2 gram twice daily or 4 gram per day. At a 4 gram per day, reduction in hypertriglyceridemia has shown to improve cardiovascular or reduce cardiovascular events.
Thank you, sir. Thank you for the nice presentations and very informative sessions. So now I would request Dr. D.K. Gupta, sir, for feliciting our extreme speaker and our chairperson for the nice session. So please, for the next.
Hope everyone enjoy these very informative sessions on MS-CLD 2025. Now, for the next sessions, I would request our chairperson, Dr. Abhijit Das and Dr. Subroto Bhattacharya, sir, on stage to take the chair. And yes, a big round of applause for the nice presentation. Requesting Dr. Abhijit Das, sir, and Dr. Subroto Bhattacharya, sir, to take the chair. Our next sessions, cardiorenal metabolic syndrome, from prevention to treatment. I would request our chairperson to speak the speaker name. Thank you.
Requesting Dr. Arindam Rai in the dais. Dr. Rai is an MD Medicine, DM Endocrinology, and having several fellowship in different associations. Is at present the Assistant Professor in the Department of Medicine, Sagar Datta Medical College, and the visiting consultant of the endocrinology in Zenith Super Specialty Hospital. He will talk about the slide. Cardio. In the cardiorenal metabolic syndrome, CRM, is from the prevention to the treatment. Dr. Rai, please.
Yeah. Thank you, Chairperson, sirs, and thanks at the outset, the organizers of ABCDCon, Dr. Gupta, for giving me the opportunity here, and thanks, Boringa, for the logistics. So, good afternoon to everybody, and today's the topic has been already mentioned by the Chairperson, so standing at close to 2025, it's definitely diabetes is not a disease of blood sugar only, so it's a disease of pipe, pumps, and filter that we all know. So definitely when we treat a patient with type 2 diabetes, maybe a diagnosis, maybe down 10 years, maybe 20 years, we have to take care of the complications of diabetes and the early, the issues that happens with diabetes, with poor progression, the cardiorenal metabolic issues, because we all know that metabolic syndrome is a kind of umbrella under the insulin resistance, and it gives the, the plenty of complications with associations with diabetes. So this is the pan-vascularity with diabetes, as we all know that major microvascular and macrovascular disease that happens because of the endothelial injury, because of the atherosclerosis, and the basement membrane thickening, microthrombus formation, erythrocyte platelet addition that gives to diabetic microangiopathy, and macroangiopathy leading to either diabetic kidney disease, diabetic eye disease, diabetic neuro disease, or the stroke, heart attack, and peripheral arterial disease. So this is the study that I Care for Diabetes survey that actually shows 95% of the people with type 2 diabetes in India have additional cardiovascular risk factors. If you check the statistics, uncontrolled diabetes that happens in majority of the patients, of more than 2/3 of the patients with type 2 diabetes, close to 78 to 80% of the patients, they actually fail to achieve a target A1C of 7% at the end of 1 year of treatment. Again, considering the hypertension, dyslipidemia, and the family history of cardiovascular disease, obesity, the smoking, and the chronic kidney disease, that also, the part of this additional risk factor for the cardiovascular disease that happens in type 2 diabetes. So this is the cardiovascular death, that is the the change in the tradition in 1990, close to 15% in Indian population, and in 2016 data shows it's almost double in 28%. Because in India, the diabetes is a very important disease, closing to 12 to 15% of the patients with type 2 diabetes that happens in India. And also the cardiovascular disease in the premature atherosclerotic cardiovascular disease is also very common, close to almost 3 to 4-fold compared to the other parts of the world. And again, the national health policy that we suggest by 2025, we have to reduce the overall 25% premature death by cardiovascular disease in India. And how to do that? And before going to how to do that, we have to know why this thing happens, because of all these mechanisms that are related to early cardiometabolic disease in type 2 diabetes. The first is the most important, is the early age of onset. So as Sarah has already said, because we are also getting a lot of patients of 12, 15, 20 years, 30, 25, 30 years of type 2 diabetes with a very high blood sugar level, along with all the other, to some extent, complications like obesity and the risk factors like obesity, hypertension, smoking, dyslipidemia, and leading to a lot of cardiovascular disease. Again, the threshold, the lower threshold for BMI for type 2 diabetes, because we all know that in Caucasians, more the 25 to 30, the BMI is close to type 2 diabetes, but in India, the lower BMI is also related to type 2 diabetes. Again, there is rapid decline in the beta cell function, that means the beta cell apoptosis that happens early in young individuals of Indian phenotype. There is high insulin resistance, dyslipidemia, low levels of adiponectins. These are the good, the cytokines that actually related to prevention of diabetes or insulin resistance. But inflammatory markers are also high. There is high chance of MSLD, adiposity, ectopic fat. Dr. Amato just few minutes back already told how the ectopic fat is related to insulin resistance and early type 2 diabetes. The thin Indian fat phenotype by the Dr. Chittaranjan Yagnik study that has already told us that how the thin fat Indians compared to the Caucasians are high prone to type 2 diabetes. And again, the gut microbiota and the vitamin, the microminerals, these are also related to early type 2 diabetes. So this is the Chittaranjan Yagnik's paper that has told, compared to the Caucasians, they have studied mainly the Indians versus the UK people, that has shows there is more the less age of onset of type 2 diabetes in Indian phenotype was almost close to 10 years, whereas the less BMI, but there is more waist-hip ratio, more subcutaneous fat, more ectopic fat, and more insulin resistance lead to the early type 2 diabetes in India compared to the UK people at the same age group with the same BMI. So this is the Indian study in different parts of the India, in the Tamil Nadu, in the Chandigarh, in the Maharashtra and Jharkhand. The people were showing almost in the urban and the rural trend of type 2 diabetes. What they have shown that close to this 25 to 30 years in majority of the cities, they have actually shown the rising trend of type 2 diabetes. So it's a bit early, the incidence of type 2 diabetes that happens in India, in different part of the India, that gives a high prevalence of type 2 diabetes in Indian scenario. Coming to what are the other high-risk complications to metabolic disturbance, they're interconnected. Apart from dysglycemia, we have the overweight or obesity, we have hypertension, we have dyslipidemia, we have smoking, the beta cell dysfunction. This is an intrinsic factor, insulin-resistant hyperglycemia, that gives to the lot of complications like the CV cardiovascular and the kidney complications, neuropathy, nephropathy, retinopathy, and the metabolic and this hemodynamic changes and atherosclerosis leads to all these complications. So this is the UKPDA study. So UKPD study shows that the patients with newly diagnosed type 2 diabetes, they have very high incidence of microalbuminuria. Also the abnormal ECG may be in the form of arrhythmia or the heart failure or microinfarction, or the patient have absent foot pulse that also leads to the vascular disease and the retinopathy in a very early stage of type 2 diabetes. But this is, the Caucasian data from the UKPD study. So what about the Indian data? Also the Indians have in early stage of type 2 diabetes, they have very established neuropathy, retinopathy, and to some extent nephropathy in majority of the studies, and this is the pooled data analysis. Coming to the Mark study, what the Mark study result shows that is the cardiovascular risk starts rising early in type 2 diabetic individuals, and we can see at the age of 35 to 40, we can see the change, particularly in the males, about the high incidence of the cardiovascular disease, mostly in the asymptomatic patients with type 2 diabetes. This is the A.G. Unnikrishnan data, the cardiovascular risk in the newly diagnosed type 2 diabetes patients in India. The studies actually results are horrible. They have showed 39.5% were classified as high risk in the newly type 2 diabetic patients, whereas almost 60%, 60.5% were classified at very high risk for this cardiovascular disease in newly type 2 diagnosed patients. So they have suggested that the patients who are newly type 2 diagnosis are very high risk for atherosclerotic cardiovascular disease, and a national guideline should be there to decrease the incidence of cardiovascular death overall in this kind of patients. So this is a very age-old slide that actually shows how the insulin resistance starting maybe down 10 or 15 years before the diagnosis of type 2 diabetes, and that actually gets stagnant to some extent. Initially leads to the hyperinsulinemia, then the diagnosis of type 2 diabetes, and then the hyperglycemia. But the phase of hyperinsulinemia or insulin resistance is very much important in the pathogenesis of this cardiovascular disease, because the genetics, the weight gain, the dyslipidemia, hypertension, and the impaired glucose tolerance, this all leads to this cardiovascular disease incidence, and the pathogenesis actually starts much, much more earlier than the diabetes diagnosis. So what is the evidence we have? So this is the study, that is a PESA study, that is a progression of the early subclinical atherosclerosis, and they have found the subclinical atherosclerosis in different spectrum of the HbA1c. They have started from HbA1c of less than 4.8 up to 6.1, that is in the prediabetes range, and they have studied that the coronary artery calcium score, even the carotid arteries, iliac arteries, femoral arteries, so all the vascular, the channels, the statistic shows it's a statistically significant change that happens in this as the HbA1c increases, the carotid plaque or the atherosclerosis that also increases in majority of the arteries irrespective of their site. Again, the Nurse Cell study, that actually also shows the risk of myocardial infarction or stroke. Also there is, even in the diagnosis, before the diagnosis of type 2 diabetes. And the study result shows almost 3.6-fold increased risk of myocardial infarction or stroke within the 10 years prior to diagnosis of type 2 diabetes. So majority also in our clinics and also the referrals we have seen, the patients actually first have the history of type 2 diabetes or this stroke or heart attack maybe 5 years, 7 years back, and now they are diagnosing as type 2 diabetes. So we can at least decide that the patient can have in future of diabetes if the patient have already the cardiovascular risk factors or the incidence of atherosclerotic cardiovascular disease. Again, this is the study, the ACE 1950 study in the pre-diabetes range. So they have subcategorized the patients in 3 categories. That is the non-diabetic patients, the pre-diabetic patients, and diabetic patients. So what we can see, the red marks are actually, the pre-diabetes range, and all the cardiac markers, there is this troponin T or the CRP, NT-proBNP, or this LV ejection fraction, all are there high in this pre-diabetes range compared to the normoglycemic or non-diabetic range, and definitely they are very high in diabetes range. So even in the stage of pre-diabetes, all these cardiac biomarkers are increased. That means the patient have started the premature or the subclinical cardiovascular disease from the stage of pre-diabetes. So this is the mechanism how this hypoglycemia actually strikes the cardiac tissues. I am not going in detail of it. Definitely the dyslipidemia, inflammation, oxidative stress, vascular remodeling, whether it's intravascular or it's intracellular, that gives to the increased atherosclerosis and the diabetic cardiomyopathy, ultimately by myocardial fibrosis and death. So this is the insulin resistance. Again, the same pathophysiologies of oxidative stress, early diastolic dysfunction, poor energy insufficiency by this increased free fatty acid, hyperinsulinemia and hyperglycemia leads to this kind of lipotoxicity and metabolic inflexibility in the cardiac myocytes. So these are the different stages of cardiac dysfunction, like the diastolic dysfunction initially, as sir already said, that patients with a grade 1 fatty liver. Like that in every patient of type 2 diabetes, what we do a echocardiography, and that shows a grade 1 diastolic dysfunction. So we shouldn't ignore this grade 1 diastolic dysfunction, because this may be the first finding of a subclinical cardiovascular disease in majority of type 2 diabetic patients, because it starts with a diastolic dysfunction. That again leads to the systolic and both diastolic dysfunction. Then it goes to the microvascular and the coronary atherosclerosis, and ultimately leads to overt ischemia and increasing the infarct size, and leads to ultimately myocardial fibrosis and heart failure. So what is important here is the triacylglycerol content that increase in the myocardial myocardicytes and ultimately leads to this fibrosis. So this is the meta-analysis of 27 echocardiography-based studies in type 2 diabetic patients, and the ultimate pooled analysis, the prevalence shows almost 46% of the patients with type 2 diabetes has LV diastolic dysfunction, and this may be one of the very important significant factor for this cardiovascular disease, premature initiation. It's a very important slide that shows the prevalence of the subclinical cardiovascular disease in type 2 diabetic patients in South Asian ethnicity, and these are mostly asymptomatic patients. So significant coronary artery disease, almost to the tune of more than 50% stenosis, even in the patients with type 2 diabetes, and they are still asymptomatic. So this is very, very important compared to Caucasians, who have almost 28% incidence, whereas in South Asians it's 41%. So 2 out of 5 asymptomatic people in type 2 diabetes in South Asian race may have a significant coronary artery disease. Going to the other part of this metabolic issue, like diabetic encephalopathy. So majority of the patients with type 2 diabetes, when we actually have some of the issues like the headache or something, we do the CT brain, and what we find, microangiopathies, there is microinfarcts. So these are also subclinical majority of the times, and we can find the early this cerebral degeneration, early aging process that happens because of the dementia at the same time, sometimes in type 2 diabetes happens early. So these all actually leading to increased senility. So what are the acute and chronic disease spectrum in this neurological complication? Like metabolic neuroglycopenia, stroke, and brain damage neurological deficit as an acute one, whereas the chronic one is the advanced aging, microangiopathy, and early dementia. So what are the drugs we have available for this cognition impairment? Practically in all anti-diabetic regimen, whether it's insulin or the oral agents, we have very limited data about this cognition impairment. We have only data with the sitagliptin, some of the DPP-4 inhibitors that have actually shown some improvement in the cognition, particularly in the elderly people. Some of the data are there with metformin, with the normal cognitive function, they actually preserve the cognition in the long run, particularly in type 2 diabetic individuals, whereas all other, the agents, including the SGLT2 inhibitor, insulin, sulfonylurea, they don't have any sufficient data for the proven benefit of cognition in type 2 diabetic individuals. Coming to another very important aspect of this cardiorenal metabolic disease is the diabetic kidney disease. We all know the hemodynamic, metabolic, and the inflammatory changes happens in the kidney in type 2 diabetic individuals, leading to all the pathophysiologic changes that leads to early the diabetic kidney disease. The duration of diabetes and the progression of diabetes is definitely very, very important for advancing this diabetic kidney disease, though it has been correlated from stage 1 to stage 5 as per the diabetic kidney disease staging, but the proteinuria may not correlate, the albuminuria may not correlate with the stage of the disease or the EGFR. So we can have both the spectrum of the patients with a very normal EGFR with a high proteinuria, with even a patients with the high EGFR or the low EGFR with a moderate or low proteinuria. So that's why the KDIGO has been categorized in these patients into the different 5 EGFR categories, stage 1 to stage 5, and the A1 to A3 microalbuminuria of less than 30 to 300 or more than 300. And we can put the patient at any point of the chart where we can find what is the EGFR status of the patient and what is the proteinuria status of the patient. Because early proteinuria is already indicate the patient have to some extent the angiopathy, that is a microangiopathy, and the patient can have the cardiovascular disease. even that time the creatinine maybe or the eGFR can be normal. So this is a very important, the nomenclature has been put here, the DHKD syndrome by Dr. Suresh Chandra Das. There is a diabetes, hypertension, kidney disease syndrome where more than 50% of the patients with type 2 diabetes in India at diagnosis had to some extent chronic kidney disease. 8 out of 9 such patients with diabetes can have hypertension. So they have suggested the syndromic diagnosis of this DHKD is important for early detection and effective treatment, maybe the prevention of the long-term complications. Coming to the chronic kidney disease and cardiovascular disease, I have already elaborated that the chronic kidney disease is highly related with the cardiovascular disease because the angiopathy that is established anywhere in the body, and the data also shows the patient who have persistent eGFR of less than 60 compared to the eGFR of more than 60, they have high cardiovascular event, all-cause mortality, cardiovascular death, major cardiovascular events like stroke or MI, all are increased in the patients with the chronic kidney disease with the eGFR of less than 60. Coming to the diabetic retinopathy, I am not going in detail of the pathophysiology of retinopathy. Again, the same process of the inflammation, oxidative stress, Ag accumulation and neovascularization that happens mostly in the PDR, whereas the NPDR is related to podocyte loss and endothelial cell damage. It has been shown that peripheral arterial diseases are also related with the type 2 diabetes, and these are highly related with the cardiovascular disease. So as many pulses are not palpable, the patient have high incidence of cardiovascular poor outcome or cardiovascular established disease. There is 47% increased risk, 5-year risk of the major cardiovascular event in the patient who have the peripheral arterial disease. And there is 17% increased risk of the each additional the absent pulse is there compared to the by patient who have felt the pulse. Coming to the cardiovascular autonomic neuropathy, that is the CAN, there is a definite and independent predictor. 1 out of 5 patients in diabetes can have the CAN. 1 out of 14 newly diagnosed type 2 diabetes have the CAN, and 1 out of 20 patients develop CAN annually in type 2 diabetes. And especially in South Asians, the cardiac autonomic neuropathy can be very much associated with type 2 diabetes. They usually presents with syncope, that is a postural dizziness, even in the extreme with sudden cardiac death at midnight. So coming to the complications, definitely cardiovascular incidents like stroke 1 in 13, myocardial infarction 1 in 10, heart failure 1 in 7 patients, coronary artery disease 1 in 5 patients, and any cause of CV death 1 in 3 patients. So every third patient you see, you can tell the patient that you may die in cardiovascular, any sort of cardiovascular disease in future. Coming to the other associations like autonomic neuropathy, 1 in 5 patients, fatty liver disease, as Dr. Amartya said, 1 in 4 patients. So that's why I suggested every type 2 diabetic individuals don't go for the LFT and USG only, go for the fibroscan of the patient to find out whether the patient have MASH or not, because these are highly correlated with cardiovascular disease. Chronic kidney disease is very much related, so in every patient at diagnosis do the urea creatinine and urine albumin creatinine ratio, and at least once yearly check the urea creatinine and urine ACR to find out the early chronic kidney disease for the prevention of the atherosclerotic cardiovascular disease and the progression of renal disease in future. Again, the LV diastolic dysfunction, so don't ignore the patient with LV diastolic dysfunction, because every 50% patient have that LV diastolic dysfunction, and this can actually indicate a premature disease or a subclinical disease which can establish in future with a complete atherosclerotic cardiovascular disease. Obstructive sleep apnea is a very, very important issue. So majority of the type 2 diabetic patients are actually obese or overweight. So please find out with the obstructive sleep apnea the proper sleep study and go for the CPAP if required for the patient with obstructive sleep apnea. So this is a prevention to regression to retardation. Definitely this is important. I'm just going in 2 or 3 slides there. So intensive glycemic control is very important, but this is actually for the prevention of microvascular disease, but for major macrovascular disease like cardiovascular disease or mortality, the data are limited. So we have the target in intensive and control, this conventional group in STENO2 study, and that actually shows the much reduction of HbA1c to the close to 6.5 without hypoglycemia with a proper blood glucose control and statin that gives at least 7.9, that almost 8 years in life in patients with type 2 diabetes with a stringent control. So this is a holistic person-created approach in type 2 diabetes management. I'm not going in details of it. Definitely the cardiovascular renal aspect we have to give more importance along with the weight reduction. The same has been replicated here in the American Diabetic Association, the latest guideline. So the holistic approach from the patient to disease to healthcare provider to therapy to healthcare system, and this has been addressed in all the guidelines, particularly PAN World. And the same has been implicated here is a multifaceted intervention improvement, the coordinated diabetes study that has shows the patients, the multifaceted intervention from statin, from ACE inhibitor, ARB, from SGLT2 inhibitor, and or the GLP-1 analog. This is a combination that gives the best, the cardiometabolic and the renal protection in type 2 diabetic individuals. So going to summarize my today's talk, the Indian phenotype of type 2 diabetes have increased risk of the vasculometabolic complications, which may begin at definitely younger age group compared to the Caucasians. It is possible to prevent the occurrence of diseases, events, or complications with early and intensive multifactorial control. Beyond control of glycemia, personalized approach for the cardiovascular and kidney protection are relevant in early type 2 diabetes, and evidence-based therapy facilitated by optimum patient education can improve the adoption, adherence, and outcome for holistic care. So thank you for your patience hearing, and thanks again, and may I have some questions.
Any question from the audience? So I have one question.
Sure.
Nowadays, definitely beyond the cardio-renal protection in diabetes, there is another issue is upcoming, that is the liver, the NASH or the NFLD. And you have already mentioned that FibroScan is there, but during the other previous speaker's talk, you also mentioned that it is not available everyone, and it is costly little bit. So is there any other screening procedure that we may follow in our day-to-day practice?
Yeah, we have some of this the screening issues, some of the classes are there, also available in the internet, and also the applications are there in mobile. We can put the SGOT, SGPT data, we can put the patient's age, platelet count, and so we can have this kind of study, but this actually, gives some of the...
The FIB-4 score you are telling, yes.
But definitely we have to prove it with this, this FibroScan, and we have to go proceed for the proper treatment.
Or elastography by ultrasound, is it helpful?
I think, the FibroScan is more standardized than the
definitely, if it is not available,
yeah,
then my
definitely
question
give
is
some,
there.
it can give some of the, the impact or the issues.
So any question from the audience, please?
So any questions from audience, then we will go next.
So
episode. Any questions?
No questions. Thanks,
okay, fine.
Dr. Rai, for his...
One question.
Thank you for your excellent presentation. One just comment that each and every diabetic patient should be exposed to annual diabetic retinopathy. This vessels, the retinal vessels less than 0.2 or adopted this is 0.5 millimeter. So it is very important to look at the vessels. You can have a direct vision of the vessels. So it is very important to develop this habit to refer the patients to the ophthalmologist. It is one of the most important thing. Another thing is that there is some correlation between this nephropathy, this ophthalmopathy, then cardiac disease, cardiometabolic disease. So it's also very important to refer this patient to the ophthalmologist.
Yeah, absolutely. I completely agree with you, sir, that annual screening. So screening is a very important part in the management of type 2 diabetes. It is not only the drugs and glycemia correction. So we have to at least annually screen for diabetic retinopathy. Just send the patient to the ophthalmologist. There is no, all the scans are required at primary event. So they have to just dilate the eye and we have to check with the ophthalmoscopy whether there is any problem arising or not. If there is suspicion, then go for this detailed scan of the patient for retina. Otherwise, we can also do, the fundoscopy. There has been already some of the fundal cameras that are also provided by some of the companies. So they are also doing it, in our OPD basis. So that can also give, some of the evidence that, okay, if the patient is actually have some problem or not. And at the same time, the nephropathy screening by, the urea creatinine twice a year and the urine ACR albumin creatinine ratio once a year. That is very important for nephropathy screening. At the same time, the foot care is also very, very important. So at least annually check the patient's pedal pulses and foot inspection at every visit. That's also very important, along with the monofilament test and vibration pressure threshold. So these are actually in the neuropathy, retinopathy, and nephropathy screening. This is very important for the patients, for complication in type 2 diabetes.
Just a short comment to add to that. I think T.N. Banerjee sir has raised a very important question, all diabetic patients we need to send to the ophthalmologist to rule out retinopathy and the stage of retinopathy, and more importantly to rule out diabetic macular edema. Retinopathy, we all know it can be mild, moderate, whatever, and we need control of diabetes and hypertension. But if the patient has developed diabetic macular edema, it needs active intervention. For the ophthalmologist, fine, we will treat the patient. For our perspective, there are two medications we need to be very much concerned about. One is, everyone knows, pioglitazone has to be stopped when the patient develops diabetic macular edema. Another one drug which is being used nowadays quite commonly, even though expensive, but with lot of beneficial effects, GLP-1 agonist. If the patient is having active retinopathy requiring treatment, we should not initiate a GLP-1 receptor agonist at that patient. So there, in India, it's still in a very infancy stage, but already there are some legal battles already started in the United States regarding this issue. So I think we should need to be careful about that. All patients whom we are giving GLP-1 or we are initiating GLP-1 retinopathy screening to rule out active proliferative retinopathy should be ruled out.
Yeah. Especially the patients are on liraglutide. So the liraglutide study, they actually shows there some of the changes in retinopathy.
One more comment. We often brutally ignore this history of sexual activity of the patients. You know, the penile, all this, they have got diameter 1 to 2 millimeter like that. So it is also very important to take care of this sexual health.
There are a lot of issues, you know, not only the sexual part, only the psychological aspects are also very much important in type 2 diabetes, because depression, anxiety, these are highly correlated with diabetes. So I think the diabetes education to the patient is a totally different segment apart from the pharmacological treatment that we do. So at least give some of the time to the patient, discuss with the patient what are the problems they have. At least some of the points definitely you can address, and you know, the proper referral to the patient, to the psychiatrist if required, to the ophthalmologist, to the nephrologist, to the cardiologist. Definitely that's an important segment of diabetes management.
Thanks, Dr. Rai, for his nice
Thank you.
Thank you everyone. Thank you, Dr. Roy, for the nice presentations. Now I would request Dr. A.K. Mukherjee sir. Dr. A.K. Mukherjee sir to give the felicitating gift to our extreme speaker and chairperson. Audience, please give a big round of applause for the nice presentations. I hope everyone enjoy these very informative sessions.
Now moving towards the next, I would request Dr. Ashish Mukherjee sir and Dr. Amitabh Biswas sir to take the chair for the next session. Moving with the time, embracing fruits of innovations with insulin degludec. So for that, I am requesting Dr. Ashish Mukherjee sir and Dr. Amitabh Biswas sir to please take the chair for our next session to continue. Thank you.
Welcome you all. Congratulations, ABCDCon team, for the nice conference. The next session, we'll have a versatile speaker, Dr. Amrita Shankar Chaudhary. I don't think he requires any further introduction in this forum. He will discuss on that moving with the times, embracing fruits of innovation with insulin degludec. Amrita, please.
Thank you, respected chairpersons. I think you have to tolerate me another 25 minutes before I'm done. So that talk will be basically on basal insulin, the new generation basal insulin degludec. Moving with times, embracing fruits of innovation with injection degludec. So this is the financial disclosure. This is actually a sponsored talk, and the slides have been provided by Novo Nordisk. So starting with the hypothetical case study. Commonly, these are the patients who usually come to us in our OPD. Rajesh is a 48 years lecturer, obese, hypertensive, diabetes for last 8 years. He has hyperlipidemia, has a family history of diabetes, drinks alcohol occasionally or around 2 days per week, non-smoker, and exercises less. Very poor glycemic control, A1C of 9.7%, fasting 218. Cholesterols are high, still uncontrolled with statins. has albuminuria developed, the urine albumin creatinine has gone up. Patient has been diagnosed with increased ASCVD risk and microalbuminuria, and he has been advised strict glycemic control, diet, exercise, and a better lifestyle. Now the challenges with previous medication, he is already on antihypertensive therapy, drugs for dyslipidemia, still uncontrolled. For diabetes, he is on metformin 2 gram per day, liraglutide 1.2 milligram per day, already on a GLP-1 receptor agonist therapy, empagliflozin 25 milligram per day. He still has uncontrolled hyperglycemia, and because of his hectic work life, he fears insulin injection. He won't be able to adhere to the timing of injection. Fear of hypoglycemia is always there. Now, to treat Mr. Rajesh, what will be the most ideal next line of treatment? Now, if you go by the guidelines, the patients are uncontrolled on OADs, then an injectable GLP receptor agonist is recommended. The patient is already on liraglutide. The next best option definitely is a basal insulin, because the A1C is around more than 9%. We do not have any other options to bring down the A1C by more than 2% other than insulin at this point of time. So this will be the points I will be discussing in the next few slides. Quest for ideal basal insulin, transitioning away from first generation basal insulin analogs, and delving into the realm of ultra long acting basal insulin. Now, what are the features of an ideal basal insulin? Basically, there should be a flat, peakless activity profile to minimize the risk of hypoglycemia, to avoid glycemic variability. It should have a minimum glycemic variability and a long duration of action. The duration of action should be such that the insulin action does not stop beyond or before the next dose is injected. For example, there are some basal insulin, especially in some cases of, and not all cases of first generation basal insulin, we have sometimes seen, if the basal insulin is injected at 10 p.m., we have seen the pre-dinner values going very high, which means that probably the basal insulin had stopped working at around 2 hours before dinner, and thereby the pre-dinner goes up. And once the pre-dinner goes up, it's very difficult to control the post-dinner and the next day's fasting. It sets up a vicious cycle, and ultimately the glycemic control worsens. Now, if we start with the journey towards perfecting basal insulin, we have come a long way from discovery of the animal insulins, and now we have these wonderful basal insulins and the newer generation of insulins. The first basal insulin to be strictly not truly basal, however, providing good basal coverage was the NPH insulin discovered in 1954. Wonderful, cheap, economic insulin. I still use NPH in some cases where they have economic constraints, and as well as I use a lot in patients with pregnancy in diabetes as well. Then came Detamir, did not gain much popularity because it had a shorter duration of action. Glargine U100 revolutionized the treatment of diabetes with basal insulin when it came. We still use Glargine U100, still one of the very good insulin to have in our armamentarium. And then came the second generation basal insulins, the Glargine U300, and finally the Degludec. So with progressively improvement of the basal insulin, we have seen the half-life of the insulin getting longer and the variability of insulin getting decreased and reducing chances of hypoglycemia, which is very important when we are prescribing insulin. See, the most important fear, not just for patients as well as for the physicians, endocrinologists, diabetologists, is that the fear of hypoglycemia. We do not want our patients to have hypoglycemia. If at the point of initiation or at any point of time at the early stage the patient suffers from hypoglycemia, patient will lose confidence, they will discontinue insulin, or even if they are using insulin, it will be very difficult to convince them to increase the dose to get optimum glycemic control. So anything which prevents hypoglycemia, even by a margin of 2%, 5%, is definitely suitable than other insulins. So insulin Degludec has the PKPD profile, as you can see, has a flat profile across the 24 hours, does not have a peak, does not have a trough, so therefore there is definitely less variability. Regarding efficacy, we have the TRUST study, where more than 1,000 patients of type 1 and type 2 diabetes patients were exposed to Degludec for 1 year. A1C reduction at the end of study period was seen to be around 1.8%, with a very good plasma fasting glucose reduction of around 64, so thereby no question on or doubt on the efficacy. Now, compared to the first generation basal insulin, if you see, the onset of action of Degludec is very short, 0.5 to 1.5 hours. Glargine has an onset of action of 2 to 4 hours. Duration of action of Degludec is very high, more than 42 hours. Glargine has a duration of action of 22 to 24 hours. Practically, sometimes we even see sometimes it goes down to 18 hours, 20 hours, patients who are very highly insulin resistant. So Degludec has a faster onset of action and a prolonged duration of action as compared to Glargine U100. Glycemic variability, as I have mentioned, are the highs and lows we face in our patients. For example, a patient might have come to your OPD with an A1C of 7%, but if you look at the glycemic profile, if you go for a SMBG or even a continuous glucose monitoring, you might find the patient is having a fasting blood glucose of around 65 or 60, PPG of around 180. The average is being maintained. He has an A1C of 7, but he is having a lot of hypoglycemias and glycemic excursions. That means he is having a high glycemic variability. So we need to avoid glycemic variability because we have seen the clinical studies have shown high glycemic variability can lead to aggravate the complications of diabetes, especially cardiovascular complications and cardiovascular events. Now compared to glargine 100, we can see the euglycemic claim study, degludec maintains a steady profile across the 24-hour period, where on the other hand, the pink color bars, you can see the glargine U100, the first 12 hours shows a consistent high maintaining level, and gradually the level of glargine gradually decreases, and thereby it shows how the fluctuations of glycemic variability can occur with the first generation of basal insulin. Day-to-day glycemic variability is again very important. As you can see, the green bars are constant. So a constant C is maintained with degludec. The red bars, as you can see, the glargine 100, there is highs and lows, and again, which leads to an increase in day-to-day glycemic variability as well. So lower the glycemic variability, better with the glycemic profile. It will be maintained within the target range of 80 to 180, preventing hypoglycemia, preventing glycemic excursion, and this is what we want. This is the most ideal scenario we want to have in all our diabetic patients. So we have time in range study as well, the Switch Pro Act RCT, where degludec was compared with glargine U100. Estimated treatment difference was a significant 1.3% or 20 minutes per day of improvement in time in range was seen with degludec compared to U100. So even this improvement matters a lot when we are considering long-term treatment, long-term management. Safety, again, very important to note that I have talked about it initially, that we don't want insulin to cause hypoglycemia. Safety of degludec has been established. There are a lot of phase 3 studies, the BEGIN study, the Switch 2, then we had the dedicated cardiovascular outcome trial, the DEVOTE, and real-world evidence has also shown consistently proven hypoglycemia benefit in more than 16,000 patients, so therefore safety is not an issue at all. Now, achieving targets safely, this is the post-hoc analysis of Switch 2 trial. Now, it has been seen that one can achieve lower glycemia targets with degludec before incurring an equivalent glycemia, hypoglycemia risk. So better A1C reduction with less hypoglycemia definitely makes it an attractive basal insulin. Flexible dosing hours is something which is a very important advantage of these insulin. Many patients, because of our lifestyle, cannot adhere to the fixed time of injection of insulin. Degludec gives the flexibility of 8 to 40 hours. Minimum gap should be 8 hours. Patients should not be injecting 2 doses below 8 hours, but the time limit of the next dose can range up to 40 hours. For example, the patient has come home late. Patient usually takes the injection at 10 p.m. Patient came at 1 a.m. He has forgotten to take the injection degludec at bedtime. He can take it in the morning, early morning, and from the next day, he can take it in the same day itself at night, maintaining a gap of more than 8 hours. So this is the flexibility of injection degludec, which is again wonderful to have in our today's busy lifestyle. So to summarize the benefits of degludec versus glargine 300, faster onset of action, less glycemic variability, higher efficacy, better time in range, and definitely a proven safety profile. Now coming to comparison with the other second generation basal insulin, the glargine U300, where all the confusion lies. Now which is better than the other? Very difficult to say as of now. So regarding onset of action, degludec has an onset of action of 0.5 to 1.5 hours. Degludec has an the glargine U100 has an onset of action of 2 to 6 hours compared to degludec's 0.5 to 1.5 hours. Duration of action of degludec, as I mentioned, is more than 42 hours. Duration of action of U300 is around 30 to 36 hours. So well beyond 24 hours, usually meets the criteria of a long-acting basal insulin. We want to have a longer duration of action. But still, degludec has a faster onset of action and a more prolonged than U300. Efficacy as far as A1C reduction, this was a study of Tibaldi et al. Published in 2019, where degludec was found to be superior to a glargine 300 as regards A1C reduction is concerned. Statistically significant better A1C control was seen when degludec was used in this group of population. Fasting plasma glucose reduction was also found to be better in some of the studies when degludec was compared with glargine U300. Glycemic variability, just like U compared to U100, even with U300, as you can see, the left side, the degludec has a stable profile throughout the day with slight fluctuations in glargine 300. So within the glycemic variability was better with degludec compared to glargine 300, and also the day-to-day glycemic variability was less with injection degludec compared to glargine 300, which is again amounts to less of hypoglycemia, less of glycemic excursions, and better glycemic control. The confirmed study was basically a real-world evidence study, which showed that compared to where degludec and glargine was compared in insulin-naive patients, more than 4,000 people were studied, and there was 30% lower rates of hypoglycemia with degludec compared to glargine U300, which is again very significant, as I've already mentioned, in the treatment of diabetes with insulin therapy. Dose time flexibility, we have huge flexibility with degludec, 8 to 40 hours. Glargine U300 also gives a dose time flexibility, but it is less, which is plus minus 3 hours, but yet it is still quite beneficial even for most of the patients. Potency wise, again, the studies have shown degludec might be more potent, as a 30%, glargine has a 30% lower potency compared to injection degludec. Now this is a bit of controversial statement. Theoretically, when we are shifting from other basal insulins to injection glargine U300, a dose of extra 20% dose of glargine 300 has to be given from the previous basal insulin. Now this comes from the fact that theoretically glargine 300, basically a large volume of injection, 300 units per ml of injection is being injected. So in a smaller compact area of deposition, a large volume of injection gets injected. So from that, the absorption in the systemic circulation is very slow. Theoretically, there is a decrease in bioavailability of the injection glargine 300. So while we are changing to glargine 300, it is recommended that we need to increase 20% of dose. But how far it is true in practical, we need further studies. More detailed study has to be looked into it in practical circumstances. More we use it, probably more the better idea we will have regarding this increase in 20% dosage, whether it is needed or not. Better adherence with degludec, confirmed study again shows that once the patient is quite satisfied, patient is not having hypoglycemia, blood glucose is controlled, A1C is maintained, that is the satisfaction actually the patient gets. And once the patient is satisfied, it's very rare that patient will be non-compliant with therapy, and all these insulin, the second generation basal insulins like degludec, do provide this sense of satisfaction to the patients. Same time, now again, glargine 300, as I've already mentioned, it's very difficult to differentiate between these two basal insulin. Glargine U300 has also shown remarkable benefits as regards time in range, as regards hypoglycemia prevention in many of the studies. So as of now, there are subtle differences in the head-to-head trial, the BRIGHT trial. There were very less dissimilarities compared to similarities in both these insulin. Some of the trials have shown that even the injection U300 has a less potency of developing hypoglycemia in the early titration phase. But again, I have shown some of the studies of degludec where they have shown it is more potent, more efficacious, less of hypoglycemia. So anyways, we are blessed to have two wonderful basal insulins, insulin injection degludec and injection glargine 300 as of now. In some respects, definitely one insulin has to be superior than the other compared in treatment of patients while we're using in patients of type 1 diabetes and type 2 diabetes. So here, the action, if we have the basic statistics, the action is definitely faster onset of action of degludec. Glucose variability is slightly less. Proven safety profile in most of the studies and requires a lower dose theoretically. So to summarize, the ideal insulin injection degludec fits the bill. Flat, peakless activity minimizing the risk of hypoglycemia, minimal variability, and a very long duration of action of more than 24 hours, allowing huge dose flexibility. So with this, probably I end my presentation. I thank you all for your patient hearing.
Hello. Thank you, Amrita, for a nice presentation and discussing in detail about the basal insulin, specifically degludec. Any question from the floor, please?
I have one question.
Yeah, please.
Actually, the second generation insulin, there is a good enough in time in range as well as HbA1c reduction, but in our practice, there is a postprandial excursion is there.
Postprandial excursion, yes.
But as per, there is a flexibility is there because of glargine is there, as well as the degludec is also there. So is there any benefit in the, because of this flexibility in that range when the postprandial excursion is there getting any benefit in that? Or how we can manage that postprandial excursion in case of this type of second generation basal insulin?
Yeah, very nice question. Actually, we have a lot of doubts regarding while we are managing insulin, whether this will be able to control. Because we all know that while we are initiating insulin therapy in insulin naive patients, standard recommendation is most often to start off with a basal insulin. So when there are certain criteria when to consider a basal insulin or when to consider a basal bolus or a premix insulin. Now, if the gap between the fasting and the postprandial hyperglycemia is not very high, the delta is less, and the fasting is definitely a bit high, we prefer to start off with the basal insulin. Given the idea that the basal, once the fasting plasma glucose gets control, the PPG itself will get control. Initially, it does happen in most cases, once the fasting gets control, and the PPG will also get control. But we all know that diabetes is a progressive disease. With gradual increase in time, there is beta cell exertion, decrease in beta cell function, and definitely the postprandial part does not get well controlled, maybe after a few years of basal insulin, or in some cases even from the start. Now, in these cases, this dose flexibility will not give any further effect because ultimately only the fasting is being covered. We are not giving any prandial coverage. So, if the patient is having some OADs, we can use the help of some OADs to bring down the PPG. We have DPP4 inhibitors, we have alpha glucosidase inhibitors, acarbose, voglibose, these are the drugs. We can counsel the dietary part is very important, low carbohydrate, high in fiber food, those are the other aspects where we can use to manage the hyperglycemic excursion. Having said that, if still the postprandial glycemia is not getting control, the first step to intensify the insulin, what we can do, the patient is very comfortable using the basal insulin, we can go for a SMBG profile, identify the peak. Sometimes there is only one peak, maybe after the post-breakfast, maybe after the post-lunch. One peak which is going above 200, rest of the blood glucose is usually under control. At that point of time, we can just add a short-acting prandial insulin. So if the basal continues, we give the prandial insulin coverage to cover that peak only 2 shots per day. Again, the patient's blood glucose will get under control. Basal plus therapy, yes sir.
Patient is on actually the liraglutide.
Okay.
That patient, which is talkative about.
Yeah.
And here the patient, we can add on that the basal insulin or stop the...
No. The liraglutide can be continued.
Continued.
GLP and insulin are two different things.
Yes.
If the patient is on GLP-1, we do not give a DPP-4 inhibitor.
Yes.
Two things should not be combined. We should be any DPP-4 inhibitor we stop. Then we can give a GLP. The GLP can be continued.
GLP
in fact,
continue?
if the GLP is continued, the insulin dose requirement will be less, weight gain will be less. Yes. I think this is a no-sponsored talk, but for academic purpose, I think we should discuss the insulin with lixisenatide combination is there. Lixisenatide is one molecule which is GLP-1 receptor agonist. Disadvantages was that it could not show cardiovascular benefit. Main advantages of combining these two is that the extra weight gain which we see with insulin is not there because lixisenatide can balance that weight gain. So that is again an option which can be used, and lixisenatide has postprandial coverage as well.
বিকালে সন্ধ্যাবেলায় 15 নিয়েছিল, ওয়েট হলো 50 কেজি। আমি ডেগলুডে কি হিসাব করে দেবো?
When we are converting, thank you sir, there's again a nice question. So if the blood glucose is not controlled, patient is having lot of fluctuations, glycemic variability, converting premix to degludec is a very good option. I mean, if you are converting, you are asking degludec or the co-formulation, sir? Degludec korchen na co-formulation bolchen? Degludec korchen. Ekhon again it depends. Duration of diabetes, what is the hyperglycemia, postprandial hyperglycemia level. If PPG is not very high, fasting blood glucose remains high, patient is requiring higher doses of premix insulin at night, then definitely there is an option of converting the premix into the basal insulin. Now, the basal, now if you are considering premix insulin, premix has a basal insulin component, the NPH, which is 70%. So before I go to that part of your question, I just want to add, since I will forget it later on, since the premix has a 70% of basal insulin, I have seen some prescriptions, I won't say it's wrong, but it is not physiological to combine two basal insulins. I have seen some prescriptions where patients are getting twice daily premix and again a glargine at bedtime. I won't say it is wrong. Nothing is wrong as long as the blood glucose is controlled and the patient is not having hypoglycemia, but it is not physiological to add two basal together. If you are adding a basal insulin, either a degludec or a glargine, it's always advisable you stop the premix and convert it into a short-acting prandial insulin. That is one part. The second part, coming to your question, is that if now we have to know the dose of basal component of your premix insulin. So if the patient is taking, say, 20 units per day of premix insulin, so 20 into 0.7, that is 70%, 20 into 0.7 will be around, say, 14 units. So that is the basal component patient is getting, right? Get my point? Yeah, yeah. 12 units in the morning, 8 units at night, 20 units is the total dose. 70% is NPH, that is a basal insulin. So 20 into 0.7, that is 14 units of basal insulin the patient is already getting. So we need to convert that 14 units into the basal insulin. Yes. And when we are converting, we reduce another 20%. So 14 into 0.8, or you might reduce 20%. So roughly around 10 to 12 units is the basal insulin which will be giving to that patient. So for just a specific calculation, 20 into 0.7 into 0.8, just use your calculator. It will be a very fast and easy calculation, and then definitely you can titrate depending on the fasting plasma glucose.
আপনি আজকে ডেগলুডেক্স সম্বন্ধে খুব ভালো ভালো কথা বলেছেন। আমার গ্লার্জিন নিচে 100, এবার আমি
গ্লার্জিনও ভালো স্যার, এখন বলতে হচ্ছে, বললাম
ডেগলুডেক্স ভালো ভালো কথা বলছি, আমি ডেগলুডে 300 তে যাব, কি করে কনভার্ট করব?
গ্লার্জিন টু ডেগলুডেক, হ্যাঁ, সেম ডোজ স্যার, ইউনিট টু ইউনিট কনভার্সন, Now glargine is a good insulin definitely, but it has a basal coverage, long acting insulin, but that completeness, মানে এখন ডেগলুডেক আর গ্লার্জিন 300 যদি আসতো না, আমরা বুঝতে পারতাম না যে বেনিফিটটা কোথায়, কম্পারিজন নেই। এখন যখন ওরা ছিল না তখন ডেফিনেটলি গ্লার্জিন 300 was the hero, when Rajesh Khanna was the hero, when Amitabh Bachchan was not there. So once Amitabh Bachchan came in, again Rajesh Khanna, but Rajesh Khanna's importance to the kome jayeni, that is one part. But when Amitabh Bachchan is there, you definitely will want to have Amitabh Bachchan in your films. You will want to have basal insulin, second generation of basal insulin in your regimen if the patient can afford. Definitely much better than first generation basal insulin. That is proven, personal experience also, definitely better than first generation basal insulin.
Okay, now we can conclude the program right now. I think anybody don't have any question. Now we are running one question. Yes.
Renal safety profile of this particular insulin, especially diabetic kidney disease patients. How will go about it? Because we always recommend plain insulin in diabetic kidney disease because of shorter acting, because this is a long acting insulin. So how we can go about it, and what about the risks of hypoglycemia, especially in diabetic kidney disease?
Again, a very important question. So risk of hypoglycemia is higher with short acting prandial insulin because they have a peak, they have a trough effect. Basal insulin has a flat profile. All basal insulins are very safe in all patients with CKD, even in patients with CKD dialysis who require a high dose of insulin. There are a category of patients who develop CKD and the insulin requirement dose goes down very low. They have a low fasting glucose. In those patients, 2 to 4 units of short acting just before meals controls the blood glucose. Another subset of patients develops huge insulin resistance when they develop diabetes with CKD. Probably they also have an underlying NFLD, NASH, MASH, whatever you call it. So in those group of patients, fasting glucose remains very high. They require more than 30, 40, 50 units of insulin. In those patients, basal insulin has to be given. Very safe, very effective, need not worry. It is more often the prandial insulin which causes the hypoglycemia. I've very rarely seen there is a fasting hypoglycemia. It's more often it occurs in the daytime, mostly caused by the prandial insulin.
use insulin in case of SDH or ICH or CVL?
Any patient who is admitted acutely ill, obviously insulin is the therapy to be used. We do not give oral medications. Once the patient is recovering, patient is going home, patient is eating well, no acute signs, we can convert to OADs, the safe, whatever is safe, depending on his renal and liver profile.
There is no such contraindication.
There is no such contraindication when the patient is recovered.
Thank you. Thank you. Just one point to add that deglutition is now allowed in the pregnancy also.
Yes.
Yes. FDA appears to this. With this, I thank you. Thank you, Amurtha. For nice
Take me.
discussions. Thank you,
Amurtha.
everybody.
Thank you,
Guys,
sir, for
Amurtha.
the wonderful
Yes,
presentation.
the shortage of time.
As you have quoted this
And,
Amitabh Bachchan
Hey,
and Rajesh Khanna, you need Amitabh Bachchan, also remember the playback singer. They also help them to elevate, no?
Elevate.
So the association of this basal and bolus also is very important.
Bolus is also very important. Still going strong.
Thank you.
So thank you everyone. Please give a big round of applause for that, for the nice presentations. And so requesting Jayant Rana sir for felicitating our speaker and our chairperson. And now I am giving my mic to Dr. Shubhamoy sir for the next session.
So we are having beautiful sessions over here, but I have taken the microphone because we have a very special session of a panel discussion on a relatively new molecule that is non-steroidal MRA, finrenone, for the spectrum of patients with CKD and type 2 diabetes, improving CVS and renal outcome. I will request everybody to listen into this session because three luminaries in their respective fields and all national level speakers, they will have the panel discussion. Dr. D.K. Pahari, Dr. S. Shamazdar and Dr. Sunil Lila. And I will request our very respected senior most physician, Dr. D.K. Pahari, to chair as well as moderate the session. Thank you.
Hello. So before this session starts, I have an announcement to make. I would like to request all the jury panel of PGT paper presentation as well as those PGTs who have participated in paper presentation to be kindly present, because after this session we are going to felicitate them. Thank you.
Sir, arakta mic.
Okay, sure. Yeah. Okay, sure. Good afternoon, everybody. So, we have decided that we'll give a short presentation, each one of us, and then we'll go for the question and answer. So, we'll start with the short presentation.
So, thank you, organizer, for giving us this opportunity. And these are the disclaimer for this presentation. And let's start today the first perspective of this newer molecule finrenone with a case. And I think this type of case we often face in our day-to-day clinic. The 57-year-old man diagnosed with diabetes for 10 years, HbA1c 7.4, BP 138/84. Yes, there could be more stringent control of blood pressure and A1C for this particular man. But we will discuss a little bit ahead, apart from that A-B control, what are the other important parameters we need to focus in our day-to-day clinic. So this data, this epidemiology is important. Already we understand that Mr. Raj is one of that 74 million Indian who is suffering from type 2 diabetes. Now it is also important to see, when we talk about type 2 diabetes and CKD together, we have 35 million Indians too. And whether Mr. Raj could be one of those 35 million having both CKD and type 2 diabetes, that is an important issue we need to take care. So often we test creatinine, and from creatinine we get that EGFR calculation, and for this man the EGFR was 60, so it comes around G2, that means between 60 to 89, we can see here he is present in that category. But what is missing here, we don't know about the urine albumin creatinine ratio. And this is very unfortunate data, but it is very true that still the CKD is one of the underdiagnosed area, underdiagnosed zone. Yes, in this particular study, what we can say that 85% of those CKD patients had their EGFR values in last 15 months, but only 47% of them had urine albumin creatinine ratio assessment. So this is very unfortunate, because when we talk about EGFR value, it is the value which suggests the kidney function, how kidney acts. But when we are missing the urine albumin creatinine ratio, we are actually missing the bus by which we can diagnose early the irritation that happen inside kidney. If we can identify urine albumin creatinine ratio, and if we can identify those cases of microalbuminuria, we can prevent these atrocities. We can see again some very unfortunate numbers that may be associated if there is presence of CKD with type 2 diabetes vis-a-vis absence of CKD in type 2 diabetes. So both from the patient perspective and from the healthcare perspective, these numbers are really scary. Now coming to our case where the urine albumin creatinine ratio assessed and it was found to be 852. So there is macroalbuminuria. So now we can understand how the patient which was being in the mild category, we were thinking the patient may be in that mild category here, but ultimately it reaches there, so he is at high risk of CKD progression. So this is why all the guidelines that recommend our patient should be, type 2 diabetes patient should be screened more often for EGFR value and urine albumin creatinine ratio. And when we talk about the assessment of urine albumin creatinine ratio, we can see from very early period, even like 6 months, there is a dissociation. If it is more than 150 urine albumin creatinine ratio milligram per gram, there is higher, more CV events. Along with also the kidney composite outcomes are there if there is increased urine albumin creatinine ratio. So that is why everyone, every guidelines recommends to assess EGFR along with urine albumin creatinine ratio. So this should be the take-home message, one of the very important take-home message for us in all our type 2 diabetes patient. At least annually, we should measure EGFR and urine albumin creatinine ratio. Yes, EGFR will tell us about the kidney function, but why we need to assess urine albumin creatinine ratio? Because it measures kidney damage. So that is why the urine albumin creatinine ratio need to be assessed yearly. So we can see different guidelines. They are telling us even urine albumin creatinine ratio can be measured by urine dipstick method also. And there are certain tips while interpreting the urine albumin creatinine ratio, like it requires to stamp one case as macro or microalbuminuria, we need to have 2 to 3 positive tests, and that is required within a 3 to 6 month period before confirming the diagnosis. And when we talk about some confounding factors like exercise within 24-hour, infection, fever, congestive heart failure, marked hyperglycemia, menstruation, and marked hypertension, that may elevate urine albumin creatinine ratio independently of kidney damage. So we need to take care of this issue to prevent false positive results. Now coming to some pathophysiological factors like hemodynamic changes, elevated blood pressure, increased intraglomerular pressure, some metabolic atrocities like poor glycemic control. On top of that, if we have inflammation and fibrosis, this trialogue ultimately lead to kidney fibrosis. The changes could be tubulointerstitial damage and inflammation, glomerulosclerosis, mesangial expansion, glomerular hypertrophy, and cardiac fibrosis too. The myocardial fibrosis, atherosclerosis, vascular stiffness, calcification, and ventricular hypertrophy. So ultimately there will be kidney fibrosis and cardiac fibrosis leading to CKD progression and CVD progression. So there we need to have some agent which can halt this progression, the CKD progression and the CVD progression. Now coming to the treatment armamentarium, what we have before, maybe 2000, 2002, different SE inhibitors and ARBs, they were being showing some promise in this regard, but almost there is a 20 years gap when we had around 2017 to 2020 got some news on SGLT2 inhibitors starting from canagliflozin, then dedicated trial by dapagliflozin and empagliflozin that had shown some benefits in prevention of CKD progression. But at the same time, even with those canagliflozin trial or DAPA trial, there is still presence of those relative risk. So the residual risk that matters, and for that we need to have something more which can address not only the hemodynamic control or the metabolic control, we need something which can also address that inflammation and fibrosis part. So how we can modify that inflammation and fibrosis part? There is a major concern of mineralocorticoid receptor overactivation, which lead to both hemodynamic change and inflammation and fibrosis. If we have some agent which can target that mineralocorticoid receptor overactivation, that may contribute to halt or reduce the rate of CKD progression. And for that, the finrenon, which is a very wonderful molecule which targets the mineralocorticoid receptor overactivation and slows both that heart and kidney disease progression by targeting inflammation and fibrosis and the hemodynamic factors. So they give us some protection in terms of heart and kidney. So why it is little bit different than other aldosterone antagonists? Most importantly, the finrenon is a bulky molecule. It is a non-steroidal and very selective mineralocorticoid receptor antagonist. And when we talk about its structural properties, the pharmacophore of finrenon, they are very much targeting to the mineralocorticoid receptor, having the highest potency against mineralocorticoid receptor. At the same time, their selectivity was much higher compared to spironolactone and even the eplerenone. Another important benefit is the T-half, the half-life. The half-life of finrenon is much shorter. It is 2 to 3 hours. And that is why the hyperkalemia, which is very often noted with other aldosterone antagonists, is much lesser side effect when we talk about finrenon. So as modern all guidelines, including ADA, KDIGO, they are telling us, apart from those 4 important pillars like glycemic management, blood pressure management, lipid management, and also using some agents which have some specific note on cardiovascular and kidney outcome. For an example, SGLT2 inhibitor and GLP-1 RS. We need to consider something called as a special mineralocorticoid receptor antagonist which can act in this pillar and reduce the diabetic kidney disease and complications, overall reducing the cardiorenal risk with rash blockade and SGLT2 inhibitions. So now if we can summarize, we need holistic treatment approaching this CKD. We have RAS blockers, we have SGLT2 inhibitors which will take care of the metabolic dysregulation and hemodynamic perturbations. The rash blockers will take care of the hemodynamic perturbations, but when we talk about finrenon, they will also act on that inflammation and fibrosis part. They decrease inflammation, decrease fibrosis, decrease endothelial dysfunction. So ultimately it will have a beneficial role in tissue remodeling and proteinuria. So with that, to summarize, individuals with diabetes, they are tenfold having more chance to progress to end-stage renal disease. And when we talk about end-stage renal disease, they are having premature death chance, cardiovascular disease chance, early stage diagnosis and management is very important. So apart from RAS blockade, SGLT2 inhibition, we need to have something more, and for that we have Finrenon, which targets the inflammation and fibrosis part. Yes, we need to be cautious because as we are playing with mineralocorticoid receptors, there could be a chance of hyperkalemia, could be a chance of blood pressure loss, but as we had mentioned, its unique pharmacophore, it has lesser chance of hyperkalemia and lesser other adverse effects that are commonly associated with spironolactone. So with that, I may request our next speaker to carry forward.
Yeah. So good afternoon, everyone. I think I'll make a summary and a little less intensive for you. See, if you see the diabetic nephropathy patient, you have started with the SGLT2 inhibitor and possibly the AC inhibitor or ARB, and you follow up the patient, you find that the serum creatinine is rising over time. So that's the common phenomenon. If you start with the EGFR of 30, something creatinine of 2 mg/cent, you continue the therapy, and then if this is the best of outcome, you have controlled sugar, you have controlled the lipids, and then you have SGLT2 inhibitor and AC inhibitor. These two are known factors which retard the progression of kidney disease, but you see the continued progression. So what is happening? This is called residual effect. So the progressive damage in the kidney continues in spite of the two pillars of therapy what we have been discussed. So then the concept came is the called mineralocorticoid overactivation. If you start with the AC inhibitor or ARB, the mineralocorticoid receptors are overactivated. So there is a overactivation of mineralocorticoid receptors, and therefore there is a need to mineralocorticoid receptor antagonist. So the first trial, not with for the kidney disease but for the heart disease as well as from kidney disease, came through the spironolactone on RAL study. It shows the significant benefit with the heart failure as well as some kidney benefit. But the spironolactone has a problem with the gynecomastia because it is a hormonal side effect as well as hyperkalemia is very high. Subsequently, the eplerenone came. It is a less steroidal side effect, but the hyperkalemia is still high. So in the laboratory, it came as a testing method that Finrenon may be a good idea because it has shown the less of hyperkalemic effect compared to both spironolactone as well as eplerenone, and therefore this molecule has been introduced. In the tolerability study of the mineralocorticoid, this Finrenon, it has shown that there is a less of hyperkalemia versus spironolactone. In patients with a diabetic kidney disease who has albuminuria, if we use this Finrenon, it has shown the reduction in albuminuria with similar or adverse effects compared to placebo. I mean, there is hardly any side effects. And in patients with a reduced ejection fraction patients in type 2 diabetes, they are well tolerated compared to eplerenone. So eplerenone EPSA study, as I said, there was there. So because of with this background, the phase 3 started. This is called Fidelio DKD and Figaro DKD. We'll come to that, and that includes a large number of patients. And this is the heat map actually. So Okay. So this is what is called as the heat map. So initially we have only the glomerular staging, and then included is the albuminuria staging. So what you see that if the glomerular GFR is high, I mean more than 60, and there is no proteinuria, then you are green, then it's okay. If you are having, even if the normal GFR to be the beginning, but you have a higher proteinuria, your risk increases. This is the one message for all people, physicians, because at this stage, most patients actually, they are asymptomatic. They don't come to you as a kidney disease problem. They come with the diabetes. You are checking the diabetes, you are controlling sugar, your whatever the insulin you are giving. This is not, you are controlling blood pressure, but this is not enough. What we are emphasizing, you have to check the urine albumin creatine ratio. This is a fundamental, and from the beginning and periodically, you have to keep on checking, because this is the risk actually increases with time, with proteinuria only. Irrespective of everything others is normal, but you have one patient has proteinuria, one patient don't have proteinuria, the risk is increased. So this is the graph profile. This is called heat map, and this is called CGA classification of the glomerular disease. So the Finrenon, I mean Fidelio decade studies, they included this group of patients. The entire population is included in this patient. They have a GFR varying between 25 to 60, here GFR between 25 to around 90, and then some patients has got a moderately increased proteinuria and some patients has got a severely proteinuria. They are pretty diabetic nephropathy. So here we have two group of patients. Another, this is the Figaro DKD patients. They are relatively less severe. They have a little higher GFR between 60 to 90 here, and here they have a GFR, I mean it's okay, I mean close to 90, between 90 to this one 675, but this group of patients has got a higher proteinuria, this area, and this area they have a moderately increased or microalbuminuria. This is the Figaro study, and this is the Fidelio DKD study. Here the patient has got a lower GFR, but proteinuria, some are moderately increased or microalbuminuria, some are severely proteinuria. So these patients are relatively less severe, and therefore not likely to end up in end-stage renal failure in short term. In 2-3 years they will not reach end-stage because they started with a GFR of 60, at least 60 or more than 60. So, but some of them has got a high proteinuria. So the rate of progression we want to assess, how far they rate. So their primary target is the cardiovascular, the primary target is the kidney, and the cardiovascular outcome is the primary and the kidney is the secondary. Here the primary target is the kidney and the secondary outcome is the heart. So, this is the Fidelio pooled analysis. The entire area is the pooled analysis. So, they are more or less comparable. The HbA1c, the male, female, systolic, diastolic blood pressure and so on. The trial eGFR starting is the Figaro, they have a little higher GFR than Fidelio DKD. So they are almost everyone is on either ACE inhibitor or ARB, and they are also ACE inhibitor ARB. They are almost 97.9% on the glucose lowering therapy. So they are basically type 2 diabetes, CKD on optimized RAS inhibition. Potassium is less than 4.8, and then we start with this Finrenon, and the key outcome is the CB composite outcome. And then we have to see whether there is a stable GFR more than 57% in the composite kidney outcome. So what we have found actually after this all these studies, there is a 14% relative risk reduction in the cardiovascular composite outcome, cardiovascular death, non-fatal MI, non-fatal stroke and heart failure. There is a significant reduction. In the kidney outcome, there is a 23% relative risk reduction, the kidney failure is reduced, ESKD is reduced, as well as EGFR reduction. And all these are benefit in spite of patients who are already on ACE inhibitor or an ARB. So USAR, this is a stable over period of up to 4 years. So ADA recommends that in people with CKD who has more than 300 milligram per gram, means these patients are albuminuric, clinical albuminuric, a reduction of 30% or greater in proteinuria is recommended to slow the progression. So you have to reduce the proteinuria to a significant degree. That's what is essential. So the objective of the fidelity study was the 7% reduction in stage 4, even patients who are on the stage 1 to 3 stage of CKD, GFR, there is a significant benefit because it is left to the midline. In stage 4 CKD, there are already severe patients. It crosses the middle line. Therefore, theoretically is not significant, but it shows the tendency towards the significant benefit. The overall benefit between 1 to stage 4, it shows a benefit. So Pinrenon demonstrated an overall cardiorenal benefit versus placebo in stage 1, 2 and 3. This is the benefit as well as in patients with stage 4 CKD. It consistently reduced the risk of sustained more than 57% EGFR decline and improvements in EGFR. The study profile of Pinrenon in patients with stage 4 CKD was generally consistent with that patients in the stage 3 and 4. So it reduces any adverse event is almost same as that of placebo. Acute kidney injury is not much. Systolic blood pressure, there is some reduction, there is no gynecomastia, no change in HbA1c. So the practical recommendation, we start with a patient who has got a serum potassium less than 5, usually 4.8. It will start with 10 milligram or 20 milligram. If the EGFR more than 60, we start with the 20 milligram. If it is less than 60, then we give 10 milligram. We monitor usually potassium. If it is more than 5.5, we temporarily stop. If it is less than 5.5, we continue the drug. If it is less than 4.8, we double the dose to 20 milligram. So basically dose is between 10 to 20 milligram. You have to monitor the patient every month, and if it should be less than 4.8 is the standard. You can continue the dose up to 5.5 milliequivalent per potassium. So compared to other studies like aliskiren ACE inhibitor, it was a significant, it was a lack of efficacy. The ACE inhibitor or ARB combination on target as well as the VA nephron D study, this is a lack of efficacy. Kidney and the CV outcome fidelity study, it shows the big benefit, and the AMBER study shows the efficacy not studied. So in summary, with diabetes patients with CKD has a high risk of heart and kidney outcome, and Pinrenon targets MR overactivation and slows heart and kidney disease progression. It slows the kidney benefit across a broad patient population and has demonstrated good safety and profile. So the key points are individuals with diabetes are tenfold more likely to progress to ESRD than those without diabetes. Early stage CKD management is often missed. However, if managed appropriately, its progression can be slowed or halted. Despite RAS blockage and SGLT2 inhibitor, patients are at risk of CKD progression. That's what I said, the residual effect. If you show the curve of the EGFR decline over time, even in all the studies with the SGLT2 inhibitor or this RAS blockage, it goes up. It is not stable over time. If you start with the creatinine of 2, any drug or combination of drugs, the creatinine does not remain at 2. It goes up with time. The MR overactivation, which contributes to inflammation and fibrosis, is a potential treatment target, is a novel non-steroidal MRA, is effective option for CV and kidney protection, and is slowed down consistent with the cardiovascular benefit as well as kidney benefit. Thank you. We'll be having a question answer. Yeah. After the Dr. Leela talks about the cardiac protection.
Good afternoon, everybody. My regards to the chair, Dr. Pahadi. And you have heard about everything about the non-steroidal MRA in my previous 2 talks. So I'll show you how do we use them in clinical practice. Can I have the slides first? Okay. So this is a first patient who is 56-year-old male, diabetic for 13 years, CKD for 5 years, HbA1c above target, blood pressure not controlled. He is hypertension, obese, and GFR is 46.6. UACR is macroalbuminuria, potassium is 4. He is on beta blockers, RAS inhibitors, diuretics, SGLT2, sulfonylureas, and biguanides. So if you see that grid, or which Dr. Pahadi emphasized on, so it's very important that he falls in stage grade 3 CKD, and because of the severe or macroalbuminuria, he is a very high risk patient. So are we doing good to him, or something else can be done to stop his cardiorenal progression? So as he said that the non-steroidal MRA is one of the 3 pillars in patients with diabetes and CKD for treatment, along with RAS inhibitors and SGLT2 inhibitors. Of course, they all come with control of blood pressure, glycemia, lipid control, smoking cessations, and proper nutrition and regular exercises. And if you see the fidelity pool trial, they showed that irrespective of the SGLT2 inhibitors intake, the patients were on SGLT2 or not on SGLT2, because only 7% of the patients were on SGLT2 inhibitors in the fidelity pool study, that macroalbuminuria or UACR reduced in both the patients irrespective of the use of SGLT2. Now, if you could start this non-steroidal MRA in type 2 diabetes and CKD at the age of 50, you could give the patient a 5.2 years extra life of not increasing his or doubling his serum creatinine, not progressing to end-stage kidney disease, and a 3.8 years of life, which is which would be less of cardiovascular endpoints. And there will be incremental benefit if you start early in the age. And this study, which showed that if combined SGLT2, GLP-1 receptor agonist, and non-steroidal MRA in type 2 diabetes and macroalbuminuria, take any of the modalities, could be MACE, hospitalization for heart failure, cardiovascular death, CKD progression, or all-cause mortality. They were lowest if the combination of these 3 medications of SGLT2, GLP-1 receptor agonist, and non-steroidal MRA were given to the patients. So coming to our patient, this patient would be benefited definitely if he is added with Findrinone, and Findrinone should be added to the patient. The starting dose, as Dr. Pahadi mentioned, that it's if the GFR is below 60, as in our patient it was, it should be started on 10 milligrams. Fidelity trial. And in the Fidelity trial, all-cause mortality, cardiovascular mortality were lower in patients who received Findrinon, and even sudden cardiac death were lower in patients who were intended to treat in the Fidelity trial. In Fidelity trial, around 10% of the patients showed left ventricular hypertrophy, and if you could see that the composite cardiac outcome were reduced to a tune of 28% in these patients. The cardiovascular death, the non-fatal MI, the non-fatal stroke, and the heart failure. Sorry, I have a bad throat, please bear with me. And if you see the hospitalization for heart failure were reduced to a tune of 66% in these patients who had left ventricular hypertrophy at the baseline. And about 90% of the patients who did not have left ventricular hypertrophy, the composite cardio outcome were thank you, sir. So there was 11% reduction in composite cardiovascular outcome in patients who were not having left ventricular hypertrophy, and there were 14% reduction in heart failure hospitalization patients who did not have left ventricular hypertrophy. So left ventricular hypertrophy, patients who had left ventricular hypertrophy at the baseline did better with Findrinon vis-a-vis patient who did not have left ventricular hypertrophy. So adding a Findrinon to this lady would definitely help her protecting from her cardiovascular outcomes which she foresees in her futures. So all the guidelines, the AHA, the ESC, the ESH, the AAC, all guidelines, including the KDIGO guidelines, they all included Findrinon as a treatment of choice and as a class 1A recommendation. The list is being the KDIGO, which is recommending Findrinon to be used in diabetic CKD as a class 2A indication. So what if my patient has complex comorbidities and co-medications? This Findrinon was shown consistent benefit of cardiovascular and renal benefits across all spectrum of diabetes and CKD, even with high HbA1c, has a longer duration of diabetes, elderly patients on insulin, on SGLT2, GLP-1 receptor agonist, and patients even who had atherosclerotic cardiovascular disease, as shown in the Fidelity pool trial that 46% patients had some form of cardiovascular disease. So these are the takeaway points. The 5 Phis of Findrinon, that it should be started if the potassium is below 5, should withhold the treatment if the potassium goes above 5.5, should check for the cause of hyperkalemia, and once hyperkalemia is corrected, one should reinstitute rather than just forget that Findrinon is not suitable for this patient. So one should check the reasons for hyperkalemia, and once hyperkalemia is corrected, one should again restart the medicine. Can be given safely up to a GFR of 25, but can be continued up to a GFR of 15, and it reduces the progression to end-stage kidney disease in patients with diabetes and CKD by 1/5%. That is, 1 out of 5 patients would have halted progression to end-stage kidney disease, and similarly, the progression of or the formation of heart failure hospitalization is reduced by 20% in these patients who receives Findrinon on top of diabetes and CKD. So I end my talk here, and thank you very much for bearing with my voice, and again appreciate ABCDCon in allowing me to talk and Bayer to sponsor this session. Thank you very much, and we take questions and answers.
I think if you have any questions, we can start with the questions and answers. Any questions? Yeah.
For EGFR estimation, suppose myself is 67 years, 50 kg weight, 1.2 creatinine.
Yes.
One is 80 kg weight and same age. How we calculate this?
No, EGFR, I mean calculation, whatever EPI calculation, it comes with the age and the creatinine measurement. It does not come with the body weight. Body weight does not figure in that. So you don't have to calculate regarding the body weight.
But risk is more or his?
Risk is more, but that is not dependent on GFR. That is depending on other factors. There are other equations as well. There is another equation called kidney failure risk equation. I mean, I have not discussed with that. That is included in the CKD guideline, KDIGO guideline 2024. They have, they have published the CKD guideline management. In that, they have included the term called kidney failure risk equation. There is another equation that include age, sex, body weight, everything is there. So in that you have a, who are the patients who has got a higher kidney failure risk. You are the patient who has a high body weight has a higher kidney failure risk. That's correct. But the EGFR remains, is not dependent on body weight. Yes.
Thank you, sir.
With permission of Dr. Pahari, I just want to add, because you had rightly pointed out a very important concern. And you were actually, I think, wanting to refer that Cockcroft-Gault formula. So when we talk about Cockcroft-Gault formula, the weight is an important part. And yes, if you calculate the EGFR by Cockcroft-Gault formula in this weight, it will be reducing, and it may be not that EGFR calculated by the CKD EPI. The thing is that we have to go by the level, drug level. And even if we talk about Finrenon, all those calculation EGFR done by the CKD EPI formula. So you are safe. If you calculate it with EGFR via the CKD EPI formula, you are safe, medico-legally too. But when, again, there are certain drugs, just for an example and for an academic interest I want to mention, because imipenem cilastatin, if we do the dose calculation according to the EGFR calculation by the CKD EPI formula, we may land up into the wrong thing. Actually, if you go by the drug level of imipenem cilastatin, they are clear-cut, they had mentioned the EGFR should be measured by the Cockcroft-Gault formula. So that is the thing we need to understand, and that is the way how we should approach. For Fidelity or Figaro or any Finrenon studies, they had used EGFR calculation by CKD EPI formula only.
I think if you want to, anybody who wants elaboration, see there are a lot of other equations is there. So apart from equations, EPI equation, which is creatinine based, there are also cystatin C based equations are there. And nowadays most people want that if you have done both creatinine as well as cystatin C, you have an average of creatinine and cystatin C, and then you find out, because the patient who is obese, your elderly patient who is obese and the overweight, that cystatin C will be overestimated, because at the fat content that increases the EGFR. Whereas a lean body mass, patient who has lean body mass, the creatinine clearance will come down, because it depends on the muscle mass. Patient with the muscular mass, they have a high, so there are a lot of variabilities. In order to reduce the variability, nowadays people are asking for, if you have creatinine and EGFR by both creatinine clearance as well as the cystatin C, an average of these two, and that's more accurate. In any given critical situation, particularly acute kidney injury or patients with a drug overdose or patients are undergoing CRRT, continuous, because the patient is on dialysis for 24 hours, drug is dialyzed. So how to give the drug? If you have to do that, you have to measure the GFR, you have to collect the urine volume, and then UVIP, there is an equation, and then you find out the correct, actually, this is a correct estimation and not the just theoretical GFR or something like that.
Thank you, audience. So I will invite one more question. Why, I will explain later. One more question from audience, if any.
Sir, my question is regarding the use of Finrenon. Sir, what is in clinical practice, what is the actual EGFR or actual the level of USCR we will start Finrenon?
So, interesting question. So, if you need to have the GFR and the UACR calculated at a time, if your GFR is above 60 and you have macroalbuminuria, then you can start Finrenon. If you have a GFR above 60 and microalbuminuria, Finrenon is not recommended to be started in this patient. If the GFR is below 60 and whatever is the level of microalbuminuria, it has to have some level of albuminuria, then you can start Finrenon. So above 60 you should have macroalbuminuria to start Finrenon, and below 60 you can have microalbuminuria to start Finrenon. can be given up to a GFR of 20, 25. But if started above 25, can be continued up to a GFR of 15 if your potassiums are below 5.5. So that is all about the starting and...
No, there are a lot of other things too. I mean, this year, the CKD guideline, KDIGO has published the CKD guideline. What they say is, I'm talking about the SGLT2 inhibitor. Based on the DAPA-CKD and EMPA-kidney trial, they are now saying any stage of CKD, you start with the SGLT2, class 1A indication. And what they are saying, even if the GFR of 70, you still start it retards the progression, irrespective of degree of whether you have a proteinuria, non-proteinuria, any CKD, non-diabetic CKD, no proteinuria, still you give SGLT2 inhibitor, it benefits. Now the guidelines for Finrenon, see this is a one trial on this Finrenon. So this is the fidelity, all pooled analysis and so on. So now the guidelines, if you have to based on one research molecule, I mean study, then the guideline has to be based on what they did actually. They start with the lowest GFR is 25. You cannot say that I'll start with the GFR of 20. I mean, that's theoretically is a difficult thing. I mean, if you say that I'll start with the GFR of 15 and patients with the proteinuria, possibly you are correct. But then the guideline don't say that. But how come the guideline will come? Because there is only one study which says that the GFR you have to do below, I mean, we have given below, above 25. For SGLT2 inhibitor, for example, what they say, all the studies, the EMPA kidney study, it shows that it started with a GFR of as low as 20. Below 20, you have no guideline there because there is no trial data. And therefore, what now they say, even if you have started with the GFR of 20, you continue till the patient goes into dialysis and transplantation. And then the reason why they are saying so, you say that if you have started, the benefit, it is not anti-diabetic anymore, because if you have lost the kidney, you are not having a glycosuria, and therefore your sugar control is not done by the SGLT2 inhibitor. But you have the cardiac and the renal benefit, even in spite of the low GFR, and therefore SGLT2 you continue till the patient goes into dialysis or transplant. Yes.
Yeah, so at the take home, we can say the lower limit we should know that the rule of 5, as we had also explained there, the 25 VGFR, that lower cutoff we should understand, and the potassium value 5, that we need to remember. Because anything if we can do, we play with that two numbers, then it will come upon us and it will file a medical legal case against us. The other issue is that upper limit, as beautifully explained by Dr. Leela about when macroalbuminuria, the eGFR cutoff is a little bit upper, we can also take those patients. But even if the eGFR is normal 90, 96, 100, but there is microalbuminuria, rather macroalbuminuria, whether we should start Finrenon or not. So there comes our off-label use spectrum. So we can use, yes, those populations are not included in that particular trial. That does not mean our clinical decision making can prohibit to use them, because ultimately our goal is to provide patient better outcome in terms of kidney parameters. So there we can use, because already urine AC are elevated, and if it is true elevation of urine albumin creatinine ratio, then we need to prevent the further ongoing kidney damage. And that is why I think the SGLT2 inhibitors, RAS blockers and Finrenon, specifically from the MRS, we need to consider in that subset also.
So, sirs, can I conclude? Okay. So, I would request, sir, please, one second.
Yeah.
I would request Dr. T.N. Banerjee and Dr. Sujan Sarkar to please felicitate our three sirs. And after this felicitation, I know all of you are famished. Just a small program of prize and felicitation for the PGTs and the felicitation of the jury board who have selected the PGT winners in the paper presentation. And then we will have a lunch break after a short inauguration of ABCDCon, 10th ABCDCon.
Requesting you all for a big round of applause because of the nice discussions. We had just thought about many things, so a big round of applause for our panel discussions member. Thank you so much.
So, Dr. Arnab Banerjee, I would request the PGTs to come forward and our jury members of the paper presentation for felicitation.
Hello. So I would like to announce the name of the respected juries for taking all the pain and conducting the session of paper presentations of the PGTs. May I request Dr. Aditya Prasad Sarkar sir to please come on the stage. Dr. Abhijit Das sir, Dr. Dinabandhu Naga sir, and Dr. Rupam Ta sir. And may I request our secretary, Dr. Subhama Chatterjee sir, to please felicitate these dignitaries. First, second, third.
I would request audience to give a big round of applause. Audience, please make some sound. Thank you.
Now I would call upon the names of PGTs who have participated with their paper presentation, and I will ask each one to come one by one. Dr. Sunil Roy De. Arnab, please come on the stage and help Dr. Subhama sir. No. Participants. Dr. Abhirup Nag. Dr. Abhirup Nag, please come. Next, Dr. Sukumar Maji. Dr. Rana Barik, Dr. Aritro Mahapatro, Dr. Somik Sarkar, Dr. Swati, Dr. Ritun Sarkar, Dr. Indrani Chaudhary, Dr. Nivedita Ghatak, Dr. Anvesha Mandal, and lastly, Dr. Joni Mandal. Sukumar Maji, please come on the dais and accept your participation certificate. And PGTs, don't forget to collect your delegate certification also. We will announce the time. It will be probably in the evening, along with other delegates. So now it's time for the winners. After thorough evaluation by our jury panels, the third prize goes to Dr. Aritro Mahapatro, and his title of paper presentation was Clinico-Radiological Findings of DPLD. Please, Aritro, come on the stage. Hey. Second prize goes to Dr. Nivedita Ghatak. Her talk was Apla syndrome secondary to SLE in disguise of CVA in a young patient. Please, a big round of applause for young PGTs presenting their paper on such a... Okay, on behalf of Nivedita, if someone else wants to accept his award, sir, please, sir. Dr. Naga, sir, please, thank you. And now the most awaited moments for the PGTs. The first prize goes to Dr. Indrani Chaudhary.
So some noise for that, please audience. Make some noise, give a big round of applause for her.
Once again.
So give a big round of applause for the winners.
Once again, thank you all the jury panels and the delegates who have presented their paper, and hope that this legacy will continue in coming ABCDCon also. Thank you. We will move on to our next program.
So we are moving to our next stage of program. That is, before inauguration, I have an announcement to make, and that's a sad one, that one of our senior most physicians in Bardhaman, Shamul kothay oটা daw? Dr. Ashish Ranjan Banerjee is not among us anymore. He passed away for his heavenly abode a few weeks ago. He was, till his active practicing life, he was with Association of Physicians of Bardhaman and the formation of ABCD, and this and this photograph, he has last came to ABCDCon the year before last, that is the after COVID, the ABCDCon we have performed. He was one of the chairpersons, and this is one of the photographs of him is with us. And I will request everyone to stand up and for condolence for 1 minute. I will count. We are starting. Respected audience and dignitaries, you can sit down now. And I will request, inauguration. I will request our President, Dr. Subroto Bhattacharya sir, to formally inaugurate 10th ABCDCon, please. And all of our, I will request all of our organizing committee members as well as other dignitaries to please come forward to light the lamp. Please come. Please come, sir. Professor Banerjee, sir, I can see you. Please come, sir, for the inauguration. It will be a memorable moment for us. চালিয়ে দাও অল্প করে ব্যাকগ্রাউন্ড
Thank you, sir.
So, as because we are running slightly out of time and we have a scheduled lunch break and we have to shorten that, we are going for a short lunch break of 20 minutes and after that our post-lunch sessions will start. And there are many exciting sessions, 6-7 sessions are there. So please, everyone, I would request to go for the lunch. But the time is 20 minutes, please try to follow that.
and Dr. Snigdhendu Ghosh sir to take the chair and please start the next sessions.
Good afternoon. I welcome all to this hall after post-lunch session. Now we will have a very interesting discussion, and our speaker is none other than Professor Samar Banerjee. And he does not need any introduction. He is known to all over Eastern India. Sir, please. Sir, please.
Thank you, ABCD. Am I audible? Hello? Yes, sir. Thanks to ABCD, I have come several times here in the ABCD program for giving lectures. This time I feel honored. I am more honored because my very close and near classmate, Professor Arun Das, cardiologist, have to listen to my lecture sitting in the front row. I was expecting Dr. Tushar Motopal. He is also a classmate, but probably he is busy with some other job. He will arrive later on. I am going to start a very basic thing, and that the topic is harmonizing diabetes care with insulin co-formulation. Let me clear what is co-formulation. It is not a mixture of two insulins. Two insulin are kept in the same solution. When we mix like short-acting insulin and intermediate insulin, there is some reaction, but they remain separate but in the same solution, and they are absorbed also separately, and their pharmacodynamics are also separate. Not a single one affect the other one. Diabetes picture diabetes picture a little bit for the South city. 90 million people with type 2 diabetes we are going to have in our part of the country, and diabetes in India, the incidence is 101 million people with diabetes and 136 million people with pre-diabetes has been detected by R.A. Manjana. She is the daughter of V. Mohan from Chennai, very close to me, and this is the 2023 report. 101 million people, which will be added by 136 million people. So huge. Now the incidence is more or less more than 10 to 20%. But the problem is, for coronary artery disease, patient will immediately go to doctor, follow the advices regularly, because there is agonizing pain and also the threat of sudden death. Diabetes do not give any pain itself and does not kill, it only kills silently. So the compliance rate is very poor. And individuals with type 2 in India have uncontrolled glycemia, 8 out of 10. A1C target is below 7 in cases of younger group, elderly, frail, renal failure, gross coronary artery disease, neuropathy, those who have chances of developing frequent hypo, then we keep above 7.5, even above 8.5. 3 out of 10 individuals with diabetes are being managed with insulin only. I am not going to tell that you give insulin to all. There is no paper which has supported that insulin is better than oral agent in any efficacy. But when oral do not work, insulin will definitely work. So in our country, a huge number of patients, they do not get insulin, though they actually require insulin for 2 reasons. One is resistance from the patient and also mental resistance of the clinician. Develop diabetes at a younger age. What is about the Asian phenotype? Progress faster from stages pre-diabetes to frank diabetes. High level of abdominal fat. This is not the so-called huge tummy, we are more calculating the intra-abdominal fat. Increased insulin resistance even at low level of body mass index, beta cell dysfunction occurs quite early and rapidly. And I am getting type 2 diabetes even at the age of 11 or 12 also. So all children do not think that they are only type 1 diabetes. And on an average picture, fasting 172, PP 253, A1C 8.56. This is the picture of the South Asian, and where postprandial peaks are much higher. And indices for holistic choice of insulin therapy. Why we need a better insulin? Lower hypoglycemia, mealtime flexibility. If you use some insulin, which should be taken at the fixed time within half an hour, those who are working and staying outside, they may not reach home. Convenience, simple regime, basal bolus, scientifically based insulin, but you will have to give 4 doses. That becomes practical in most of the cases. Convenience of device, if you give by insulin pen, very easy to take. Better quality of life, cost effectiveness and efficacy, and all that together, IDEG ASPA, which is available as Rhizodec, satisfies all the criteria. I am not going to in favor of company, but practically I always to start with Rhizodec, titrate with Rhizodec. Ultimately the need comes down when the glucose toxicity improves. Those who cannot afford at all, for them I start with the conventional insulin. This is about the ultra long acting degludec. This is about the aspart, the hexamers, and they do not interact in the solution. They remain separate, absorb separately and act differently. So this is about the aspart, the YOLO. They reach the peak within 2 hours. So if we take before the food, 15 minutes before food, for aspart 15 minutes, for conventional human insulin 30 minutes, for fast acting aspart it should be 5 to 10 minutes. Then at 2 hour postprandial, which is the topmost peak, is controlled. And the degludec, which is the long acting, it acts for 40 to 42 hours. They will take the rest of the sugar control. In some cases, even with one injection you can control. Say if you give before the maximum large meal, say before lunch, the aspart will lower the postprandial blood sugar, and the degludec will take care of the up to the before the next meal timing for more than 24 hours. But all the cases will not be of like this one, and some cases we will have to give twice a day. These are the different studies, SMART study we call. I am coming to the studies, and there are many round world evidences in favor of this. I am not going to the details of the paper, many papers. Efficient glycemic control with low risk of high data. Study was done, type 2 diabetes, scheduled to start treatment with the IDEG gas, and safety data confirmed, or severe hypoglycemia 3, 6, 12 months were calculated. Adverse effects and serious adverse effect and adverse drug reaction, causality, casualty, severity and outcome all were studied, and patients were given the IDEG gas to 1029 across 40 sites in India. You know, now according to Government of India, every molecule to be marketed must have an Indian trial. Assessment of change in A1C, fasting postprandial baseline 3, 6 and 12 months. Let me see what happened. 45% of the patient on insulin therapy were on basal insulin to oral antidiabetic, and 73% were on oral, 27% insulin. But with IDEG gas, after 6 months, what is the result? There is PPG reduction of 82.5 milligram %, fasting 50.4 and A1C by 1.8%. Of course, we always recommend to use oral agent with insulin. It will lower the dose of the insulin, so there will be less hypo, and many newer agents have got organ protective effect, which is not offered by insulin. Insulin only lowers the blood sugar. So cardioprotection, renal protection, which is offered by SGLT inhibitor and GLP-1 analogs, metformin, basic drug, should be always used. Confirmed hypo, first visits when the patient was on conventional insulin were 176, with IDEG gas after 12 months it came down to 11. Severe hypo, also it became 0 after 12 months. So incidence of hypo is very less because the long-acting insulin degludec has a very smooth peak, so there is no acute peak and no hypo. Simplicity in dosing regime, basal bolus regime, 3 short-acting, 1 long-acting, different titration schedule, persistent monitoring. For basal bolus, you will have to go for 4 tests a day, if not 5. Ide gas, similar reduction in A1C, less hypo, requires less dose, lesser dose, simple to administer. So patients with type 2 diabetes uncontrolled or basal insulin are divided into 2 groups. One group had glargine 100 units OD plus aspart plus oral antidiabetic. Another group was given the Idecasp with oral antidiabetic. Idecasp achieved similar improvement in fasting and A1C compared to basal bolus, 9% lower dose with Idecasp, fewer mean number of daily injection with Idecasp versus insulin glargine. Another trial, basal or premixed insulin once a day converted to Idecasp once or twice daily, basal premix, Idecasp twice daily or OD, basal bolus also converted to Idecasp as required. Switching needs to be individualized based on the patient situation. And study shows that there is definite improvement in the quality of the life. Change in diabetes therapy related quality of the life, willingness to continue treatment, preference for Idecasp. If I can manage with such a insulin which produces less hypo, where you can take the insulin dose with a variation of 2 to 3 hours 7. So if you are supposed to take by 9, you can reach 3 to 4 hours you can delay. Then the acceptance rate is very high, hypo incidence rate is very high, and overall safety data, nocturnal hypo is very dangerous because patient cannot notice, patient is found dead in bed. Daytime patient can notice and take steps to prevent it. Quality of life is determined by the number of injection and the side effects and also incidence of hypo. All these disturb the quality of the life. Switching to Idecasp associated with the improved quality of the life. Association of, Dhruvi Hasnani et al. From Mumbai, they also compared degludec insulin aspart with insulin glargine in insulin NEP patients. Result indicate that Idecasp was non-inferior to insulin glargine 300 units known as Trogio and therefore has potential utility as an initiator molecule. Both drugs adequately improved glycemic parameters with a low risk of hypo. These findings support expert panel recommendation suggesting Idecasp as a preferred choice for initiating insulin therapy in individuals with uncontrolled type 2 diabetes. The latest RSSJ guideline of which I was the president and I was in the guideline committee, they have also recommended these Idecasp as the insulin of first choice. This is a study by Kumar et al. In the study of Krishna Seshadri from Chennai, there is a significant increase in percentage point in range. Now you have heard of CGMS, continuous glucose monitoring system, a machine is attached to you, every 15 minutes blood sugar is being done. If blood sugar remains within the target, that means 70 to 180, we call in range. If beyond, we call it as beyond range. So, the significant increase in percentage of point in range, that is our target with the use of the molecule. This significant increase in percentage of point in range favors Idecasp before breakfast and before dinner meals. If patient is busy, he will not have to carry any insulin. Before leaving house, take insulin. Coming house, take insulin. Another Japanese study, post-dinner self-monitoring blood glucose favored Idecasp in comparison to glargine when 7-point SMBG profile were taken into account. These influence on post-dinner SMBG may be due to the fact that Idecasp was administered before the main meal in the evening. Rajiv Kobil, another of my good friend from Mumbai, in a survey of 247 patients study showed that Idecasp injection in different social situations were able to increase and decrease the dose with ease and benefit. If you are going to any marriage party during Ramadan etc., then just alteration of timing, taking the injection within 3 to 4 hours will also act. This survey points towards a positive attitude towards achieving glycemic control with iodine as PAR. Patient reported attitude, practice, satisfaction and quality of the life, and the study has assessed the duration of insulin, demographic information, diabetic status, missed insulin dose, ease of use, quality of life, weight gain, frequency of blood sugar monitoring, etc., etc. And they show that patient attitude, practice, satisfaction and quality of the life all improves with iodine aspar. Reported improved quality of life with a reduced peaks, 89.8%. This is the statement of the patient. Found it comfortable to inject IDECASP in different social situations, 86.7%, could manage their day-to-day activities better than initiating IDECASP. So there is also reduction in pill burden when you are taking this insulin with other tablets from 2, 3 or 4, the blood sugar is coming down, you can lower the number of the oral agents on those. Dosing convenience, you start with 10 units, don't go for higher dose. Gradually increase every week. If there is no problem, you can do on every third, fourth or even once a week if there is no problem, and increase by 2 units of the dose. Start with 10 units of the dose. If both fasting and PPs are higher, you go for 2 doses of insulin. But if on average, you can try it single dose and then you go on adding some oral agents. If above fasting plasma glucose target, that is more than 120, add 2 units to 10, if less, -2, if same, maintain the same dose. And you try to give before major meal if you give single dose, or if you take 2 doses before breakfast and before dinner. Cost effectiveness, the study has shown yearly total cost was lower with IDEC as compared to all treatment. They have compared with other insulin, but ultimately the cost which is incurred for the treatment of the hypo or failure of the treatment and development of organ complication, if you take together and you take the cost of the insulin, then it is appears to be much cheaper. The number needed to treat to being less than predefined individual treatment target was lower with IDEC. Another study, one Saudi Arabian study, for 5 years provided cost savings of around $13 million. It was mainly driven by the reduction of hypo events, which I just talked. So choice at insulin initiation, lower hypo, mealtime flexibility, simple regime, convenience of device, better quality of life, cost effectiveness and efficacy. And I just like to mention before you, the IDECAS is a really very much helpful for us as insulin. Many cases are controlled in 1 doses. Some cases require 2 doses. When you give 1 dose, you give before the large meal or when the postprandial blood is very high. If it is above lunch or breakfast, you give before that. Other cases give 2 doses. Titrate every 3rd or 4th day, 7th day. Increase by 2 units till you reach the fasting target of less than 120, A1C below 7, and this much I can say that these are helping the patients a lot, because many patients are controlled with 1 dose, and ultimately as there is improvement in glucotoxicity, the dose comes down and so the price barrier goes away. And I have shown, I know there is a mental block behind all of us to prescribe costly medicine. But my patient I have seen spend a lot for alcohol, spend a lot for their cosmetics, etc. But if you can convince, he will take, ultimately he will be benefited and price will come down, less hypo and less complication. I congratulate you for making my 10 books successful. This book is published this year, this is the 11th on gastrodiabetes, and hopefully I will publish the 12th book next year. Thank you for your patient hearing. Thank you again.
Thank you, Professor Omrani sir, for his excellent presentation. Now it is open for the audience to ask their queries.
question from audience side?
Hyperglycemia, we prefer the basal bolus regime. Sir, in that case, whether you suggest the IDES caps or conventional basal with bolus regime?
No, if the patient is in acute critical condition, there is wide fluctuation. In that case, you will have to give by basal bolus. Even sometimes you need intravenous insulin also, ketoacidosis, etc. To control come down, after 7 days you target for this one. But when there is wide fluctuation, I will not advise you to go for this insulin. In that case, basal bolus infusion. Infusion or subcutaneous?
Sir, in cases of OAD failure, when a patient comes in our OPD with OAD failure, we are choosing the insulin. In that case, we are conventionally uses the long-acting insulin, either U100 or U300. In that case, where is the justification or the IDEX is better than used glargine?
Degludec itself is the best basal insulin. It is not 100 glargine or 300. Its duration of action is more longer and its side effects are less also. Second point, by OAD failure, I will give you tips. If the fasting is say 180, postprandial is 250, mathematically you give glargine, 180 will come to 120, and if there is equal reduction, then from 280 it will come to 180, reach the target. But if the difference between fasting and PP is more than 100, say fasting 180, PP 450, when you reach fasting 120, PP will be at 350. Am I clear?
Yes, sir.
So you are not reaching the target. When the difference between fasting and postprandial more than 100, you must use the short-acting insulin, either in IDECS or separate one. Another hint I am giving, never use insulin alone without oral agent. My insulin book and oral antibiotic book I have mentioned should be always combined with the oral agent. I just told all the drugs, majority, show organ protection, lower insulin dose, less hypo. And between you and me, it is against the company. Insulin produces secondary high insulin resistance, produces systemic atherosclerosis. So we always want to avoid that. So try to lower the dose of insulin, but when you need, you will have to give insulin, but never alone, except in
inpatient.
I am not asking you a patient with sepsis, give him oral agent.
Thank you, sir.
Sir, another question is, sir, there is a co-formulation insulin. That is one is long-acting, another is short-acting insulin. But in case of long-acting insulin, basal insulin, there is a maximum dose is 0.5 international unit per kg per day. So if in case of this type of co-formulation insulin, is there any maximum dose of this co-formulation insulin?
Insulin is the only drug in the pharmacology book which has no higher doses. You will have to use according to the requirement. When there is gross beta cell failure or infection or insulin resistance, sometimes we use more than 100 units per day. This is a wrong concept. There is a higher ceiling. No ceiling for insulin. Oral tablets have got higher ceiling. Start with 0.2 units per kg, and every week by looking at the picture, fasting PP, you titrate the dose.
Actually, they are they are telling that is in case of basal insulin, they tell that there is a maximum high dose is that.
Company,
so in that
has told you wrongly. If you go through the books, you go my insulin books, insulin has no upper limit. During ketoacidosis, you might have to use 200, 300, 400. Whatever they need, you will have to give. But ultimately, when the glucose level is coming down, there is improvement in the glucotoxicity and lipotoxicity. So beta cell will regenerate, will secrete more insulin, and insulin resistance will also improve. So there will be more efficacy of the insulin.
Okay, so thank you.
So I think there are no more questions. With this, we end this session.
Thank you so much, sir, for the nice presentations. And now I would request Dr. T.N. Mukherjee, sir, and A.K. Mukherjee, sir, also. So felicitating our extreme speaker, Dr. Somar Mukherjee, sir. Somar Banerjee, sir, sorry.
Audience, please give a big round of applause. Make some noise also for the nice presentations we have just taught about. And moving towards the next session of the day, updates on diabetic retinopathy. For that, I am requesting Dr. Subroto Bhattacharya sir to take the chair. Our next sessions, update on diabetic retinopathy. For that, I am requesting Dr. T.N. Banerjee sir and Dr. Subroto Bhattacharya sir to take chair and initiate our next session on updates on diabetic retinopathy. Would request for a big round of applause for Dr. Somar Banerjee sir. So moving towards the next sessions, I am requesting Dr. T.N. Banerjee sir to take the chair and initiate the next sessions. Updates on diabetic retinopathy. Over to you, sir. Thank you.
Good evening. Good afternoon. At the outset, I'm thankful to Dr. Sumit Banerjee for accepting our invitation. And you know the epidemic of diabetology, but we have not discussed the epidemiology of diabetic retinopathy. Incidence of diabetic retinopathy is also as per with the kidney disease, diabetic kidney disease, cardiometabolic disease. The two incidence of diabetic retinopathy, according to WHO, is more than 35%. But Indian record show is 18 to 20%. So it's much less than what the WHO says. But the thing is that we are hardly recommending or referring the patients for evaluation of diabetic retinopathy to the ophthalmologist. You all know that this diabetic retinopathy is preventable, and if we can refer them early, then the eyes can be saved, the vision can be saved. It's a tragedy if the diabetic patient loses eyesight or vision very early. So with this, I will request Dr. Sumit Banerjee to come to the dais and give his deliberation.
And thank you for your excellent words, Darok. And I am grateful to all the members of the ABCD for giving me the invitation and sharing my thoughts. Especially I am grateful to my childhood friends and school friend, Dr. T.N. Banerjee, for inviting me. And this is a pleasure, really, I am feeling very pleased because this is the first time I am, at least in Bardhaman, attending one seminar which is multi-speciality. We usually arrange the seminars with belonging to our own specialty. So this is a very good venture. I think it will be more to come. I will waiting for that. So today I will be discussing about the second tragedy of the life. Why I am calling second tragedy? Because the first tragedy is definitely the loss of life. And second tragedy is definitely the loss of vision. Loss of vision with life is very, I think, a very painful sensation for any person. As you all know, diabetes is a multi-system disorder. It can affect any part of the body. And as it also affects all parts of the cornea, all parts of the eyeball, starting from anterior segment cornea, there is more incidence of glaucoma, more incidence of cataract formation and vitreous implantation, and along with retinopathy. So today my discussion will be limited to only this diabetic retinopathy. So I am not going into the details of incidence and prevalence because I think you know better than how many persons are suffering from diabetes. And but some highlights have been given. I have some Indian study that 12.5% population aged 40 and above. And there was an Indian multi-center cross-sectional study which indicates that 1 in 5 Indian population is suffering from diabetes. And among those, about 18%, it was also a multi-center study done by the Shankar Netralaya, Chennai. They have done a multi-center study showing that retinopathy incidence is around 18%. It is more severe, diabetic retinopathy is more severe in type 1 than type 2. And 5% of diabetic patients actually progress to vision-threatening diabetic retinopathy with loss of vision. And lastly, there is 0.4 million, 40 lakhs of people blind worldwide from diabetes. So what are the key challenges, what we are facing? It is mostly diabetic retinopathy, lack of awareness. Lack of awareness from physician and lack of awareness on part of the patient also. Because we have seen that this is retinopathy, the progresses because lot of delay of initiation of treatment, not due to inadequate treatment. So usually we delay in initiating the diagnosis and then starting the treatment. It is usually asymptomatic to begin with in 80% cases, and this is a coincidental finding. So your role as a medical specialist is very important. So you should ask each and every patient of diabetic to go to the ophthalmologist and to find out whether there is any evidence of retinopathy, because you know the retina is the only place when you can see the vessels directly without any invasive procedure. And it only produces symptom when it is advanced. In 20% cases like vision failure, metamorphosia. Metamorphosia means this distortion of image, and sometimes the patient will complain of floaters, and rarely they complain of loss of vision, that I will talk to you later on, due to macular edema or vitreous hemorrhage. And most of all, it has to be remembered that 90 to 90%, 95% cases, as Dr. Tarok was telling, that it is preventable. In 95% cases preventable, we take care earlier. So what are the risk factors? Risk factor, as you all know, duration of diabetes is very most important factor. But it is not the duration of diabetes only, but duration of diabetes after puberty. As if the patient suffering from diabetes at the age of 6, and another patient coming to you is suffering from diabetes from the age of 12. But at the age of 25, we will see the what the date of, not the initiation of the diabetes, but how far age from the age of onset from the puberty, after puberty. So how after puberty, what is the age of duration? So we consider the age of duration of diabetes considering the puberty stage. And good control of diabetes, it not only prevent but delays 75% in occurrence and 25% in reduction of progress. Every 10% decrease of HbA1c will reduce the progress of diabetes of 35 to 40%. The incidence is very high. And hypertension also. Hypertension, you know better, the hypertension, there are so many grades, type 1, type 2, type 3, so many, depending on the blood pressure level. But it has been seen the control, this is the most second morbidity of diabetic retinopathy. If the blood sugar is controlled in around 145 to 150 and 85 to 90 diastolic, the incidence of diabetic retinopathy is reduced. This is the study has been done, about 35 to 37% reduction. And proteinuria definitely increases the chances of diabetic retinopathy, along with pregnancy is another cause. In any case, the pregnancy causes, if there is a pregnancy, there is no diabetic retinopathy, and there is pregnancy, there is a 10% chance of patient developing diabetic retinopathy. And also 5% chance of diabetic early non-proliferative diabetic retinopathy to get proliferative diabetic retinopathy. But another good thing about this, that almost fewer reversible after the pregnancy is over. So smoking and another risk factor, hyperlipidemia, obesity, anemia, and cataract surgery can also increase. Any patient having cataract with diabetes, operation of any operation leads to some vasoactive substances, inflammation is there, so there is more chance of diabetic retinopathy. And there is a gender predilection, female is to male 4.3, and there is a genetic factor. Genetic factor, not especially for retinopathy, this is for the diabetic patient. And suggestion has been given that it may be autosomal recessive. So coming to the etiopathogenesis for diabetes. Diabetes is a, mostly we are considering now there's a microangiopathy and also it causes macroangiopathy. So we are ophthalmologists are more concerned about the microangiopathy. And these are the causes: capillaropathy, hematological changes, the deformity of the blood cell, increased stickiness of the platelet, leukocytosis, increased rouleau formation. That also lead to narrowing of the blood vessel, leading to microvascular occlusion, irregular blood flow, and decreased oxygenation. That means hypoxia to the retina. That leads to the fatal outcome, that is the neovascularization. You see, there is a blood-retinal barrier. I'm going just glimpses, just idea. The blood-retinal barrier composed of two parts. Inner blood-retinal barrier that is formed by the endothelium of the retinal capillaries, and the outer blood-retinal barrier. It is the retinal, this retinal pigment epithelium. What I am mentioning, because the blood-retinal barrier, inner and outer blood-retinal barrier, they have immense role in protecting the retina from the hyperosmotic agent so that they cannot enter into the retina. So if the blood-retinal barriers is broken from any cause, either both the blood-retinal barrier or any one of them, so there will be egression of fluid and egression of colloidal material, actually hyperosmolar material into the retina, causing exudation, lipid infiltration, and sometimes in advanced cases, the bleeding into the retina. So integration of the blood-retinal barrier is very important, which is broken in diabetes. So what are the problems? You know, there is a pericyte loss. It's 1:1 endothelial is to pericyte. What we know is the 1:1 ratio. But in case of diabetes, there is a loss of pericyte. So there is a weakening of the blood vessel wall. There is basement membrane thickening, and also capillary occlusion leading to ischemia, vascular shunting, and ultimately all roads leads to neovascularization. So this is the tight junction already mentioned. This is the endothelial. Left-hand side, you can see the tight junction is intact. And on the right-hand side, you can see that tight junction, endothelial junction is being disturbed. So in a nutshell, this is the etiopathology. There is leakage leakage, occlusion from the basement membrane thickening, endothelial cell changes, RBC changes, platelet stickiness, leading to retinal edema. And on the right-hand side, you can see the shunt formation due to hypoxia, and then that leads to release of vasoproliferative substances that lead to neovascularization in the retina and neovascularization of the iris. So what are the types? The types are non-proliferative, proliferative, and diabetic retinopathy, diabetic maculopathy is a separate entity. And number 4 is the advanced diabetic disease. This is called the vision-threatening diabetic retinopathy, which is about 5/200 vision in a patient, which is actually the potentially blinding for the patient. Now I will tell you one by one. So before I go into the pathology, I want to show you the normal, what the normal retina looks like. This is the normal retina looks like, the disc, the macula, and all the blood vessels. So now come to the mild NPDR, non-proliferative diabetic retinopathy. And the pathognomonic is a microaneurysm. And it is the hallmark of any diabetic retinopathy. And why it is formed? It is micro means it is very small, 10 micron to 100 micron in diameter. Cannot be visible with ophthalmoscope and other methods which we use during the diagnosis. This is the saccular dilatation of the blood vessels. Mostly, initially, it comes from the venous side because the venous walls are weaker than the artery, and then it comes from the capillary and then goes to the arterial side. The microaneurysm is a hallmark of diabetic retinopathy, mild NPDR. And this is the microaneurysm, what you see in fundus fluorescent angiography. So as I told you, that we cannot be able to pick up all the microaneurysm because if it is less than 30 to 40 micron, it is not visible ophthalmoscopically. We can see it by fundus fluorescent angiography. And on the right side, you can see the actual pathological picture. The moderate NPDR, when in advances, it is moderate NPDR, non-proliferative diabetic retinopathy. There is microaneurysm that is plus, that is mandatory. Along with that, there will be dot and blot hemorrhage, hard exudate, cotonal spots, but there is no sign of proliferative diabetic retinopathy. I will show you the slide. This is the cotonal spot. You can see the cotonal spot here. They are not well defined and in the superficial layer of the retina along with some of the hemorrhage. The cotonal spot are nothing but the microinfarct. And they are formed due to exoplasmic stasis in the nerve fiber layer. And the most important thing is that it is formed due to microinfarct, that is ischemia and hypoxia on that part of the retina. And on the other side, you can see the hard exudate. These are confluent and they come together. You see the soft exudate or cotonal spot, the side they are also called cytoid bodies. They are discrete, but in the hard exudate, they are in a cluster. They come in a cluster. This is formed due to leakage, and this is formed due to from the ischemia. So there is a basic difference between two. One is leakage due to egression of fluid and plasma from the blood vessel, and this is due to ischemia. And there are dot and blot hemorrhage. You see there are so many dot and hemorrhage. In the diffusely, usually it is spattered over the posterior pole. And now come to severe NPDR. Severe NPDR, this is the 4-to-1 rule. You see in diagnosis severe NPDR. So why we are differentiating? Because the treatment also differed. Up to that stage, which I previously discussed already, up to moderate NPDR, we do not do anything, treat the patient, we only observe the patient if there is no macular edema. Until there is macular edema, we do not treat the patient with mild NPDR or moderate NPDR. But this is the severe NPDR. This 4-to-1 rule means there will be hemorrhage in all the 4 quadrants of the retina. All the 4 quadrants of the retina, usually more than 20 in number. There will be venous bleeding in 2 quadrants and edema in at least 1 quadrant. So I will tell you what is venous bleeding. I will show you the picture of venous bleeding. This is the edema. This is the edema. You can see the collateral vessel. Actually, what is the edemas? Edemas intraretinal microvascular abnormality. They are the shunt vessel. There are some procedure to differentiate between edema and neovascularization that I will tell you later on. But this is the edema means there is severe hypoxia in that part of the retina. This is edema, parallel vessel. This connects the artery from vein. This is arteriovenous communication, precapillary. You can see both the picture, the straight lines, they are edema. They are parallel with each other. So these are venous bleeding. This is a rule 2. So I have told 4-to-1 rule. 4 means hemorrhage in all 4 quadrants. 2 means venous bleeding at least 2 quadrants. You see retina is divided into 4 quadrants. Superior temporal, superior nasal, inferior temporal and inferior nasal. So if there is venous bleeding in 2 quadrants, then it is severe non-proliferative diabetic retinopathy. And this one already discussed edema. So 4-to-1 means hemorrhage in 4 quadrants, 2 means venous bleeding in at least 2 quadrants, and 1 is edema, intraretinal microvascular abnormality in 1 quadrant. So it is severe. There is another category. This is we call very severe. Very severe means any 2 of the 4 which I have already discussed, either hemorrhage in 4 quadrant, edemas in 1 quadrant, or venous bleeding 2 quadrants. Any two together is called the very severe. Then what is the importance of very severe? If there is very severe NPDR, that it will progress to the PDR, proliferative diabetic retinopathy. In next 1 year, the chances are very high, 50%. And from severe to very severe, it is around about 15%. But very severe to PDR, there is a possibility that patient will go to PDR in coming 1 year. So in very severe NPDR and severe NPDR, we always treat. Oh, this is the, at a glance, I have given 4 types of retinopathy. This is mild, having only microaneurysm. So still there is some hemorrhage are there. Say this is the blood hemorrhage. And moderate NPDR, already discussed that you can see the hard exudates are there. Moderate NPDR means apart from microaneurysm, there should be either hard exudate or cotton wool spot or dot and blot hemorrhage. And this is severe NPDR. I already discussed 4-to-1 rule, hemorrhage, exudate, this is the venous bleeding, and I think this picture is not clear. There is edemas are there. This is clinically significant macular edema, diabetic edema. Why we call it clinically significant? Because this hampers the vision, and we have to treat this patient. This is called, popularly known as clinically significant macular edema. We do not treat all the cases, but if this is CSME, we must treat the patient. So next we are coming to PDR. What is the difference between PDR and NPDR? Only neovascularization. As already told, if there is no neovascularization, new vessel formation, this is non-proliferative diabetic retinopathy, and as the name goes, proliferation means not only vascular proliferation, it is a fibrovascular proliferation, and leads to, which causes called this PDR, proliferative diabetic retinopathy, the hallmark of which is neovascularization and vitreous or preretinal hemorrhage. I'll show you the picture. There is 2 things. This is NVE, neovascularization, and this is edema. Edema is already sun vessel, it is already present in the retina. It was there, it has dilated. But NVE means it was not there, it has proliferated. So there is basic difference. It lies very superficially and very filmy, and they are screw-like. They bleed easily. So this will bleed, but edema will never bleed, because they have a strong intima and all the vascular walls. But NVE, the neovascularization, they bleed because they are very fragile. Oh, this is another picture, showing the neovascularization of the disc. This is the neovascularization of disc. It has proliferated like this. But the main thing is that it is closed by gliosis. So usually what happens, as this neovascular, their lumen is very small. Sorry. They are either closed by gliosis or by any thrombus formation. But the distal part survives. And this is an example of bleeding in the vitreous. This is subhilar hemorrhage. This is the boat-shaped typical subhilar hemorrhage. And for all that together, this is NVD, neovascularization of the disc, NVE, neovascularization elsewhere. So I'll tell you what is the difference between the NVD and NVE. And this is preretinal hemorrhage. These are all finding of proliferative diabetic retinopathy, and this is the ultimate stage, tractional retinal detachment. So this is a picture I have taken from this is a OCT picture. This is the neovascularized front you see. You can see this front, which is actually creeping into the vitreous from the retina. This is the neovascularization. This is the OCT picture. So PDR, proliferative diabetic retinopathy, is again divided into low risk and high risk. So what is high risk? I'll go to tell you what is the high risk. So any NVD, neovascularization with vitreous hemorrhage, it is high risk PDR. And NVD, neovascularization of disc involving more than 1/4 of the disc, optic disc having diameter of 1,500 millimeter. So if it occupy 1/4 of the disc, then it is with vitreous hemorrhage or retinal hemorrhage. Any neovascularization disc with vitreous hemorrhage is called high risk. But if it is more than 1/4 of the disc diameter, then the topic of hemorrhage, vitreous hemorrhage or retinal hemorrhage does not come. So if it is more than 1/4, it is proliferative PDR with risk, PDR with high risk. And if it is less than 1/4, that should be vitreous hemorrhage to call it at the high risk PDR. And any NVE, that is neovascular and elsewhere, of half disc diameter, more than half disc diameter, but in that case, there must be vitreous hemorrhage or periretinal hemorrhage to be called it as high risk PDR. So what is high risk PDR? High risk PDR means that in 15 to 20% patient will develop VTDR, vision threatening diabetic retinopathy, in 6 months' time. Oh, and this is the same thing, this PDR. Okay. And last thing, the diabetic maculopathy, as I have told you, this is asymptomatic, except in case of diabetic maculopathy, that the patient is become symptomatic. So coming to the last point, management. Management is the strict control of blood sugar and good metabolic control. Not only control of you, this is better your domain, you know better than me. And keeping hemoglobin HbA1c below 7, lifestyle modification, timely eye checkup with dilated fundus examination, early detection, and now the anti-VEGF therapy, laser application, and surgery in advanced cases. Thank you.
Thanks, Dr. Sumit Banerjee, for his. Thanks, Dr. Sumit Banerjee, for his nice deliberation. Dr. Banerjee, come here.
Thank you so much, sir. Now I am requesting Dr. Shubhamay Chatterjee, sir, for felicitating our speaker and chairperson.
Very short. Sir, pregnancy-te diabetes নিয়ে বোধ হয় কি এটি যে gestational diabetes or normal pregnancy?
No, pregnancy, diabetes and pregnancy is a different subject. I am telling about the incidence of diabetic retinopathy with pregnancy.
Risk factor বলেন যেটা?
Risk factor is if the patient doesn't have any retinopathy, there is 10% chance of developing retinopathy. And if the patient has already non-proliferative diabetic retinopathy, there is 5% chance of from going to proliferative diabetic retinopathy. So there is increased chance of getting the retinopathy and increased chance of progress. But fortunately, it is regressible mostly.
আচ্ছা একটা ডায়াবেটিস পেশেন্ট যদি আসে আমার কাছে আমি তাকে কি আই চেক করতে বলবো না আগে ভেজালগুলো সবগুলো পরে
No, that's a very good question. Actually, the type 1 and type 2, you know. In type 1 diabetes, usually the patient present with symptom and they are diagnosed early. So in that case, we ask the patient to come after 5 years after the primary initial diagnosis. But in case of type 2 diabetes, as usually it is not, patient usually comes asymptomatic to the physician also, and it is by chance diagnosis. So it is mandatory that you refer all the type 2 patient immediately to ophthalmology because you are not sure how long the patient is suffering from diabetes.
আচ্ছা হাইপারটেনশন আর ডায়াবেটিসের মধ্যে যে রেটিনা চেঞ্জ হয় একটু কাইন্ডলি বলবেন একটু?
Pardon?
হাইপারটেনশন যে রেটিনা চেঞ্জ হয় আর ডায়াবেটিস রেটিনা মাঝে মাঝে এমসিকিউ তো আমরা গুলিয়ে ফেলি।
Hypertensive changes are mostly the vascular changes. That means precapillary arterioles, they are straightening, increased reflex, intimal thickening. So this is, and in diabetes we are mainly concerned about the capillary. So in hypertension, actually what happens, the arteries becomes thickened and they are pressing over the veins. So there are Salus sign, Gunn sign, there are so many signs are there. So this is actually bigger arteries and bigger arterioles are involved. But in diabetes, is microangiopathy, capillary, precapillary arteriole and postcapillary venules. Mainly the difference is this.
Thank you.
So this is the last question for this session, and if there is any other question,
yes, sir, one
Dr. Banerjee will be in the audience, so please discuss this with him personally.
Yes.
We are running very short
Sir,
of time.
In most of the cases, neither the physician nor the patient has the luxury to go for the dilated ophthalmoscopy examination. So in this scenario, how do you see the role of non-mydriatric artificial intelligence powered retinal screening for the diabetic retinopathy screening? Because most of the time, patient does not have luxury of getting an attendant or 3 to 4 hours to get a dilated ophthalmoscopy?
No, you see, as you were telling about the artificial intelligence, there are some cameras are now coming. So the cameras are very good. So they can pick up early diabetic changes. So if you don't have the luxury of asking the patient to go to ophthalmologist, then you have to be habituated to doing the ophthalmoscopy. So I think it is not very difficult to do. I know many physicians and diabetologists who do it personally. So that they get early diabetic retinopathy. Because it is a specialized domain. You cannot treat the diabetic retinopathy, but you are the mainstay of treatment. You are controlling the diabetes, you are controlling the metabolic defect and other things, and associated hypertension also. So you are the pivot person. We are just supporting you. So it is not possible for you to go for OCT and DFA to do it. So, but the artificial intelligence, you can utilize the camera. The fundus camera, handheld fundus camera is there. It is available. It is not that costly. So you can take the photograph of the patient if there is any early diabetic retinopathy. But as I've already told you, the early diabetic retinopathy, the microaneurysm is a hallmark. They are very small. That's the reason they are called micro. And if it is not more than 40 micron, they are not being detected even by ophthalmoscopy. So in camera also, or AI also, they can define the area of this vascular insufficiency. The camera is there. They can tell you this is the area of hypoxia. But they will not define the cause why there is hypoxia. But they can pick up the area of hypoxia and delineate the area also. But no. but microaneurysm. Now, what I have seen, I am practicing ophthalmology for almost 30 years, but it is a very pity I have seen that the patient are not also aware, but physicians don't take it otherwise. Most of the physicians refer, but there are still some physicians who do not refer the patient because the patient has come to diabetes for control of sugar. The patient is not aware of what is happening in the kidney, what is happening in the retina. Until and unless you make the patient aware or conscious that you may have some retinal problem, and the incidence is not less, 20%, 18 to 20% are suffering, all diabetic patients suffering from retinopathy, and that's also asymptomatic. So this is very important. You can use artificial intelligence, you can use a camera to delineate the area of hypoxia, but very difficult to isolate by locate this microaneurysm by camera. No, that is as far as the AIOC is, I am a member of AIOC, I say 60,000 ophthalmologists, they are already registered. No, I am not overburdened, I am actually...
Actually, sir...
No. Yeah, then you have to...
Yes, sir, actually why I asked this question, because I am already using AI software in my clinic since last 4 years. And recently, by one of my ICMR funded project has been accepted for publication. Very soon it will be in the public domain. And from that study, I have got 17.5% of diabetic retinopathy prevalence, and 15% of them were moderate diabetic retinopathy, and 2.5% were severe retinopathy. So that's why this use of AI is very important, because it does not need dilatation. It is very cheap and very user friendly.
No, that way you must be acquainted with just do ophthalmoscopy.
Yeah.
I think this is the
we
best
cannot
thing.
Treat.
We
can just screen.
You dilate the patient and see by ophthalmoscope. Yes. At least you can diagnose 50 to 60% patient. Because this is seeing the ophthalmoscopy is not very difficult. But in seeing the ophthalmoscopy, I think you can at least presume, or you can assume that it might be something wrong in the fundus. So then you not need to send every patient. So if there is any doubt in your mind that the fundus looking really different from others, so that patient you can refer. And diabetic retinopathy checkup is not time consuming. For us, it takes about 2 to 3 minutes.
But for patient, it takes 2 to 3 hours, sir. For
Because
dilatation.
now,
That is inconvenient.
that toll has to be taken. I have seen many patients who diffuse dilatation. But I always ask the patient, if you are not interested to check your retinopathy with dilatation, don't come to me. So I will not give any service because you people all sometimes send the patient to ophthalmologist whether there is any DR, diabetic retinopathy is there. The patient is very anxious. I am in a hurry. No, I will not apply any drop. I will go by car. I will drive my scooter. But that is the, I think that is the not should be done. Because every patient, if there is, you want to check diabetic retinopathy, you must see it with after dilatation. Without dilatation, it is not possible. Even don't take it otherwise.
No, I'm not taking it otherwise. That's
we
why
are
I
doing
asked you,
fundoscopy, undilated fundoscopy for 30 years. But still, we are not able to find out this something lesion is there in diabetic retinopathy. So in each and every diabetic patient, myself, I dilate the patient. And if the patient refuses, then my prescription, I write it down. Patient refused to dilate. But otherwise, he will tell to you that doctor has seen, but he has not found any diabetic retinopathy. It is not possible. Without dilatation, without proper examination, whether the patient have some microaneurysm or not. I am not talking about hard exudate, soft exudate, hemorrhage. It becomes easy for us to diagnose the patient.
Thank you, sir.
Thank you so much. Thank you so much, sir. So kindly give the felicitations to our speaker, Dr. Sumit Mukherjee sir, and our chairperson, Sumit Banerjee sir. Sumit Banerjee sir, and our chairperson.
A big round of applause, please. So make some sound, some big round of applause for the nice interactive session by Dr. Sumit Banerjee sir. And thank you, sir. Our next sessions, psychiatric manifestations and medical mimicking. And for that, I am requesting our chairperson, Dr. Sandipon Nayak and Dr. Snigdhendu Ghosh to take the chair and initiate the session. Psychiatric manifestations and medical mimicking. I am requesting Dr. Sandipon Nayak and Dr. Snigdhendu Ghosh to take the chair and initiate the session. Thank you, sir. Over to you, sir.
So good afternoon, everyone. So our topic is psychiatric manifestations and medical mimicking. So I will request Dr. Debjani Banerjee madam to kindly start the session. So it is an important topic in both in government setup and private setup. Many a time we confuse between both of them.
So you start. You need no introduction. You are well known to this part. So I hand over.
Thank you, sir. Thank you, chairpersons. And my heartfelt thanks to the organizers for inviting me here today. Because most of us here are practitioners, I'll deal with the topic as we see it in our clinics. আমি কিছু কেস বলবো যে কেসগুলো আমরা ক্লিনিক্সে পেয়েছি এবং আপনারাও পান so that কোথায় আমাদের কিভাবে ভাবতে হবে just to it's just food for thought, that's all. 74-year-old woman with known hypertension referred to psychiatrist because her daughter said that her mother sees small kittens and puppies all over her bed and the floor. When I asked the patient bollo যে এত বেড়াল আর কুকুরের বাচ্চা আমার ঘরে যে আমি হাঁটতে পারছি না। তো if you just see this, কি মনে হবে? Hallucinations, right? This is hallucinations only. But এই কেসে what are the things that you need to think? Number one, onset of the illness. This was an acute onset. একটা মানে most important হলো visual hallucinations. During our MD, all of us, it was put in our brain that visual hallucinations, think of organic causes. Because visual hallucinations, usually pure psychiatric illness hoy na, number one. Number two, onset at 74 years of age. Usually psychotic illnesses, age of onset will be 22 থেকে 30 years. যার কোনো previous history নেই, কোনো history of affective মানে mood disorder নেই, psychosis নেই, তার out of the blue 74 years এ একটা psychosis হচ্ছে. Third, পেশেন্টের কোনো অডিটরি কম্পোনেন্ট ছিল না। She could not hear the kittens and puppies. She could only see them. And কোনো most important, there is no previous psychiatric history. এই পেশেন্টটা when we investigated, এটা খুব কমন, দেখবেন আপনাদের চেম্বারেও বলে যে আমার উইকনেস লাগছিল বলে আমি অ্যান্টিহাইপারটেনসিভ বন্ধ করে দিয়েছি, as if antihypertensives causes weakness. So she had stopped for around 2 to 3 weeks before that. On MRI, there was an occipital infarct. Actually, visual cortex se jodi, because we have a neurologist with us, visual cortex, if there is a lesion, so there can be release hallucinations. Ar jeta hote pare, seta holo sometimes due to neuroplasticity, some other visual areas behave as higher optical centers. But though acute onset e seta hoy na, but most common holo release hallucinations. This was actually CVA presenting as psychosis. Eta first. Second, arekta case, again elderly female, 70-year-old female, who presented to the clinic with low mood, lethargy, hopelessness, muscle weakness. If you probe the patient, last 7 days, her family said that she had insomnia, she couldn't sleep. She complained that বাইরে থেকে লোকে আমাকে ডাকছে, যেটা বাড়ির কেউ শুনতে পাচ্ছে না. But she could hear people calling out for her from outside her home. She felt there was hair in her food. She felt there was insects in her bedclothes. She was picking them out. And there was urinary incontinence. And in the evening, her consciousness was getting altered. মানে দিনের বেলা একটু ভালো থাকতো, সন্ধ্যের পর থেকে ভুল বকাটা বাড়তো. Categorically, this is what family members will complain. If you take the history, usually এই পেশেন্টেরও ছিল history of nausea and vomiting. She is a compulsive she compulsively drinks water. This she has been doing for many years. This is not a recent thing. Her family members, they called up the physician, treating physician, and said the patient is low, saradin ঘুমাচ্ছে, শুয়ে থাকছে, কথা বলছে না, and the physician added escitalopram, and the patient was known hypertensive on olmesartan hydrochlorothiazide combination. Her serum sodium was 125. This is classical hyponatremia presenting with psychiatric symptoms. Actually, elderly people on diuretics, people who may drink water more than usual, people who are taking anti-epileptics, antidepressants, antipsychotics, they have a very high chances of developing hyponatremia. If the sodium falls, symptoms usually start if sodium falls below 130, but lower than 125, you may get severe symptoms. Nausea and vomiting is also a cause and effect of hyponatremia. Escitalopram is one SSRI which is notorious for even precipitating hyponatremia in patients on diuretics. So if we see data, all SSRIs may cause hyponatremia, but most research have found it with escitalopram. So if you give escitalopram, if you are giving diuretic, please keep hyponatremia in mind, and we usually educate the patient about it. Arekta case, এই কেসটা we learned during our MD, এটা খুব ইন্টারেস্টিং লেগেছিল তখন। 27-year-old woman with basic schooling, history of poor academic performance. There was no medical psychiatric background. Family history included a sibling who was diagnosed as psychosis, schizophrenia. Another was diagnosed with acute psychotic disorder and substance abuse, alcoholism. And there was a sister with mental retardation. Her disease started 4 months ago with depressive symptoms, mostly. Apathy, anhedonia, lack of energy, lack of interest in her surroundings, accompanied by social isolation, fatigability, slowing of speech, psychomotor slowing, distal tremor. Psychomotor slowing means slowness in thinking, slowness in movement, slowness in all activities. There were no psychotic symptoms. Kono hallucinations chilo na, delusions chilo na, aggression tokhono chilo na, weight loss chilo mild. And patient bollo that all these symptoms started when she had a conflict with her husband. এরকম একটা হিস্ট্রি নিয়ে পেশেন্ট এসেছিল, সিআইপিতে পরে ভর্তি হয়েছিল পেশেন্টটা। Initially diagnosis was depression. She was treated with SSRI for 3 months. She did not improve. She had a suicide attempt. And after suicide attempt, patient was admitted. During the first 3 days, she had a sudden change of behavior. Starting with mutism, she stopped speaking suddenly. And she had ataxia, gait alterations. Or gait alterations was diagnosed that time as conversion, dissociative symptoms, because she had a history of stress. And antipsychotics were added. Of course, that was also not effective, but what was significant was even low-dose antipsychotic, she developed severe EPS, extrapyramidal symptoms. And psychomotor slowing ta aro exacerbate kore gelo, tone increase kore gelo, tremors bere gelo, CT scan kora holo, CT scan there was some subcortical and cortical atrophy, which of course did not correspond to her 27 years of age. She developed slurred speech, involuntary movements, she couldn't swallow anymore, and neurologist was consulted. That time we did not have resident neurologists in CIP, so neurologists were consulted from outside, from the Government Medical College in Ranchi. Later she was diagnosed to have Wilson's disease. Wilson's disease is we all know, because you are all physicians here, is an autosomal recessive disorder. This finding was found that she had hyperintensity in basal ganglia in the T2 of MRI. But even her ceruloplasmin level was normal initially. And on slit lamp there was KF ring. Usually there is a history of jaundice, there is family history of neuropsychiatric manifestations, and very importantly, sensitivity to neuroleptics. Even low-dose antipsychotics can cause high amount of extrapyramidal symptoms in these patients. Approximately 30 to 40% of patients of Wilson's disease display psychiatric manifestations at the time of diagnosis. 30 to 40% is a huge number. And it is seen, research data says, when psychiatric symptoms precedes neurological or hepatic manifestations, the occurrence of the illness and the diagnosis is very long. Sometimes it takes more than 1 year for the diagnosis. This is so important because sometimes the neurological deficits may be irreversible, and this case may even be fatal. So this Wilson's disease is very commonly present with such symptoms. And because it is autosomal recessive, sometimes even history is very difficult to get because both parents need to have it for the patient to develop. So sometimes even family history is not very clear. Now I'll come to another patient. This is very common. This is something we see every day in our clinic. Male patient, 22 years of age, no family history, no personal history, brought with aggressive behavior, self-harm, episodic abnormal behavior, and depression. Patient said that he could feel his twin coming in and another presence. যেটাকে আমরা সাইকিয়াট্রিতে something like deja vu phenomenon. You feel another presence coming in, and these behaviors occur due to that twin. And the presence as psychosis. On history, 3 years prior to the onset of psychiatric symptoms, he had headaches and he had episodes of total amnesia. EEG was normal. Again, a patient history is so important because I think you must have understood this is temporal lobe epilepsy. Actually, temporal lobe epilepsy, the aggression, sometimes the patients, there are some cluster of symptoms. Commonest holo, এই যেটা বললাম, deja vu phenomenon. Second, butterflies in the stomach. Patients will feel that they have an abnormal feeling in the abdomen followed by this. So many patients feel कि এটা গ্যাস থেকে হচ্ছে because পেটে abnormal phenomena এর পরে এই aggressive behaviorটা হয়. There is sometimes if the seizure progresses, there is lip smacking, chewing movements, amnesia of the event followed by recovery. আর কেন আমরা epilepsy ভাববো এই কেসে? Every episode will be the same. The presentation will not change because ওর particular একটাই localized lesion থেকে localized area থেকে seizures হচ্ছে, কিন্তু পিওর সাইকিয়াট্রিতে যে অ্যাগ্রেশন হয় ওটা ইউজুয়ালি গোল ডিরেক্টেড হয়, মানে somebody is telling you something and you are aggressive. Here the aggression is non-goal directed. The patient has similar episodes, patient does not remember, and they're very short lasting episodes. So cases like this is usually temporal lobe epilepsy. Temporal lobe epilepsy is one of the commonest forms of epilepsy in adults, and it usually has associated mood symptoms like depression, sometimes even psychosis, and patients usually if anti-epileptics are added, patients have marked improvement. So my topic was medical mimics and what is the importance in this in our clinic. Medical mimics are nothing but medical conditions that present with symptoms resembling psychiatric disorders. A reverse tao hoy. Sometimes a psychotic disorder may present with physical and medical symptoms leading to confusion and difficulty in management and diagnosis. So it can run both ways. We miss and even physicians may miss. Initial misdiagnosis may lead to unnecessary treatment, prolonged therapy, increased hospitalization, more morbidity and mortality for the patients, and more cost. Which are the population where you will think ki it can be something else, especially older adults, patients with chronic medical illnesses, and individuals who have substance use disorders. Older adults because Alzheimer's ache jader Parkinson's disease ache, as sir will say, adding levodopa carbidopa combinations precipitates psychosis in so many patients with Parkinson's disease. So patients develop aggression after addition of the drug. So you need to think about that when treating Parkinson's disease. Delirium due to hyponatremia, due to drug-induced delirium, chronic medical illnesses like SLE, epilepsy, all these may present with some sort of a psychiatric symptom. And substance abuse, we all know about delirium tremens precipitated by alcohol withdrawal. of course, individuals who have previous history of psychiatric symptoms. Sometimes having a previous psychiatric history masks your medical illness because there is a preconceived idea that the patient is having a psychiatric disorder. And of course, immunocompromised patients because they may present in so many, a plethora of symptoms. How do we evaluate? First will be presentation. Is it an atypical presentation for a psychiatric disorder? Like, as we were told, uncommon things are uncommon. So common things are common. Is the medical condition or substance use, if there's a temporal relationship, like you add a drug and the patient develops the symptoms. Patient stops or takes a substance and the symptoms develop. So is there a temporal relationship with the drug or a history? Are the psychiatric symptoms better explained by a primary psychiatric disorder? Or is the psychiatric symptoms maybe a consequence of the disorder or treatment of the medical condition? So we need to take a complete medical and psychiatric history, history of present illness, review of current prescription. I remember in one of our state conferences, we had an entire topic based on please see previous prescriptions and please see what are the drugs the patient is currently taking. That will give you so much insight about it. Of course, physical and mental status examination, laboratory testing, and ruling out organic causes. Here, there is a role for collaborative care between physicians and psychiatrists so that we can help each other. This, I'll just end. One of the commonest referrals that we get. Patient comes with chest tightness, shortness of breath, visits cardiologist, ECG, TROP-T normal, psychiatric assessment follows presence with anxiety, diagnosed with generalized anxiety disorder, and identified as somatic symptoms, treat with anti-anxiety drugs, and the patient improves. But the problem is, before that, the patient would have visited some 7 cardiologists and 17 physicians before they will realize that they may need an anti-anxiety treatment. To just summarize my presentation, a thorough medication history, review of recent changes in treatment regimen, especially even small dose changes, understanding the patient's degenerative disease process, that will help in intervention and stabilization. And for clinicians who may be new to neuropsychiatric patients, that unintended behavioral or intended clinical response to medication may be changed by multiple variables. So if a CNS active agent is added, like antidepressants, like antipsychotics, like benzodiazepines, you need to see whether the patient develops some other symptoms. Having like polypharmacy, which is very, very common, multiple medications, and use of drugs in patients who have either hepatic or renal insufficiency, they may also present with complications. Thank you so much.
Thank you, Debjani, for your exhaustive presentation. You have presented 4 cases, 2 elderly, one with stroke of visual cortex giving rise to hallucination, second is hyponatremia, and 2 young
Wilson's
adults,
disease at
one
TLE.
is temporal lobe epilepsy, another is Wilson's disease. So in elderly patients with hallucination, dementia with Lewy body disease is a very
very, very common.
A very common example, and all extrapyramidal disorders ultimately will have psychiatric symptoms.
Yes.
But when patients with Parkinson-like illness present with early hallucination, then we have to consider dementia with Lewy bodies. And you have very well exemplified 4 cases. All are psychiatric symptoms of organic disorder. But we face problem for the reverse. When patient presents with non-epileptic seizure. Yes. So it is a very difficult condition to treat. So and patients are referred late in these cases. So now the session is open for discussion and any question?
Yes, sir. রিলেটেড নয় কিন্তু আমার জানা ইচ্ছে করছে একটা এমসিকিউ পড়েছিল স্মোকিং কি মেন্টাল ডিজঅর্ডারের মধ্যে পড়ে
নট বাই ক্যাটাগরি মানে আইসিডি কিংবা ডিএসএম
বইয়ে লেখা আছে তাতে আমি কনফিউজ হয়ে গেছি যে তাকে 2 মার্কস দিব না দিব না একটা এমসিকিউ পড়েছিল যে স্মোকিং মেন্টাল ডিজঅর্ডারে পড়ে আমি সব কেটে কেটে দিয়েছিলাম দেখুন আর 2-4 জন আমার টিচার প্রফেসর
স্যার একটা মেন্টাল ডিসঅর্ডারের জন্য তার আরো কিছু ক্রাইটেরিয়া লাগে তাই সোশ্যাল অকুপেশনাল ফাংশনিং ইমপেয়ার্ড হচ্ছে কিনা তার হেলথ ইমপেয়ার্ড হচ্ছে কিনা he or she wants to stop smoking or not he or she is unable to stop smoking or not
সে তো প্রথমে সে বিড়িকে প্রথমে খায় পরে 10 বছর বিড়িওকে খায় তখন তো মেন্টাল ডিসঅর্ডারে পড়বে
same with alcohol
Actually any substance
would be a mental disorder.
One thing, yesterday we had a very exhaustive discussion in ABCDCon at ITC Sonar. Now, for addiction, deep brain stimulation is a modality of treatment. Apart from epilepsy, Parkinson disorder, then movement disorders, now it has come in a big way of deep brain stimulation for addiction. Okay, so addiction may be a psychiatric disorder. Like in your obsessive compulsive disorder, now deep brain stimulation is a modality.
মানে আমরা খুবই মানে ক্যারিয়ার মেসেজ খুব ভালো পেয়েছি যা কেস প্রেজেন্টেশন হয়েছে আমি একটা অভিজ্ঞতার কথা বলছি একটা পেশেন্ট লিথিয়াম টক্সিসিটি হচ্ছে ওর লিথিয়াম লেভেল মোর দ্যান 2 মানে একটু সিভিয়ার টাইপের ছিল তারপর 1.5 হলো বাট স্টিল হি ইজ নট রেসপন্সিভ টু দি ট্রিটমেন্ট তারপর বই ঘেটে ঘেটে দেখলাম যে পেশেন্টটা মেবি দ্যাট নন এপিলেপটিক সিজার যেটা বললে she was suffering from non-epileptic seizure. Ultimately, কি হলো যায় না, maybe it's not a very rare condition. So non-epileptic seizure in a lithium toxicity is also very important. If lithium toxicity after recovery from the lithium level, lethal lithium level, if the patient does not respond, think about it. There is suffering from.
Sir, একটা ছোট্ট কথা বলছি. Usually conversion reaction কিংবা conversion reaction বা dissociative symptoms যদি আপনি temporally দেখেন তো this is not usually caused by depression, it is caused by bipolar disorder. মানে bipolar is more commonly associated with his conversion reaction rather than depression. Our patient usually has a history of suicide or suicide attempt. তাই lithium is the drug of choice for suicidality. তাই ইউজুয়ালি কিন্তু আপনি কনভার্সনে দেখবেন লিথিয়াম অ্যাড করাই হয় তাই আপনার মেসেজটি ইজ ভেরি ভেরি ইম্পর্টেন্ট দ্যাট লিথিয়াম টক্সিসিটি টু বি থট অ্যাবাউট থ্যাংক ইউ
I have one more comment.
হ্যাঁ স্যার
That as because our association, all physicians, delegates, most of them has practice of chronic metabolic diseases, and diabetes is one of the major part of it. This subclinical hypoglycemia, that also sometimes mimics psychiatric symptoms, and if you can tell 1 or 2 words about this, we will be enriched.
They present with episodes of lethargy, episodes of psychomotor retardation, episodes of clumsiness, sometimes altered sensation. But usually few episodes of clumsiness, drowsiness followed by recovery. হতে হতে ওরকম তাই অনেক সময় পিপল থিঙ্ক ইট ইজ ডিপ্রেশন ইটস ভেরি ইজি টু থিঙ্ক ইটস ডিপ্রেশন
আমার একটা অভিজ্ঞতার কথা বলছি বয়স্ক ভদ্রলোক নিয়ারলি 85 ইয়ার্স ও বারবার কি আসে যেতে ফিজিশিয়ানের কাছে যায় ডায়াবেটিস আছে ফর লং টাইম বাট যতবার যায় ও হেভি রেসপিরেটরি ডিস্ট্রেস হয় রেসপিরেটরি সাংঘাতিক তো আমার খুবই পরিচিত তো আমার চেম্বারে এসে দেখছি খুব জোর হাঁপানি হচ্ছে কিন্তু আমার মনে হলো না এটা কোনো সাইকিয়াট্রিক প্রবলেম আছে যাই ওকে বাড়িতে ঢুকিয়ে গিয়ে আমি আমাকে একটু খাও আমার কাছে তখন ইয়েও ছিল না স্টিক ছিল না খাই দেওয়ার পর তোর ইম্প্রুভমেন্টটা মানে আবার নর্মাল হয়ে গেলো সেই মানে আমার যা ইমপ্রেশন হলো যে এই ধরনের প্রেজেন্টেশন মে নট বি সো আনকমন ইন হাইপারগ্লাইসেমিয়া যেহেতু বললো তাই বললাম ইনসিডেন্সটা।
না না একদম একদম।
In my clinic, who has some kind of that neurosis-like symptoms, I have done a simple CBG and his or her blood sugar is 40 milligrams.
Yes.
And after taking some food, absolutely normal.
একদম। আর স্যার আরেকটা কথা জাস্ট ছোট্ট করে বলছি, আপনি ইফ ইউ টেক আ প্রিভিয়াস হিস্ট্রি, আপনি কিন্তু 90% আপনাকে বলবেই না সে লাস্ট 10 বছর কোন একটা সাইকিয়াট্রিক মেডিকেশন খাচ্ছে অ্যান্ড উইদাউট প্রেসক্রিপশন খাচ্ছে, বলবেও না আনলেস ইউ রিয়েলি প্রোব অ্যান্ড আস্ক হোয়াট এলস ইউর টেকিং, হোয়াট এলস ইউর টেকিং, হোয়াট এলস ইউর টেকিং। তো আপনি দেখবেন সে হয়তো ওলানজাপিন খাচ্ছে 2 মিলিগ্রাম, 5 মিলিগ্রাম খেয়েই যাচ্ছে, তো হঠাৎ স্টপ করে দেবে, তখন অন্যরকম প্রেজেন্টেশন হবে। আর পেশেন্টস হাইড ইট ইন্টেনশনালি, সো ওই পুলিশের মতন খোঁজ নেওয়াটা খুব ইম্পর্টেন্ট।
So I think we have very nice presentation by Dr. Debjani Banerjee ma'am, and now this is time for a short respect giving thing. So for that I am requesting Dr. B.D. Chatterjee sir to felicit our madam and our chairperson. Give a big round of applause for the very lovely presentations, which is very helpful, I think, for every one of us. So give a big round of applause, make some noise also. Thank you, sir. Once again, ma'am, lovely presentations. Thank you, ma'am. So I feel everyone just enjoy, not only enjoy the session, we learn a lot of things from the session. Moving toward the next session, I would request our chairperson, Dr. Rakesh Kumar sir and Dr. Miraj Mondal sir to take the chair and initiate the session ahead. The topic is translating guidelines recommendation to clinical practice with inclisiran. I am requesting Dr. Rakesh Kumar sir and Dr. Miraj Mondal sir to take the chair and initiate our next session.
Dr. Rakesh Kumar. I think he has gone outside. Sir, you please chair this session. Our academic head, Dr. T.N. Banerjee, will chair this session.
Over to you, sir.
Good evening. At the outset, I'd like to thank organizer for kind invitation. So it's a great privilege to have our sir, Professor Das Vishwas. And I can remember in my DM residency period, we have the opportunity to work with him the first time in medical college, and that time sir was in SSKM hospital. So our topic is the translating guideline recommendation to clinical practice with inclusion. So our respected sir, Dr. Arup Das Vishwas, please sir.
Thank you. Good afternoon, everyone. First of all, I would like to acknowledge the invitation, and I am grateful that you have invited me to Bardhaman to speak on something new. The topic is old, I mean the lipid profile, but the molecule I will be discussing is a bit new. Now, we were a few days ago very happy that we got a new world champion from our country in chess. So happy. But for some other reasons, India has now become famous. Dubious distinction of becoming famous. Champion in diabetes, champion in hypertension, champions in coronary artery disease. So these distinctions are not good. We don't want to be there. Now we know Indian subcontinent is running through the epidemic of coronary artery disease, and these maps have been taken from a very good publication by Anjana Mohan and others. They published it in Lancet, the ICMR in diabetes, India diabetes study. And here you will find that India is very much rich in lipids also. So if we look into the distribution of total cholesterol, LDL cholesterol, triglyceride, and low HDL, all the risk factors are present, and India is red, almost all of them, but here in this triglyceridemia group also, India becomes red if we take the urban population. So dyslipidemia is a major problem in our country. And in that study, the overview was found in 81%. We cannot dream of it, conceive of it. 81% are dyslipidemic, but this is mainly driven by low HDL cholesterol. Dyslipidemia and generalized abdominal obesity were significantly higher among urban compared with rural residents, but there is, with the lifestyle change is ongoing, the civilization is changing. Our rural population is also getting affected. And of the lipid parameters, only hypertriglyceridemia was significantly higher in males, while hypercholesterolemia, low HDL cholesterol, and high LDL cholesterol were significantly higher in females. And in case of lipid, we know that is the major risk factor for atherosclerosis. Only good thing about this is a modifiable risk factors. Lifestyle is there and multiple molecules of them come. And dietary modification, physical exercise, they remain important. But while you are conceiving of dyslipidemia in a person causing atherosclerosis, you know that it is not only the level of the lipid, but also duration of dyslipidemia is important. So we call it LDL level into time, the total plaque burden is equivalent. And plaque burden can be calculated from LDLC level and duration of exposure. So both magnitude and duration of LDLC exposure impact risk, and it is quantified. For every 1250 incremental increase in plaque burden is double. The risk of MI is double. So here to here, there is a log linear shift. And for every 1 millimole increase in LDLC, the risk of MI is 30% or higher. So all the guidelines, be it Western, be it Asian, be it Indian, everybody is going in favor of aggressive lowering, and lower the better dictum. So if we look into the CSI guideline, we are for very high risk people to recommend less than 55. So it often creates a confusion among the patients. They come with the report, they look that this is normal limits, and often stop the useful drug, very useful drug, statin, and say my lipid has become normal. So now again, what I have found in the doctors also, that they ask that high dose of statin, what was written by Dipankar or Arindam, it is stated by one general practitioner, this, you don't need these high doses. Your LDL has already come to LDL, 70. But in his case, maybe it was 55 the requirement of LDLC. But he from the report thinks that 130 is quite normal. So these guidelines are very important to read, for whom, how much LDLC should be there and how much statin should be given. So Lipid Association of India also goes for this type of stringent control for the very high risk, CV risk, less than 55. Similarly, ESC guideline for the very high risk population recommended that 55 should be the goal. And in some cases, even 40, 30, these may be the recommendation. So we have to define. And it is not only going to the level, it should be rapid, quick, and with strong medications. Our primary drug remains statin, particularly the high intensity statin. If the patient cannot tolerate that high intensity, we often go for the maximally tolerated and often combine it with ezetimibe. In some cases, like acute coronary syndrome, Indian guidelines say that start high-intensity statin ezetimibe from the very beginning. And in some cases, we go for phasic testing, and at 4 to 6 weeks interval, we test it and add one by one drug. So combination drug has become the mainstay of therapy, not only in the field of hypertension, not only in the field of diabetes, but also in the field of dyslipidemia. So one by one, we add it on statin, ezetimibe, maybe bempedoic acid, and it has seen that 3-drug combination, oral drugs I'm talking about, that is ezetimibe, statin, and bempedoic acid often gives a new molecule-like effect, that is reduction of LDL. There are papers on it to the extent of 75%. I'm going to these 3 oral drug combination before coming into the newer molecules. Why? Because in our poor country, everybody may not be able to offer evolocumab or newer injectable drugs like inclisiran, of which I'll be dealing with in this afternoon for a few minutes more. So for the very high risk, we know LDL has to be less than stable. For the extremely high risk, these have been defined. My time will not permit to go into definition of all these risk factors. But what is low risk, where there is no risk factor? But even then, this patient, if there is some amount of LDL rise, then may require a statin after, of course, lifestyle modification. But this group on the left-hand side, where we are talking about very high risk or extremely high risk, they require statin from the very good. Now, what about the statin intolerant patient? Maybe there are some tips and tricks about statin intolerance, what to do, lowering the dose, switching over to other drug, etc. But for the statin intolerant people also, these newer molecules like evolocumab, alirocumab, and inclisiran are very useful. And the intensity of lipid lowering you get with the moderate intensity statin 30%, high intensity 50%, PCSK9 inhibited, that is the newer molecule I was talking about, 60% reduction. With combination, this can be achieved from 65 to 85% reduction. Very, very effective and safe combination and safe reduction. So next 10 minutes or so, I'll be speaking on inclisiran, the new molecule, and it is in the field of siRNA, that is small interfering RNA. This acts almost like through the natural molecules that exist in our body, but this is a synthetic molecule, and this has got a passenger strand with its 3 antenna. It gets combined with the GalNAc into the, I'll be showing another diagram and explain there how that is attached to the liver cell. And there is a guide strand, and this small interfering double-stranded RNA, what does it do? It inhibits PCSK9 formation. And you know that PCSK9, if it gets attached to the LDL receptors, they are inhibited. They cannot take up cholesterol properly, and LDL level goes high because LDL is not taken up by the liver, not metabolized. So PCSK9 inhibition by any means, by antibody or by this inhibition of formation, the LDL receptors will be getting activated, they will be recirculating through the inside and outside surface of the liver, and they will take up the extra LDL and lower it down. So here you can have some idea about this. I will not go into the details of the picture again, but what you find, there is a injected inclisiran molecule. On the cell, there is a acetylglycoprotein receptor on the hepatocyte surface. By this previous GalNAc, that triantenne I showed you, it gets attached to here. Now this inclisiran is taken up as it gets to attach to the acetylglycoprotein receptor. Here it gets attached to RNA-induced silencing complex, which in short is known as the RISC. Now you get, there were two chains, one red, another blue. Here is the only blue chain because it has become already split. That gets now attached. You know there is always a RNA DNA in the nucleotide, nucleic acid coding. Depending upon, based upon the coding, they gets attached to PCSK9 mRNA. So PCSK9 mRNA is the responsible that comes out of the genes inside the nucleus, and they get converted into PCSK9 protein. This PCSK9 protein, as I was talking earlier, gets attached to this LDL receptor. If it gets attached to this receptor is inhibited, doesn't take up the LDLC. But if it is freed, then the LDLC receptors are very active. They can take avidly the LDL, and inside the cell, they are taken up. The LDL is degraded in the lysosome, whereas the LDL receptor comes back into the surface to do its job again. But PCSK9 inhibits that. So I was talking about the antibody that can prevent the PCSK9 in the circulation. Here I am talking about inside the cell, the inclisiran. I am repeating here that this, after gets this RISC inhibition, what happens? This PCSK9 mRNA, that complex that was formed with half of the inclisiran chain, that is now degraded and broken down. So it was trying to form PCSK9, but it itself gets broken down. So that is the mechanism. Because you may become interested how this molecule is acting. This is an interesting phenomenon to know about molecular biology of this thing. So what's the route of administration? This is subcutaneous. How frequent? First dose, then next first dose after 90 days, then every 6 months. So except the second dose that you are giving, every dose is at 6-month interval. So it is a dose, 2 doses every 1 year. That means it's a quite long-acting thing. So within 48 hours that goes inside the liver, it acts over there and remains there and acts for 6 months. So you have to give it 2 injections only in a year. So these are the advantages of this molecule. And this twice yearly molecule, this makes the patient very compliant. So we may not be able to take statin regularly or not in the full dose that is required. We often reduce the dose, we may skip, we may forget, we may dislike a dose, or with evolocumab, we may not like a twice or thrice weekly injection, so that becomes advantageous. And also, financially, with statin, if you compare, there is no here. It is much, much higher, much costlier. But if you compare with evolocumab, this becomes cheaper. Now, cost-efficacy relationship is a bit difficult thing. In our country, it becomes a very difficult thing because we have to purchase these drugs from the pocket. But if it's disbursed by the health authority or the insurance, the things become separate. According to the Western countries' calculation, this is cheaper because the patient's development of atherosclerosis is delayed, complications are delayed, hospitalization is delayed, treatment for intervention, surgery, these are not required or delayed. So it becomes relatively cheaper on the long run. But in our country, unless the patient is provided by the insurance or by the service giver, like the CGHS or our ESI, then it becomes a difficult thing, or insurance by the population. So again, I've told about all these things. There's from the frequency of dosing, extent of LDL-C reduction, and side effect profile. The inclisiran has got advantages, and the power is very important. Safety is also important. I'll show you the safety data also. Now, side effect is mainly a bit of reaction that may happen at the injection site, that is localized. That again is not that it is a compulsion to happen, may happen, redness and itching, etc. So why I am showing you this picture of Kalpurush or Orion? Because this molecule has been backed up by multiple Orion studies, series of Orion studies. I am not going into the details of the Orions, but these Orions have given us confidence about usage, the efficacy and safety in different populations, normal patients with hepatic dysfunction, patients with renal dysfunction, atherosclerosis, etc. Now we are waiting, results will be soon published, outcome data. That's the only weak point, that it is very powerful in lowering LDL to the extent of 50–60% that has been documented, with high intensity statin that can go up to 75 to 85% of reduction. I'll give you a short example of my own experience if you want, or time permits. But outcome, there I think that will be also come out to be positive. So it is inclisiran demonstrated effective and sustained reduction. This is very important. So just one-time efficacy is not everything. By 90 days, we find 52% reduction, and by 5–10 days, we find 54% reduction. And the pooled analysis of multiple patients showed that 87% of patients at any past baseline visit achieved the goal of less than 70, and 70% of patients by the end of 17 months keep it, that is, goal remains fixed. And not only the LDL-C reduction, total cholesterol reduction, non-HDL reduction, ApoB reduction. This particle is also important because this is associated with the bad particles, not the good one. So this is also an important thing. So going into the side effect profile, if you look into the analysis of the side effect between inclisiran and placebo, what is found that injection site reaction is the main thing. Other side effects are almost equal with placebo. The guidelines, the European, English, American, and our own Indian guidelines all keep it in their recommendation. They were all recommended it. I'm not talking about inclisiran specific molecule, but the whole group as PCSK9 inhibition or causing less of production may not be at the first outset, but maybe at the second or third step, this can be given. Now, in our country, we often have to do a trick that in ACS patient, when we want a very drastic and global reduction, powerful reduction and quick reduction in LDL-C, often 1 or 2 doses we can afford from the insurance level. So should I go with the case study or should I carry on? Okay. So thank you. I'll be quick. So patient was elderly, staying alone. She was 66 years old lady, had comorbidities of hypertension, diabetes, dyslipidemia, hypothyroidism. And Her risk factors thus were hypertension with diabetes ischemia. And regarding the complaint, she had mild chest pain, severe muscle cramp, myalgia, multivessel CAD, post-CABG status, residual ischemia was there, but her coronary angio didn't reveal much of problem except that there were minor lesions only after revascularization. But she was significantly symptomatic, severe osteoarthritis of the knees. So we have to look into a patient as a whole, because if we ask this patient to exercise, walk and walk, she cannot do it. Often we have to get for modified exercise, but even then we have to go for lifestyle modification otherwise and strong drugs. But she was not tolerating the good drug statin, which she was getting at the level of atorvastatin 20 milligrams. She was also having other drugs for diabetes, for hypertension, etc. Not going into those details. Her LDL-C was 110 despite atorvastatin 20. So any one of you, what should be the target LDL in this lady? I have given you the targets, but this very high risk patient, what should be the target? Anyone, quick. 55, yes. So by 20 we have got 110. More than 55% reduction is still wanted. So this patient was given injection inclisiran, which is available at only one molecule is available in our country, one brand. That's why I can take the name. It is available as injection Cybrava. So that was given because the dictum is earlier the better, lower the better, longer the better, and safer the better. So she was given this. She was happy that she was not interfering with her life, and her LDL was 64% reduction to 40%. Similarly, one of my similar patients, she was also diabetic with post-CABG status, having chest pain. On angio, after doing this, I found that I couldn't do anything by surgery again or this PDCA, etc. So again, in this case, I managed from the insurance people LDL reducing drug, inclisiran. She was tolerating statin. I combined both. So this can be given with or without statin. In statin intolerant, without statin, or maximally tolerated dose of statin. And even with statin, if the goal is not achieved, you combine them. So she again showed on the next month that it was 70% reduction. So this is a very effective drug, and it didn't have any problem with the side effect. So thank you for the patient hearing. Thank you for the extra time, chairpersons. So let you have a low lipid profile. Though I know that your lunch was not good regarding the LDL-C reduction. Thank you.
Thank you so much, sir, for your well-detailed discussion on molecular biology and guideline recommendations and clinical applications. So now the forum is open for question. I have one query. So besides the cost, if there is cost does not matter. So
yeah, cost matters.
Sir,
so no, I'm just giving you an idea about the cost. From the distributor, if you are not correcting, it is correcting from the first-hand source, it will be around 1,20,000. But from the distributor, if you get the distributor's price, it will be between 90,000 to 1 lakh. The company people can arrange it.
So I would like to know that if the cost is not the matter, so promising drug, so in near future, will it be applicable as a first-line drug, or is there will be any scope of giving this drug in ACS patient along with the statin 1 or 2 doses in coming future?
Yes,
so the cost
we may
is not
have
the
to
matter.
modify our situation that we are not continuing it throughout life. Initially, we are controlling the emergency, tackling the emergency by the injection, then switching over to 3 oral drug combination to achieve a good LDL control. This will be definitely a good drug, particularly for the very difficult to control dyslipidemia, though it is not yet recommended in the homozygous group. the familial dyslipidemia, they will be effective. And in those people who are not tolerating statin, this will be the drug of choice. Those people are not complying with your statin prescription, not taking it daily, or you are prescribing it, somebody is decreasing it. In those cases, if you want to give 2 injections, 2 shots and forget, this type. So modifications will then genuinely come. And one day will come, I was lecturing in the CSI regarding the future, in what is going to be in 2050. The whole thing will change. Any type of, this type of drugs will not exist. Okay.
Do they change the plaque character? This quality of plaque is changed with this inclisiran therapy? Because quality matters.
You are talking about the plaque,
this core of the
plaque activity?
Yeah.
Yeah. So if the plaque is vulnerable, then it's a large lipid core, soft, as probably you are talking about softness, and the lack of fibrous tissue. Fibrous tissue may be 1 layer thick or the lipid-rich core. They are more vulnerable by erosion or ulceration or rupture and lead to an event. So this fact is very important, whether a plaque is vulnerable or stable. Maybe somebody is having a 70% plaque, he is pulling through his life, he is happy with medication, is not going any far, intervention unwilling. In that case also, if it is not vulnerable, you can pull away with drug therapy. But in some cases, maybe a 25% plaque, he had an ACS, any event due to the rupture, erosion, ulceration, and liberation of the large lipid core and inviting a large red thrombus, that patient will go to Dipankar or Arindam.
What is the role of inclisiran in this? Do they change the quality of this plaque?
These plaques has to be changed by multiple mechanisms, not single mechanism. One is giving up smoking. Another is controlling diabetes, controlling inflammation from all sorts, lifestyle modification. And in the drug level, statins are very much important. They help in stabilizing the plaque.
Another thing is that in patients with pregnancy with familial hyperlipidemia, hypercholesteremia, or type 1, type 2, do they need this inclisiran for this inclisiran?
Inclisiran at present, the on-label indication is heterozygous familial dyslipidemia. You can give it, and really it is indicated. Suppose any one risk factor is there and heterozygous dyslipidemia is there, or there is increased lipoprotein A level for which we don't have any good drug at the present moment, inclisiran can be given.
Thank you.
Thank you, sir.
Any question?
তুই এদিকে আয়, তোর কোশ্চেন শুনে লম্বা বোঝা মুশকিল, এদিকে আয়।
Hypertension with dyslipidemia লিখছি, hypertension with dyslipidemia বলছি, dyslipidemia বলছি, তাতে কটা কম্পোনেন্ট বেশি বা কম হলে আমি এই dyslipidemia টার্মটা ইউজ করব।
আমি কোশ্চেনটা ঠিক শুনতে পাচ্ছি না, মেবি আই এম হ্যাভিং সাম প্রবলেম।
হাইপার আর কোলেস্টেরল বেশি আছে, ট্রাইগ্লিসাইড বেশি আছে, অথবা শুধু টিটা বেশি আছে, তো সেখানে হাইপারটেনশন আমরা যখন ডায়াগনোস লিখবো, হাইপারটেনশন উইথ ডিসলিপিডিমিয়া, হাইপারটেনশন উইথ যে কম্পোনেন্টে ইনক্রিজ হয়েছে সেটা লিখবো, কোনটা লিখবো?
আমি যতটুকু বুঝলাম একটা পেশেন্টের মাল্টিপল রিস্ক ফ্যাক্টর আছে, লাইক হাইপারটেনশন অ্যান্ড ডিসলিপিডিমিয়া। তো ট্রিটমেন্ট এখানে হবে টার্গেট অল দ্য রিস্ক ফ্যাক্টরস, নট দ্যাট। কোশ্চেন ওয়াজ নট দ্যাট।
স্যার কোশ্চেন করছে ডিসলিপিডিমিয়া কখন বলবো? Is it hypertriglyceridemia or high LDL or a low HDL? Question is when we will call dyslipidemia. When TG high or LDL high or HDL low. Question is like that.
Or combination.
ডিসলিপিডিমিয়া বলছি কেন?
When we will call. কখন বলবো dyslipidemia?
হ্যাঁ, এইখানেই সেটাই হচ্ছে কথা। It will depend upon the risk factor. আমরা যেমন হাইপারটেনশনে স্পেসিফিক্যালি বলে দিই যে 140/90, সেগুলোকেও এখন রিডিউস করা হচ্ছে, দ্যাট ইজ দ্য কাট অফ ভ্যালু। কিন্তু এগেন মনে রাখতে হবে যে বিপি কিন্তু একটা কন্টিনিউয়াস ডিজিট প্রসেস। 140/90 পেলাম মানে ওটা হলে নদীর এপার ওপার মানে ফাট করে ওখানে ডুবে গেলাম, ওখানে বেশ পাড়ে ছিলাম, তা নয় কিন্তু 1-2 মিলিমিটারে বিরাট কিছু তফাৎ হয় না। কিন্তু সেখানে বলা হচ্ছে অন এপিডেমিওলজিক্যাল গ্রাউন্ড, প্রথম দিকে যে এপিডেমিওলজিক্যাল গ্রাউন্ডগুলো হয়েছিল তাতে দেখা গেছিল যে 140-90 অবধি কমালে বেনিফিট পাওয়া যাচ্ছে। পরের এপিডেমিওলজিক্যাল স্টাডিগুলোতে দেখা যাচ্ছে যে 140-90 হলে ট্রিটমেন্ট শুরু করো, বাট ইউর গোল শুড বি not 140/90, in majority 130/80, not below 80, and on an average 120 to 130. In some cases, Chinese study te dekha geche je tader pressure ta aro komane jacche, those who are healthy can tolerate lowering 115 e jacche, tate result bhalo hocche। তার মানে কি এইগুলো সব হচ্ছে আর্টিফিশিয়াল বাউন্ডারি লাইন, এপিডেমিওলজিক্যাল ডেটা যতটা আসছে সেই অনুযায়ী আমি ঠিক করে নিয়েছি। সিমিলারলি ইন কেস অফ লিপিড প্রোফাইল অলসো আমি যেটা বলছি, কোলেস্টেরলটা মনে রাখতে হবে যে ইজ নট লাইক ব্লাড সুগার, যে আমার ব্লাড সুগার এতটার পরে নিচে কমে গেলে ক্ষতিতে চলে যাচ্ছে, পেশেন্টের নানা রকম সিমটম হচ্ছে, আরও এমার্জেন্সি হতে পারে। এলডিএল এর লেভেলটা কিন্তু সেরকম নয়, ইট ক্যান কিপ ইট ডাউন অ্যান্ড আউট, ইউ ক্যান টেক ইট অ্যাজ সামথিং এক্সক্রিটরি প্রোডাক্ট, যেটা এক্সট্রা পুরো বডির মেটাবলিজমের পর যেটা এক্সট্রা এলডিএল হলো সেইটা বেরিয়ে যাচ্ছে, দরকারি এলডিএলটা থেকে গেছে, সুতরাং ওটা যতটা পারা যায় বের করে দেওয়া যায়। ইট ক্যান বি থট অফ এজ এন এক্সক্রিটরি মেটেরিয়াল। সেজন্যে যার যত রিস্ক প্রোফাইল তার ততটা কমিয়ে লেভেলটা আমি বলছি যে এর ডিসলিপিডিমিয়া। কিন্তু যখন এপিডেমিওলজিক্যাল এই যে আইসিএমআর ইন্ডিয়া স্টাডিটা দেখালাম, ওরা কিন্তু ধরে নিয়েছে যে এতটার ওপরে হলে আমি ওগুলোকে লালে ফেলবো, এতটা হলে নীলে ফেলবো, এতটা হলে সবুজে ফেলবো। ঠিক আছে?
Thank you so much, sir, for the nice presentations. I think we are already going through shortage of time, so this is the time for felicitating our supreme speaker. So kind request Dr. Arnab Banerjee, sir, to felicit our speaker and chairperson. Highly informative session we had just gone through, Dr. Arup Das Vishas sir, and it's a wonderful session, I think. Audience, please give a big round of applause for that. Thank you, sir. Thank you. A big round of applause for our most senior doctors. So going towards the next sessions, I would request Dr. Debjani Banerjee ma'am and Dr. Pradeep Ganguly sir on stage to start the next session. Oh, sorry. Extremely sorry. Extremely sorry for the announcement. Our next sessions go with guidelines in HF patients with Fantastic Four. For that, I am requesting Dr. Satyajit Roy sir and Dr. Arnab Banerjee sir on stage to take the chair and initiate the session. Our next session, go with guidelines in HF patients with Fantastic Four.
Hello. Since Dr. Satyajit Roy has left the venue, I would request Dr. Pradeep Ganguly sir to chair with me in this session. So, the topic of this session is go with the guidelines in heart failure patients with Fantastic Four guidelines. We all know the heart failure, treating the heart failure patients with the 4 pillars, that is the ARNI, the beta blocker, and the MRA, and the SGLT2 inhibitors. So to discuss this topic, we have a vibrant speaker, Dr. Arindam Pandey. I would request Dr. Pandey to come over the stage. And Dr. Pandey is Senior Consultant, Department of Cardiology, excellent interventional cardiologist in the Medica Manipal Hospital. He's highly skilled and qualified in interventional cardiology with over 18 years of experience. And without much delay, I would request Dr. Pandey to deliver his lecture.
Thank you. Thank you, Dr. Arnob Banerjee. It's always a pleasure to come back to this conference. I think out of these 10 years, I have attended at least 5 times. And hope I'll come again next year. So thank you very much for inviting me. So today I'll be discussing on go with the guideline in heart failure patients. So heart failure, is it bad? So current evidence suggests heart failure, the mortality actually is higher than many of the cancers. So I'm just not bluffing. You can get this comparison. 1 in 4 patients who are having heart failure, particularly reduced ejection fraction, actually are readmitted within a span of 1 month. Very alarming data. About 1 in 2 patients who are actually having heart failure will get repeated admission, more than 1 admission within 6 months. And more than 1 patient out of 2 patients are going to die within a span of 5 years. And this data is not our data, this is the data across the globe. So 5-year mortality of 50% is higher than many of the cancer. I can give you example, colon cancer, breast cancer, prostate cancer. They all have mortality lesser than heart failure, reduced ejection fraction, thanks to the superb development in the field of chemotherapy and other therapies. So heart failure with reduced ejection fraction is not a good thing to have, because compared to other cancer, the prevalence of this particular disorder is far, far higher. Huge population are actually suffering from heart failure with reduced ejection fraction. I can give you an estimate, around 64.3 million people suffer from heart failure with reduced ejection fraction. So the actual burden of heart failure is way higher than projected burden. Why? Because lack of quality of our studies, particularly Indian study. You can see the available data suggests Chinese population, they have higher prevalence of heart failure, which is not actually the fact. This has happened because of a very poor quality of evidence and studies from India. Huge number of patients are actually suffering from heart failure, and India witnesses a huge heart failure hospitalization burden. Why? Because you can see the hospitalization after heart failure within a span of 1 year. It's very high, 30.2%, 1 year rehospitalization data. So many of them will get more than 1 admission. Around 6% of heart failure patients will get more than 1 hospitalization. Why hospitalization? I'm spending so much of time because there are n number of trials which has clearly shown that the number of hospitalization is directly proportionate with the mortality of the patient. So not a good thing to have heart failure hospitalization. 1 out of every 3 patients will readmit at least for within 1 year of diagnosis of heart failure with reduced ejection fraction. And increasing mortality in heart failure patient across the heart failure spectrum, because not only the reduced ejection fraction, now the preserved ejection fraction data suggests their heart failure hospitalization is also very high, and that will lead to higher mortality. So you can see how they are dying. In hospital mortality of around 10%, 9.7%, very alarming. So it's very common that a patient comes to the emergency of a hospital with severe significant shortness of breath. Out of these 10 patients, 1 patient will not leave the hospital because he will die. So very bad thing, And in our country, probably the 3-year mortality is 50%, which is staggeringly higher than rest of the world. So why is it so? Why our patients are dying earlier or in higher number compared to rest of the world? Probably because of lack of penetration of GDMT. What is GDMT? Guideline directed medical therapy. We do have evidence in the form of Trivandrum heart failure registry, which suggests that it was because of the inertia, not from the patient, but also from the physician's inertia to prescribe GDMT to the discharge certificate of heart failure hospitalized patient, and there is also significant patient-related inertia to continue the medicine. After taking few shots of Lasix, the shortness of breath goes up and the patient stops medicine. But it may not happen that that patient will return to the hospital every time. There is high possibility of something known as sudden cardiac death in these heart failure patients. So lack of GDMT is associated with higher risk of hospitalization and emergency department visit, which is a very, very known fact. And that is why the initiation and continuation of GDMT keeps the real-world heart failure with reduced ejection fraction patient alive and live longer. So patient not on GDMT in cohort trial, 29% increased risk of mortality compared to patient who were on GDMT. Very, very significant, encouraging data, I would say. So guideline-directed medical therapy is very critical in the overall management of this heart failure patient. And the key goal is to do up titration. Very important. You cannot just give a simple regime and forget about it. Heart failure needs constant up titration of the medicine, introduction of newer therapy, and evidence-based approach to the comorbidity. You should treat the diabetes, you should treat the hypertension, you should treat the obesity, because all of them will increase the mortality and chances of hospitalization of this heart failure patient. And GDMT is the foundation of heart failure care, and it has highest expected benefit, so it should be prioritized. So current available therapy for heart failure, if we see, at one point of time, 10 years back, 2013, there used to be 3 pillars. These are the game of pillars, 3 pillars of heart failure. ACE inhibitor, ARB, ARNI still was not on the board, beta blocker and MRA. Then came the paradigm heart failure trial, one of the landmark trial in heart failure, biggest trial of heart failure as of now. And then ARNI came into picture. You can see very significant 20% primary event rate reduction, which include both cardiovascular mortality and heart failure hospitalization. It also reduced the sudden cardiac death, recurrent hospitalization. So after that, all the guidelines in 2016, they included ARNI as a class 1 indicated molecule for all patients of heart failure reduced ejection fraction. Then up in 2023, we call the pillars, the number of pillars has gone up. Now there are 4 pillars. You can clearly see the SGLT2 inhibitors, which at one point of time came into the picture as an anti-diabetic molecule. And after proper evaluation and quality research, it was evident that it can be a wonderful molecule for treatment of heart failure as well. So including SGLT2 inhibitor, there are 4 pillars now. They are called Fantastic 4. So while there has been considerable success in the past 2 decades in the development of heart failure therapy, there remain significant unmet needs for the improved implementation to add the substantial residual risk. Why I am saying so? Because you can see there is still many, many people who are getting hospitalized recurrently. They are getting, they are actually dying because of lack of implementation of the available evidence and therapy. So drugs that reduce the mortality in heart failure, you can see at one point of time we thought probably beta blocker probably has the highest evidence, reduction of mortality to the tune of 35%, but now the different meta-analysis, which included all the beta blockers and all other therapy, they clearly shown that 25% reduction of mortality is seen with ARNI, which is probably the highest. Then comes the mineralocorticoid receptor antagonist, 24%. Beta blocker overall, if you consider all the 3 beta blockers, you should all clearly understand there are 3 beta blockers approved for heart failure therapy: bisoprolol, metoprolol, succinate, and carvedilol. So overall, if we include all of them, there is 22% reduction of cardiovascular mortality. SGLT2 inhibitor gives around 12% of cardiovascular mortality, compared to the existing ACE inhibitor, which only had 11%, and ARB only around 5% mortality reduction. So that is why in the Fantastic Four, we do not mention about ACE inhibitor ARB. In 2024, there cannot be any reason to continue with ACE inhibitor and ARB if your patient is having a diagnosis of heart failure with reduced ejection fraction. So to summarize the first portion of my talk, heart failure is a new malignancy, as 5-year survival rate of heart failure is worse than cancer such as breast cancer and prostate cancer, colon cancer. Lack of GDMT was associated with higher risk of hospitalization and emergency department visit, and GDMT is the foundation of heart failure care, and highest expected benefit will be offered to the patient. If we follow GDMT, we can offer them. Focus on proper implementation is very, very important. Now comes the second part. You can see the current recommendation: reduce ejection fraction, mildly reduce, and preserve ejection fraction. For reduced ejection fraction, all the Fantastic Four are class 1 indicated molecule. For mildly reduced, you can see ARNI, beta blocker, and melanocorticoid receptor antagonist, they are class 2B recommended molecule. Whereas only molecule which is class 1, which has been there in 2024 ESC guideline, is SGLT2 inhibitor. This is a class 1A recommended molecule in mildly reduced ejection fraction patient. What about preserved ejection fraction? Only molecule, apart from diuretic. Diuretic is a class 1 indicated molecule if there is features of volume overload. Otherwise, only group of molecule which is having class 1 indication is SGLT2 inhibitor. What about other molecule? Beta blocker, to be very honest, they are actually not indicated. If your ejection fraction has crossed 50%, beta blocker do not show any evidence. Yes, if there is some compelling indication, some arrhythmia or something like that, then you can give it. But merely for heart failure treatment, beta blocker are actually not indicated if the ejection fraction has crossed 50%, and all the guidelines are very uniform regarding that. Also about the ARNI and melanocorticoid receptor antagonists, because there is some evidence which suggests that they are probably beneficial, so they are class 2B indicated molecule in this field. So why there is critical inertia in achieving optimal GDMT? Yes, there is patient-related inertia. They are non-compliant, they do not take the medicine, but there is physician-related inertia as well. So there are many myths. They think my heart failure patient is doing very good with a simple pill of Ditor Plus. Why should I increase the burden of the patient? But this is myth, because reality is the underlying structure and molecular abnormality are so bad, your patient at one point of time will land up with trouble. So there is nothing called stable heart failure. All patients of heart failure are very, very unstable. At this point, they may look stable, but they will become unstable at any point of time. So when medications are prescribed, most receive low or suboptimal dose of therapy. Why? Largest concern is blood pressure. The blood pressure is in any case low for Indian patient, but I'll give you one example. There was one trial of beta blocker known as MEDIT heart failure trial, which was done in heart failure patient with metoprolol succinate. You'll be surprised to know the arm which evaluated the beta blocker compared to placebo actually had higher blood pressure. So what does that signify? So if you can treat your patient properly, with that, if the heart failure state is improving, their blood pressure will also recover. So it is very important to uptitrate the molecule. ARNI, you are starting at a low dose. You should keep on uptitrating the dose of ARNI. Then only the blood pressure will no longer be an issue, because the heart will be in a better shape, because the remodeling will be prevented and the blood pressure will come, will improve automatically. So this is very, very important, and you will be surprised to note that only 1% of the targeted population who are actually candidate for all the Fantastic Four molecule are actually receiving it in a proper dose. So that is an abysmal data. So minimal initiation and titration of GDMT during hospitalization is very bad. Still we are using ACE inhibitor, ARB, which are actually inferior molecule. Benefit of GDMT appear within days to weeks. This is also very important. You can see the graph, how they are getting separated. For SGLT2 inhibitor, the graph starts separating to the tune of 26 days only. So that early the benefit you can actually see, you can observe visible benefit. Similarly, for other therapy also, they start working very nicely, very quickly. So guideline recommendation in using 4 pillars of heart failure management. So recommendation, most of the patient, they actually are candidate where we can start this molecule, all of them, before the discharge of the patient. Why it is important to start the medicine before discharge? I have already shown you, in-hospital mortality of heart failure is around 9.6%. There is significant post-discharge mortality as well, and the risk is highest in the initial 1 month. So if you do not start this molecule, which are actually changing the trajectory of the disease, then you are missing this very important early part of heart failure, spectrum. So many of these patients will come back to your hospital for repeat hospitalization. Some of them will die. So that is why it is very important, whenever you get opportunity to start this molecule, you should start this molecule in hospital, because there are good number of evidence which suggests you can actually initiate them in hospital. You should, obviously, you should fulfill some criteria. Patient should be hemodynamically stable. There are some specific criteria to initiate them, but recommendation-wise, different guidelines, including European Society of Cardiology, as well as American College of Cardiology, they suggest we should initiate the molecule in hospital. And this is the evidence. You can see the article which suggests how we are supposed to start. Now, how we are supposed to start? Are we supposed to all of them together or sequentially? So this is Professor John McMurray. He was there to our city last week only. So he is one of the father figure of heart failure therapy. So as per his suggestion, there is something known as rapid sequencing. At one arm, you have conventional sequencing. Step 1, ACE inhibitor, ARB, beta blocker, then step 3, mineralocorticoid, step 4, ARNI, replacing the ACE inhibitor, step 5, SGLT2 inhibitor. You can see the problem. Typically, it requires 6 months to get all the important molecule on board. Whereas Professor Jan McMurray and other people, they are suggesting something known as rapid sequencing. Here you are starting beta blocker and SGLT2 inhibitor at step 1, followed by ARNI in the step 2, and mineralocorticoid receptor antagonist in step 3. Very simple. And by this, you can achieve the molecule on board within a span of 4 weeks, that is 1 month only. So this is the way forward. Do we have any evidence? Yes, we have very good quality evidence in the form of strong heart failure trial, strong heart failure data. You can see these are the slides taken from strong heart failure trial, 4 pillars of GDMT. Optimizing GDMT is associated with reverse cardiac remodeling, improved quality of life, fewer hospitalization, fewer death, and you can actually initiate them together. And this is the strong heart failure data which suggests that if you can have all of them together on board, there will be 62% reduction of cardiovascular mortality and heart failure hospitalization. Fine. So very importantly, you can see the projected event-free survival is 8.3 additional years if you can give all of this therapy together early and rapid sequencing. This is how you are supposed to do it. I'm not going to detail. Will it increase the adverse effect? You can see comparable. High intensity care, rapid sequencing, any adverse event 41.1, usual care 29.3, but you can see the fatal serious event almost comparable, 4.6 to 6% only. So yes, there will be possibility of little higher dyselectrolytemia, little higher hypotension, but at the end of the day, your patient is going to benefit. So there will be improvement in hemodynamics in day 90, improvement in all parameter of congestion at day 90. This is the strong heart failure data, and this has boosted our confidence to initiate all of them together and very early. So implementing strong heart failure in clinical practice, start patients on GDMT as soon as they are eligible. Rapid sequence, follow-up protocol should be used. Interprofessional coordination may facilitate the care, explore ways to monitor the patient remotely. So that is also coming in a big way. Remote monitoring of heart failure patient, you can get it done through some devices as well. many devices are available nowadays. In-home phlebotomy for serial lab values, embracing this strategy can optimize the patient care and prevent rehospitalization. So with that, guideline recommends an intensive strategy to initiate and rapid up-titration of evidence-based treatment before discharge and during frequent and careful follow-up visit in the first 6 weeks following heart failure hospitalization. Risk reduction and expected lifetime benefit are superior. ARNI, beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitor in chronic heart failure, particularly with reduced ejection fraction, has enough evidence, and all of them should be there on board. And strong heart failure study showed that an intensive treatment strategy of rapid up-titration of GDMT and close follow-up after an acute heart failure hospitalization was readily acceptable by patients because it reduced symptom, improved quality of life, and reduced the risk of 180-day all-cause mortality and heart failure readmission compared with the usual care. With that, I'd like to stop here. Thank you very much.
Thank you, Dr. Arindam Pandey, for your very kind and lucid presentation with the fantastic 4 pillars for the heart failure associated with AC inhibitor support. So any questions from the audience?
Yeah, so that was a fantastic lecture. Would you consider ferric carboxymaltose as one more pillar in heart failure with reduced ejection fraction? And new drugs like vericiguat?
So very important, there are few drugs which are not included in the Fantastic Four. One, as Dipankar mentioned, vericiguat. Another is ivabradine. Ivabradine do have a place in heart failure treatment, particularly in maximally tolerated dose of beta blocker if the heart rate is still high, particularly more than 70 resting heart rate. You should consider ivabradine, which is a class 2 molecule. Similarly, vericiguat. This is again important. This is a concept of worsening heart failure. What is worsening heart failure? Any emergency visit, it may not require hospitalization. He is coming to the emergency or your OPD where you are giving injectable, diuretics. In our country, heart failure clinics are not well established. But in Western country, there is something known as heart failure clinic. They only cater heart failure patient. But in our country, what happens? They come to the physician. Then commonly what they do, they increase the oral diuretic. That also serves the purpose, but that is an indication. That is an indication that your patient actually is deteriorating. If there is no proper precipitating cause, common precipitating cause, infection, anemia, if you can exclude them and still your patient is experiencing this worsening heart failure, then that indicates your patient actually is worsening. He is going to land up into hospital in due course. In those group of patient, vericiguat do have a very good quality evidence in the form of Victoria trial, which suggests vericiguat can be good option. I also give vericiguat in other patients, say for example, who are intolerant to the first line 4 therapy. Who are those patients? Kidney dysfunction. If kidney dysfunction advanced level, you cannot give ARNI, you cannot give mineralocorticoid antagonist, you cannot give SGLT2 inhibitor, so 3 are out. So what you can give? Vericiguat you can give because it is approved for very advanced EGFR, up to 15 it is approved. You can also give it to the patient who are having hypotension. There are patients who have heart failure. Systolic blood pressure is 80, 90. You are not supposed to initiate beta blocker, mineralocorticoid receptor antagonist or ARNI. So I have started them with vericiguat. I am getting good result. Many of them, they did not come to hospital, their hospitalization was reduced. There I do consider them. Regarding ferric carboxymaltose, whatever evidence we are having, it's a very good molecule, very important in terms of improvement of quality of life. I also use it very commonly. So nowadays, at one point of time, the recommendation was you need to monitor the ferritin of the patient. You need to monitor the transparent saturation. You don't need to see the hemoglobin. Hemoglobin may be normal. You are not treating anemia. You are treating the iron deficiency in heart failure patient. That is a separate, altogether different entity. And current recommendations suggest you don't even need ferritin. You just check the transparent saturation. If it is less than 15%, there is good quality evidence which suggests that ferric carboxymaltose single dose, it will give good improvement of quality of life. To some extent, it may reduce the hospitalization as well. No mortality benefit data. It will persist for around 3 to 4 months. Then again, you need to recheck. So these are the area you can use it. These are the molecule. not considered in the first Fantastic Four category, but they also hold good position in overall heart failure therapy.
We are starting the diuretics. Then along the fourth, that is pillar, we also started. But when we stop the diuretics, after the discharge, patient is continuing, but we are thinking that yes, patient may be going to the worsening of the heart failure. So patient is well good. So I stop the drug or not? What's the actually step to reduce the dose or stop the diuretics?
That's a very relevant question actually. Very relevant question, because you should clearly understand diuretics are also class 1 indicated molecule, both in preserved as well as reduced ejection fraction if there is features of volume overload. All patients should be offered, and it gives most rapid improvement of symptom. Now the question is when you are supposed to stop it, because as of now, if you do not consider mineralocorticoid receptor antagonists as a diuretic group, then none of them has shown you mortality benefit. So in long run, probably they are not going to improve the survival of the patient. So what we do, there is another school of opinion, many senior cardiologists, they consider a touch of diuretic, very low dose of diuretic, either torsemide 5 milligram or a low dose of 10 or 20 milligram of furosemide can be continued. That is good for the patient, because some of them might not be, continuing the other therapy, but I don't agree with that. I see in OPD, you should consider IV diuretic followed by oral diuretic when you are discharging the patient. In the follow-up, you should clearly look for the congestion of the patient. What are the features you are going to see? The congestion of the chest will disappear after the initial IV diuretic therapy. Then how do you monitor congestion? A very good way of monitoring congestion is to monitor the serial body weight of the patient. Now, gradually you try to, once your all fundamental 4 therapies are on board, you should give it a try to stop diuretic altogether. But at the same time, you should advise the patient to monitor the body weight. The body, body weighing machine are very less expensive equipment. And on follow-up, if the body weight is going very, fastly increasing, within a span of 1 or 2 days, the body weight is increasing to the tune of 1 kg, 2 kg, 3 kg. That is one indication probably you should reinstitute the diuretic. Otherwise, in follow-up, subsequent visit, you can give it a try to stop it altogether.
Okay, very interesting session offered by Dr. Pandey. So let us close the session.
So give a big round of applause for the fantastic session by Dr. Arindam Pandey sir. Now I am requesting Dr. Jayanto Rana sir to felicitate our speaker and honorable chairperson. A big round of applause, please make some noise. So it was a fantastic session, like the Fantastic Four. I think everyone enjoyed the session nicely. A big round of applause, please. Thank you, sir. Without further no delay, next session, epilepsy on and updates by Srigdhendu Ghosh, sir, by Dr. Srigdhendu Ghosh, sir. And for that, I am requesting our chairperson, Dr. Debjani Banerjee ma'am, and Dr. Pradeep Ganguly, sir, to please take the chair and initiate the session. Our next session, epilepsy and update. For that, I am requesting the chairpersons, Dr. Debjani Banerjee ma'am and Dr. Pradeep Ganguly sir, to take the chair and initiate the session. Over to you, ma'am.
Good afternoon, everyone, and I would like to welcome our speaker today, Dr. Snigdhendu Ghosh, our neurologist, our very popular neurologist from Bardhaman and Durgapur. He does not need any introduction. He's been the head of Department of Neuroscience in the Mission Hospital, Durgapur, currently. He's been in Indian Railways, in MRI Hospital, and he was one of the times in Bardhaman, when he was in Bardhaman, you were the one and only neurologist, so welcome.
Thank you, Chairs, for your kind introduction. At the outset, I would like to thank the organizers for allowing me to speak in front of my own people. I have divided the topic. First, I will discuss some basics, then approach and treatment of epilepsy, then epilepsy in some special circumstances, and lastly, few words about epilepsy surgery and ketogenic diet. So as there is scarcity of time, I would run through my talk. Now, to understand epilepsy, we have to be acquainted with some definitions. You all know this topic is just a recapitulation, just a form of revision. Now, seizure. What is seizure? Seizure is an abnormal neuronal firing leading to clinical alteration of neurologic function. Seizure may be motor, sensory, autonomic. Motor is seizure with abnormal body movements, which we call convulsion. Sensory seizure, observers won't see, only patient will feel. There will be some abnormal sensation of cold or some pain. And autonomic seizures, it will be manifested by incontinence, vomiting, laughter, and these are the three types of seizure. Now, there is difference between seizure and epilepsy. Epilepsy is recurrent seizure, recurrent unprovoked seizure. Now, few words about epileptogenesis. Epileptogenesis is a process by which neurons undergo structural and physiological changes, which is mostly permanent. Now, these are the different factors contributing to epileptogenesis, and now main focus is to epileptogenesis, because till date we don't have any medicines which act on epileptogenesis. We only have anti-seizure or medicine or anti-epileptic medicine. So I will not go into the details of epileptogenesis. Now, epilepsy mechanism, there is hypersynchrony and hyperexcitability. Difference is a single bad person cannot do any harm to the society, but a gang of bad persons can do harm. Similarly, a single neuron when excited cannot produce seizure. To produce seizure, a group of neurons, about 1 to 2 square centimeter of cortex has to be excited to produce seizure. So this is the difference between hyperexcitability and hypersynchrony. Now, these are the different parts of seizure, like prodrome, aura, ictal events, post-ictal events, we all know. Now, seizures may be partial and focal and generalized. I just show here. Oh, sorry. This is the focus from where epilepsy is arising. So this will be picked up by these leads. So this is focal seizure or partial seizure. And sometimes focal seizure gets generalized by when it spreads through corpus callosum and anterior commissure, posterior commissure, then it is generalized. So this is called focal seizure with generalization. And some seizures are generalized from the beginning. Here, seizure arises from bilateral thalamocortical circuitry, So EEG picks up as generalized seizure throughout the whole graph. So this is the basic difference between partial seizure with generalization, and primary generalized seizure. Now, these are the ILE classification of seizure and epilepsy. I won't go into the details due to want of time. Now, these are the classification of epilepsy syndromes. Now, how to approach seizure? So, clinical history is the most important, because EEG may or may not help you, because EEG is abnormal in 3% of normal population. And in a definite epileptic patient, 30 to 40% will not be picked up. So EEG should not be given much importance, and also depends on the person reading EEG, reporting EEG. So clinical history is the most important in diagnosing epilepsy. Now, EEG, not to overinterpret, should be clinically correlated, as I have already mentioned, and different conditions where physiological conditions, graph will be interpreted as abnormal. So we will not give that much importance to EEG. Then next comes neuroimaging. So as per ILE, International League Against Epilepsy, every patient with epilepsy should undergo MRI. Every patient, only few exceptions in idiopathic generalized syndromes like JME, then absence epilepsy, and in some cases of Rolandic epilepsy, that is benign epilepsy with centrotemporal spikes. Here we can skip neuroimaging. But in this era of medical legal litigation, we should do MRI as far as possible when the patient affords. And but drawback of MRI is that myelin gets matured by 3 years. So up to 3 years, normal MRI may be sometimes reported as rather leukodystrophy or abnormal myelination. So you have to repeat the MRI after 3 years. Now, MRI is the gold standard, but CT is important in some cases, like calcified lesions and sometimes in hemorrhagic lesions. CT outscores MRI, and nowadays these special forms of MRI sequencing are available and other special investigations. So those are mostly used for epilepsy surgery for localization. And autoimmune testing is strongly suggested in few cases like drug-resistant epilepsy, when there is dysautonomia, when semiology suggests orofacial dyskinesia or faciobrachial dystonic seizure. And genetic testing, this is very tricky. Don't advise genetic testing in haphazardly. It should only be tested after explaining everything to the patients and their parents. And when future pregnancy is planned, then only genetic testing should be done to prognosticate it. Now, approach, when to initiate antiepileptic. Whether to start antiepileptic after first seizure is very controversial. You should start after first seizure only there is definite lesion is found in neuroimaging or EEG is specifically abnormal, like those epilepsy syndromes, JME or infantile spasm or other things. Otherwise, one should not start antiepileptic after the first seizure, should wait for the second attack. And these are the things I have already mentioned. Now, when to discontinue therapy, it is also a very controversial thing. But before discontinuing, patients have to be explained everything, chance of recurrence, and usually these are the conditions where there is greatest chance of remaining seizure free. That is complete medical control of seizure for 1 to 5 years, single seizure type, either focal or generalized, normal neurological examinations including intelligence, and also before stopping antiepileptic you should have one EEG, fresh EEG, and that should be normal. Now seizure management, specific treatment, general treatment. In general treatment you have to reassure and have to teach the basic things to be done when a seizure occurs, like do not put anything inside mouth and to keep the patient in lateral decubitus, right or left, and never in supine position. And now specific treatments. These are anticonvulsants and epilepsy surgery. Anticonvulsants, first was bromide, discovered in 1857. Then gradually we have now latest is cannabidiol for Dravet syndrome. So we have a whole basket to choose. We have to apply our minds while choosing. Now these are the old antiepileptics and these are the relatively newer antiepileptics. These are the different mechanisms. Antiepileptics mostly act on inhibitory neurotransmitter like GABA and glycine, and excitatory neurotransmitter like glutamate and aspartate. Whatever antiepileptic, they have to either augment GABA glycine or inhibit aspartate glutamate. So these are the different mechanisms. These are shown here. And there are some antiepileptics which act on different mechanisms like topiramate and zonisamide. They act on sodium channel, they act on carbonic anhydrase, also act on GABA receptor, and also on glutamate receptor. So these are the roughly mechanism of action of antiepileptics. Now, how to choose antiepileptics? First, you have to classify seizure, and in generalized seizure or epilepsy syndromes, or in undetermined seizure type, you have to choose valproate, levetiracetam, phenytoin, phenobarbital, carbamazepine, and in these cases, sodium valproate. Here we should keep in mind that in JME, sodium valproate, phenytoin may aggravate seizure. These are sodium channel blockers. So if that happens, then we should try to avoid or we should withdraw. And these are the medicines prescribed and in partial seizures: carbamazepine, oxcarbazepine, phenytoin, valproate, and also levetiracetam. So while prescribing these medicines, we should always stress about side effects of Stevens-Johnson's or erythema multiforme, especially carbamazepine, oxcarbazepine, phenytoin, these medicines. Now, these are the epileptic emergencies: generalized convulsive and non-convulsive status epilepticus, and these autoimmune encephalitis and repetitive seizures. Now, these are the classification of status epilepticus. I will not go into details. It is a very busy slide and also don't have time. And these are the treatment of status epilepticus. This is impending status epilepticus. We all know we abort with benzodiazepines, any of the four. Then established status epilepticus, we give loading of phenytoin or valproate or levetiracetam. Sometimes we can give a mini loading of 50% of loading. And in refractory status epilepticus, we start midazolam or propofol infusion. And super refractory, we give, these are the measures. And when it is stamped as nausea, that is new onset refractory status epilepticus, we'll have to treat it as autoimmune encephalitis. We'll have to give IVIG, plasmapheresis, methylpenicillin, etc. Now, there are few conditions, epilepsy in these conditions. We have to be very careful in pregnancy because antiepileptics many have teratogenicity. Valproate is the notorious. So we should avoid valproate in 15 to 45 age groups, and almost all available anti-epileptics have teratogenic effect. We have to balance. Till date, these are the side effects, these are the major, these are the minor. We'll go through. And sodium valproate, though it is the most notorious, but when used up to 650 mg, side effects are not that much. But when it is more than 650, side effects start to appear, mostly neural tube defects, cardiac defects, and other mental disorders in the neonates. And these are the other anti-epileptics. All are having some form of side effects. But newer anti-epileptics are relatively side effect free, but they are still not recommended because due to want of data. So we'll have to wait few more years to have these medicines. Now, monotherapy, low dose polytherapy. Monotherapy is always better than low dose polytherapy. Now these are the studies of teratogenicity of AEDs. Now, epilepsy in stroke. I will not go into details of epilepsy in stroke. Only point is that lobar stroke has a tendency to produce seizure, like frontal, lobar, temporal, parietal, occipital. Whereas stroke involving basal ganglia, thalamus, they don't produce seizure. In general, hemorrhagic stroke are more prone to produce seizure. Ischemic stroke are less. And seizure is the commonest cause of epilepsy in older adults and elderly people. So, as per Book's teaching, one should not use prophylactic anti-epileptic in stroke. But these guidelines are produced by persons who are well protected. But for people who work in periphery, it is better to give anti-epileptics in these lobar strokes, not in central stroke like basal ganglia, thalamus. So, lobar stroke we can use, and mostly monotherapy. So, this which I already mentioned. Now, next is epilepsy and sports. Some sports act as trigger for epilepsy, like exercise may induce generalized idiopathic epilepsy and some focal epilepsy in the frontal lobe, temporal lobe. At the same time, seizure during sports like during swimming, cycling may cause injury to the patient. So it is both ways. Still, considering everything, people with epilepsy should be encouraged to exercise and participate in sports. No sports is completely off limits to them, with exception of maybe combat sports such as boxing, mixed martial arts, etc. Keep proper supervision while playing. And walking, running, cycling, yoga, there is no risk and should be encouraged. And problem is with swimming. So one can swim under supervision. So take home message is people with epilepsy should be encouraged to participate in sports, and in some special cases with supervision. They should never be discouraged. Now, epilepsy and driving, this is a big issue. Now, if we restrict driving, they will have loss of employment, and there will be tendency to break the rules, social consequences, psychological consequences, and non-compliance of regulation. There are some countries where there is complete ban of driving in case of epilepsy, like in our country, India. These are the countries with full ban. And these are the countries with restrictions. And here 24 months ban for these countries. So problem is so despite the international variability in driving with epilepsy, regulations all agree that countries should regulate drivers' license eligibility with certain medical conditions such as epilepsy to ensure patient and public safety. They should be allowed to drive with a seizure-free specific period of time, and they should never be banned like India. So it depends on the type of epilepsy, and they should undergo periodic medical checkup. Now, few words about epilepsy surgery. When drugs fail, we'll have to consider epilepsy surgery. So two types of surgery are there. One is surgery proper and another is neuromodulation. In surgery proper, usually it is mostly performed in temporal lobe epilepsy like anterior temporal lobectomy, amygdalohypocampectomy. Besides that, we also perform hemispherectomy, multiple subpile transactions, and corpus callosotomy. And in neuromodulation, we perform DBS, anterior thalamic stimulation, and vagus nerve stimulation. Vagus nerve stimulation can be performed at any age, whereas deep brain stimulation involving anterior thalamus can be performed only in adults. And few words about ketogenic diet. When all fail, we can try this. Ketogenic diet is high fat, low carbohydrate, and recommended daily allowance of protein, but it is highly unpalatable. Adults usually do not take it. In children, it can be given by a nasogastric tube, and it acts by altering brain metabolism, whereby inhibitory neurotransmitters are promoted in brain. So this ketogenic diet is the last resort. Now take home message. Clinical diagnosis is the key. Always try to give a complete diagnosis. Not like seizure disorder, you try to classify it as idiopathic generalized, focal seizure, or focal with generalization, or epilepsy syndromes, so that proper anti-epileptic can be prescribed. Non-epileptic seizures should always be the last diagnosis. After exclusion, even if you are almost certain about the etiology, you will have to investigate and to rule out the organic causes. Then do not give too much importance to EEG. Always teach the basic general management. Start an appropriate AED and intimate about serious side effects, because this Stephen Johnson thing, it may kill the patient. So we'll always have to write, inform as soon as you feel allergy, rash. So this has to be stressed. So do not go on adding drugs after drugs. When two drugs fails, it is certain that patient will not respond to drugs. So then we'll have to send the patient to a epilepsy center or to a epileptologist. And we have to keep a very low threshold for surgery. So with this, I end my talk.
Thank you, sir. Thank you, Dr. Ghosh.
Yeah.
With the recurrent fall, the cardiological evaluation shows nothing. If they do a CT scan or MRI, there is a new term, I don't know why, this chronic ischemic changes or cerebral atrophy. But without I at least used to give a short course of anti-epileptic therapy. So is it right or is it wrong, or if the anti-epileptic is started, it should be continued for how long?
Yeah. Problem is with this is termed as syncope. So syncope is a condition after extensive investigation you don't get anything in many cases. So cardiologists refer to neurologists, neurologists to cardiologists, and ultimately they don't have any solution. We only do an EEG of 30 minutes. So 30 minutes of EEG won't pick all seizures. 40%, 30 to 40% will be missed. In these cases, EEG for 4 days, 5 days, up to 7 days can be done. EEG, continuous. So there is one cap where leads are put and patient is there, he lies down, and whenever he goes to toilet, that cap is removed. Whenever he is eating or doing something, that cap is removed. But continuous up to 7 days we have also done, in my residency period for workup for epilepsy surgery. So that can be done, but that is not practical here in most of the places. In that cases, a safe anti-epileptic like levetiracetam we can give, and we should write for the benefit of doubt, levetiracetam is given, and if during workup any other cause is found, then levetiracetam can be withdrawn.
How long it should be continued if there is nothing else is found?
You can continue, you have to continue.
For lifelong?
Almost. Otherwise, if the patient remains well with your medicine, then it has to be continued. In elderly patient, you cannot take any risk.
Sir, I have one question. If there is a head injury and then there is bleed, and the patient has not have any seizure.
Any?
There is no seizure.
Oh, no seizure.
No seizure. But there is a documented head injury with a bleed. So if you start anticonvulsant, prophylaxis, and if yes, for how long?
Yeah, no seizure. Actually, as per recommendation, as per book teaching, prophylactic anticonvulsant has no role. But in practice, we use it. Because if seizure occurs to a bleed, then size of bleed will increase and Glasgow's coma scale will fall so drastically, then it is better to start an anti-epileptic. And this should be treated as acute symptomatic seizure, like up to maximum of 3 months. You can withdraw it.
Thank you. Sir, one more question. For tuberous sclerosis, do you directly refer to a neurosurgeon or do you treat with anticonvulsants first?
Tuberous sclerosis has rather many spectrum. First, in infancy, it may present with infantile spasm. Then you can treat with ACTH. Then later you can start vigabatrin. And neurosurgery role, if there is big cortical tumors or subependymal giant cell in subependymal giant cell astroma, you have to send for surgery. Otherwise, small subependymal nodule, you need not do any surgery.
Thank you, sir. Any other questions?
সিজার হয় এবং সেই ক্ষেত্রে আমরা কি করতে পারি? স্লিপ ডিপ্রাইভেশন, কতদিন ডিপ্রাইভেশন হলে কি ওষুধ তোমরা দিই?
Seizure has some triggers like hyponatremia, hypocalcemia, hypomagnesemia, lack of sleep. These are triggers for seizure. So sleep deprivation during EEG may bring the seizure. In normal, without sleep deprivation, seizure EEG may be normal. In many cases, after sleep deprivation, EEG comes as positive. So it acts as a trigger.
ওয়ান টাইম কনভালশন হলে আমরা কি এমআরআই বা এই জাতীয় কোনো বলবো না, ওয়েট ফর অ্যানাদার সিজার?
Nowadays it is better to do MRI. ILE recommends MRI in all cases of seizure. You have to do MRI, you have to do EEG. If MRI and EEG are normal, then you don't start anti-epileptic after the first seizure. Exception is febrile seizure, that is in children, 6 months to 5 years. That febrile seizure, you need not do MRI. But in all other seizures, you have to do.
Sir, idiopathic epilepsy in childhood and adult age epilepsy হয় কত বছর না হলে আমি ওষুধ বন্ধ করব?
Usually 1 year to 5 years, if seizure free, you can try. But in some epilepsy, as soon as you discontinue, there will be recurrence, like juvenile myoclonic epilepsy. If you, not in all cases, in some cases of JME, if you withdraw anti-epileptic, there will be seizure. So it will have to be individualized. One trial of withdrawal has to be given. That can be up. Usually we give 2 to 3 years of seizure-free interval. We try after conveying everything to the parents and the patient.
সেক্ষেত্রে গ্রাজুয়াল করব, গ্রাজুয়াল।
Anti-epileptic should always be tapered. Don't withdraw it abruptly.
Thank you, sir.
Thank you. Because we are running short of time, we'll close the session. Thank you, sir.
স্যার একটা জিনিস,
Hand over to MOC.
পোস্ট স্ট্রোক আমরা যে একটা অ্যান্টি এপিলেপটিক দিয়ে ছাড়ি, হাউ লং টু কন্টিনিউ, বি ইট হেমারেজিক সিজার অর আ ম্যাসিভ ইনফার্ক্ট?
Two types of post-stroke seizures are there: early post-stroke seizure and late post-stroke seizure. Early post-stroke seizure is up to 7 days. Late post-stroke seizure is after 7 days. In early post-stroke seizure, we can withdraw it in few weeks to up to 3 months. But in late post-stroke seizure, it has to be treated as epilepsy, long term.
And for prophylaxis, how long to give?
Prophylaxis.
মানে আমরা যখন দিয়ে ছাড়ি যেমন পোস্ট
For
ডিসচার্জ,
prophylaxis, not more than 3 months. Not more than 3 months, because prophylactic thing is rather they discourage, guidelines discourage prophylactic anti-epileptic. So, but if you start, because we have to start in periphery, we are not protected. So after 3 months, we can withdraw it.
Thank you, sir.
Thank you so much, sir, for the nice presentations. And now I would request Dr. A.K. Mukherjee, sir, for giving the token of respect to our speaker and chairperson. Please give a big round of applause. Make some noise also. Make some noise also. So I think it's a great learning session. We have received lots of updates on epilepsy management by Dr. Snigdhendu Ghosh. Thank you so much for this nice session to all of us. Thank you, doctors. Great. Thank you so much, doctor. Thank you, ma'am. We are actually going short of time. So our next session of the day is breaking the barriers of clinical inertia on MRA adoption in HF management. For that, I am requesting our chairperson, Dr. Shaugoto Sarkar and Dr. Rakesh Kumar sir to take the chair for the next session. Our next session, breaking the barriers of clinical inertia on MRA adoptions in HF management. Over to you, sir.
To speak on the next topic, I would like to invite Professor Dr. Dipankar Ghosh Dastidar, who is a very renowned intervention cardiologist in this part of the India. So without wasting much time, I would request sir to take on the session. Thank you, sir.
So, thank you, and thank you organizers for having me here. Good evening. I am going to talk on breaking the barriers of clinical inertia on MRA adoption in heart failure management. Throughout the day, I think you heard several talks on heart failure management, but my focus will be mainly on the mineralocorticoid receptor antagonists. And where are we heading? As you are quite aware that the heart failure is a very grave problem with prevalence around 1 to 3% in general adult population worldwide. And this is the Indian data. We have 0.7 to 1.5%. So this is the incidence in India. And you'll be surprised to see that many of the developed countries like Canada, Germany have higher incidence of heart failure than in India. The reason is that they are detecting more cases. That is the main reason. Now, first I will be giving my talk on heart failure with reduced ejection fraction, and Dr. Arindam clearly explained that there are 4 pillars in its management. One is ARNI, beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. We are now also quite aware that comprehensive disease modifying is much better than conventional heart failure therapy. What do I mean by that? Comprehensive means you start these 4 pillars at the same time in one go, and you rapidly increase the dosage. Conventional therapy was step-by-step addition. So after this strong heart failure trial, now no more step-by-step addition is recommended. You first of all give a comprehensive therapy with rapid sequencing of the dose. And this has been shown to reduce the risk, providing survival benefit. So rapidly initiating foundational therapies can maximize survival and minimize the risk of worsening heart failure. Now, unfortunately, the guideline-directed medical therapy in heart failure management, this is followed only in 82% of cases. It is not followed in the majority of the cases. It is required in 82%, but it's not. The patients were eligible in 82% of cases, but it's not followed. Quadruple therapy, the 4 pillars, are followed only in 15.3% of the cases. Triple therapy in 41.5% cases. So it is quite obvious that less than 50% of the patients are getting proper guideline-directed medical therapy. Of the 4 guideline-directed medical therapy, the least followed would be the aldosterone receptor antagonist, the MRA, which is mainly my talk today. Now, why we are reluctant to prescribe MRA antagonist in heart failure patients? Mainly because many of the heart failure patients are suffering from renal impairment. So we feel that addition of MRA will increase the renal deterioration, or it may cause hyperkalemia. Secondly, these MRA, as we popularly know, the first generation ones like spironolactone, they act also against the androgen and progesterone receptors. So they cause a lot of other side effects like gynecomastia, impotence, as well as menstrual irregularities. So because of these kind of side effects, they are usually taken off from the therapy early, and we are reluctant to use it. But you can see that MRA antagonism is a key pillar in heart failure management in the form that it is an anti-hypertrophy agent, it is an anti-fibrotic agent, and most important, it is an anti-inflammatory agent. Because these 3 pathophysiological things do occur in chronic heart failure. So the RAIL study was there way back in 2000 and published in New England Journal of Medicine, which first showed that spironolactone reduces both morbidity and mortality in patients with severe heart failure. Since then, we have been prescribing spironolactone in heart failure with reduced ejection fraction. And it has been shown that spironolactone reduces 30% reduction in death. So there were 35% lower rates of hospitalization due to worsening heart failure, and 30% reduction in the risk of hospitalization from other cardiac causes. 32% risk reduction from cardiac causes for hospitalization and other things. So the tune of risk benefit was in favor of using spironolactone in heart failure with reduced ejection fraction. But spironolactone not only acts on this mineralocorticoid receptor, it acts on androgen receptor, glucocorticoid receptor, and progesterone receptor. So it causes gynecomastia, sexual dysfunction like impotence, menstrual irregularities, and most important, hyperkalemia. So people thought that an alternative steroidal mineralocorticoid receptor antagonist, which would be more specifically acting only on mineralocorticoid receptor, was the need of the day. So people came out with eplerenone. So eplerenone was a highly specific mineralocorticoid receptor antagonist, but it was a steroid molecule. Now eplerenone was tried in this post-MI heart failure in FSS trial, and it was shown to reduce mortality 13%, 15% lower risk of death from any cause, and 21% lower risk of sudden death from cardiac causes. So eplerenone in FSS trial was equally good, particularly in heart failure with reduced ejection fraction. And it was devoid of those gynecomastia, the sexual irregularities, whatever you were having. So these kind of side effects were devoid of this. This is another trial, emphasis, also based on eplerenone, which studied patients with mildly reduced systolic function. And again, eplerenone was found to decrease death to the tune of 24% and reduce the risk of hospitalization to the tune of 42%. So definitely, eplerenone was a success in management in heart failure with reduced ejection fraction. And no doubt, MRA like eplerenone or spironolactone enjoy a class 1 recommendation in heart failure with reduced ejection fraction management. So far, so good. Now, the importance of time of initiation of MRA is very important. So the early the initiation, you see the curves separating early on. So early initiation is a key thing. So right inside the ICU, after the initial stabilization, when the patient is off inotropic support and the patient is on a stable dose of diuretics, the mRNA should be introduced, as with case of ARNI, beta blockers, and SGLT2 inhibitors. So rapid frequency and early initiation is the need of the hour. So early initiation, it reduces the risk of sudden death to the tune of 34%, all-cause mortality, all in the range of 30%. Okay. Now, certain factors which we have discussed already, and this Swedish registry also showed that why the underuse of this mineralocorticoid receptor antagonist was there. So mainly, not only those side effects, the introduction of these side effects do also cause hypotension. But ultimately, the pump function improves. The general risk benefit is in favor of giving MRA in the patients of heart failure with reduced ejection fraction. Now, even after an hyperkalemia event, it was seen that restarting of the MRA was not done in 76% of patients, which is a shame. So, whatever the side effects, we should always try to give the 4 pillars in heart failure with reduced ejection fraction. Now, down titration or discontinuation of this MRA in heart failure with reduced ejection fraction doubles the mortality or strongly is associated with increased all-cause mortality and higher risk of all-cause mortality in different parameters. Now, I come to the second topic, diabetic kidney disease. I hope you heard the topic in the morning. And again, people found out that mineralocorticoid receptor associated mechanisms is the key thing causing this diabetic kidney disease. So we had to use this mineralocorticoid receptor antagonist to prevent the progression of diabetic kidney disease. Now came the dilemma that if you are using the common mineralocorticoid receptor antagonists like spironolactone and eplerenone, which sometimes did show progression of the renal disease as well as causing hyperkalemia. So people had to come out with a novel mineralocorticoid receptor antagonist which will cause less hyperkalemia. So the spectrum now changes from RAS blockade to RAS blockade. Now this is just the renin-angiotensin system blockade, the first RAS, and RAAS means renin-angiotensin-aldosterone blockade. So the concept is a change of from RAS to RASI. Why? Because you now know that this mineralocorticoid receptor is the key thing in causing fibrosis. So you need to give an aldosterone blocker. Moreover, if you are just blocking the RAS, there is always aldosterone escape. So people also tried dual RAS blockade. Even then, the aldosterone escape was there. Now, dual RAS blockade was never encouraged in the guidelines because it causes hyperkalemia, hypotension, and there is progressive renal function damage. And moreover, certain amount of aldosterone escape is always there. So the best thing to prevent progression of diabetic kidney disease is to move forward with mineralocorticoid receptor antagonist. So this is a novel molecule now coming up. It's a non-steroidal molecule by the name of finrenon. And it has got a highly mineralocorticoid receptor affinity, and it is very much mineralocorticoid receptor selectivity, and is devoid of the sex hormone, CNS penetration, and the other deleterious side effects of the mineralocorticoid receptor antagonist. And this is a non-steroidal agent also. So this finrenon was tried in 2 landmark trials like Fidelio and Figaro. Now Fidelio was there, these are all in CKD patients. So there is no question of mild renal impairment. They are all established CKD patients. And in Fidelio, the cardiovascular outcomes were a secondary endpoint. And surprisingly, they found that all the cardiovascular outcomes was beneficial in Fidelio, which is mainly targeting the kidney population. Primary outcome was the renal parameters. And that also showed that there is delayed progression of the renal disease, delayed progression of albuminuria, so all nephrological and cardiac benefit. So a very good drug for cardiorenal syndromes. The Figaro had primary outcomes in cardiovascular parameters. And again, this trial also showed beneficial cardiovascular outcomes apart from the renal benefits. So now, ladies and gentlemen, you have a molecule apart from the steroidal ones like spironolactone and eplerenone, which works in these cardiorenal parameters. So finrenon in diabetic kidney disease was recommended as a drug of choice to prevent its progression. Now I come to the last part of my talk in the third scenario of heart failure with preserved ejection fraction. Now you are quite aware that now it is no more a homogeneous group. Actually, we now do phenotypic classification of heart failure with preserved ejection fraction. And there are 7 variants of this heart failure with preserved ejection fraction. The most common is the garden variety, in which you get obese patient with renal impairment. Then you have the coronary artery disease variant. You have the atrial myopathy variant with AF. You have the right heart failure variant. You have hypertrophic cardiomyopathy. You have the multivalvular involvement, and you have restrictive cardiomyopathy. Now all these patients are in heart failure but with preserved ejection fraction. The common pathophysiology of all of them are a chronic inflammatory state leading to increased fibrosis. So again, ladies and gentlemen, here in heart failure with preserved ejection fraction, you need an agent which will act against chronic inflammation and it will act against fibrosis. You know, all the 4 pillars of heart failure with reduced ejection fraction, they are not useful in heart failure with preserved ejection fraction. This is a very difficult subset to treat. And many a times we don't have any treatment other than treating the morbidity, comorbid conditions only. But now, with the advent of this mineralocorticoid receptor antagonist, finrenon, it is showing light in the therapy of heart failure with preserved ejection fraction therapy also. So again, the role of mineralocorticoid receptor was highlighted in heart failure with preserved ejection fraction, and it has got an important therapeutic role here. Now, so people first tried it with spironolactone, and you know the TopCat trial. The TopCat, you know, the Rails trial was a success in heart failure with reduced ejection fraction. Now the TopCat is in the preserved ejection fraction. So the first general tendency of the scientific community was to test spironolactone in heart failure with preserved ejection fraction in TopCat trial. But it was a disaster. it was not successful. But there were some trends which showed that it reduced hospitalization only. Now, why TopCat was a failure? There are a lot of studies in that, but particularly it's a worldwide trial, and it was seen that in Russia and Georgia, particularly this East Russian community, the TopCat, the choice of the patient population was not good. The drugs they took were not sufficient because spironolactone metabolite, canrenon, was not found in their urine in sufficient quantities. So this was a flawed trial design. Flawed trial design. Rather, the concept is not a failure, but it was a flawed trial design. And it took some 3-4 years for the scientific community to set back because of this failure. Ultimately, they now, with the advent of this new molecule, finrenon, which is a non-steroidal mineralocorticoid receptor antagonist, the scientific community is again trying to see or re-establish the role of this mineralocorticoid receptor antagonist in heart failure with preserved ejection fraction. Because you know, this agent will reduce cardiac hypertrophy, it will reduce the early diastolic dysfunction, and it will reduce the chronic inflammatory state also. So, definitely a choice of therapy for heart failure with preserved ejection fraction. And this November, December, the fine art result came out, and it was a success. It's been published in New England Journal of Medicine. I am giving you the very recent data. You can see the date of publication, September 1, 2024. Finrenon in heart failure with mildly reduced or preserved ejection fraction. And it was a success. You see in the red column below, in patients with heart failure and mildly reduced or preserved ejection fraction, finrenon resulted in a significantly lower rate of composite total worsening of heart failure events and death from cardiovascular causes than placebo. So now, ladies and gentlemen, you have one more molecule in heart failure with preserved ejection fraction therapy in the form of finrenon. So this is the way to move forward in mineralocorticoid receptor antagonist in our various spectrum of heart failure management. So you can now classify the mineralocorticoid receptor antagonist as steroidal and non-steroidal. Steroidal being spironolactone and eplerenone, and we saw its success. Non-steroidal is finrenon, indicated for diabetic kidney disease and now also indicated for heart failure with preserved ejection fraction. So my take-home message would be, see, in heart failure with reduced ejection fraction, you got the 4 pillars. Of the 4 pillars, mineralocorticoid receptor antagonist is spironolactone and eplerenone only. We don't have a trial of heart failure with reduced ejection fraction with finrenon. So we don't just have a trial, so it's not recommended in reduced ejection fraction. So less than 40%, you are all very versed with the treatment of heart failure. What about the patient subset above 40%? Now, above 40%, 40 to 50% is mid-range ejection fraction, and above 50% is the preserved ejection fraction. Now, in the preserved ejection fraction, you can see we have certain therapies now, established therapy, SGLT2 inhibitors, particularly after Emperor preserved and delivered trial. You have both empagliflozin and dapagliflozin as established therapy in all range of ejection fraction. You have ARNI, up to an ejection fraction of 57% and particularly more beneficial in female subset, thanks to this Paragon trial. That's an established drug. You have a GLP-1 agonist. You can give semaglutide, particularly in obese patient. Obese, heart failure with preserved ejection fraction. You know, one phenotype was obese, so you can give semaglutide to these patients. And then you have one more drug, this mineralocorticoid receptor antagonist in the form of finrenon. So this is my summary. Heart failure, reduced ejection fraction, 4 pillars. Diabetic kidney disease, finrenon, definitely the way to move forward, prevent the proteinuria, prevent progression of the renal disease. And heart failure with preserved ejection fraction, you now have also some pillars coming up, particularly again you can talk in this way, there are 4 pillars, established 4 pillars in heart failure with preserved ejection fraction also, apart from treating the comorbidities. So I thank you all for your time and attention.
Thank you, Dastidas sir, for a fantastic and crisp talk. Since we are running short of time, I can allow one question, if there is any from the audience side.
Sir, one question is there. Already we discussed that there is a in post-MI patient. What is among the 4 pillars, which is the most choiceable drug in case of post-MI heart failure patient?
Post-MI with reduced ejection fraction.
Yes.
You have to give the 4 pillars. There is, if you are combined, you are giving the 4 pillars, the mortality reduction will be to the tune of 62%. But individually you go, it is ARNI, the highest, then it comes the beta blockers, and then there is the melanocorticoid receptor antagonist, and finally the SGLT2 inhibitors. So the range starts something like 30% to 10 to 12% for the individual drugs. But most important is not only the heart failure hospitalization is reduced, but what is the most dreaded complication post-MI is the sudden cardiac death. So definitely that is also quite less by reduced by using of these 4 pillars in reduced ejection fraction therapy.
Okay, thank you.
And one more important corollary to this, I would say that revascularization is the most important thing. So if you have done revascularization in your MI patients, these drugs are not that much useful. That is why one trial is there with ARNI which showed failure in post-MI setup because those patients were already revascularized. So if you do quick revascularization, be by thrombolysis or by PTCA, primary PTCA, if you revascularize, that is the most key thing, and if the injection fraction is preserved, then the benefits of these drugs went down. But of course, these are very strong pillars.
Thank you very much for your excellent presentation. My question is, can it be used, what is the current recommendation? Can it be used in the ICCU setting, number 1? Number 2, with the advent of newer molecules such as aldosteronis inhibitor, I think it will come in the market in the next decade. What is your impression that this
Yes.
go to these?
Very good question, because the strong heart failure trial and the other trials also of ARNI like Paramount trial, they have clearly shown that early initiation of the drug in the ICCU itself is beneficial. So once your patient is off inotropic support, is off NORAD, dobutamine or dopamine, whatever you are giving, is off inotropic support and is on a stable dose of diuretics, meaning by which you are not changing the dose of diuretics, not going into failure, is stable. Then you start these medications one by one in rapid sequence and try to up titrate the dose as much as possible before discharge. Because this is the time when the patient is most receptive to receive the medication. He understands the seriousness of the problem, and this is the most likely time the patient will take medication. And it has been seen that if you introduce these drugs in the ICCU itself, the 30-day mortality, 30-day rehospitalization rates, and 30-day NT-proBNP levels are much less than if you are going for a conventional therapy where you are adding these drugs in a slow step-by-step sequence, taking 6 weeks to achieve the full dose. So those patients are likely to end up much more in failure.
Thank you, sir, for a fantastic talk and fantastic discussion.
Actually, we have discussed about the efficacy parameter, and now I just have a question for safety part. If the patient is the 4-wheeler and the patient have hyperkalemia, and at that present time the patient do not have any congestion, so diuretics use is unjustified possibly, then what drug you supposed to be prescribed, ARNI or mineralocortical receptor antagonist?
No, the question is patient is
having hyperkalemia, and in the 4 pillar of this
now, first
therapy.
question is why the patient will have hyperkalemia. If there is no underlying renal impairment,
exactly,
or the patient is not receiving potassium supplements from outside,
okay,
it is very unlikely for the patient to land up in hyperkalemia.
Okay,
if
sir.
you get any patient who has a dangerous level of potassium, first and foremost you think of renal impairment.
Okay.
Because these drugs per se like that, they don't cause hyperkalemia like that. Okay.
Exactly.
And if you face hyperkalemia, then you have to give potassium binders, you have to look for renal impairment, whatever pathology is happening. So then that is the main crux of the problem. So SGLT2 inhibitors in this situation would be the safest drug to go. MRA antagonist and ARNI, both are concerned here. So you have to titrate the dose accordingly. And once the hyperkalemia is taken care of, you should look at the cause and re-administer these drugs, and have to keep a watchful eye on increase of creatinine and development of hyperkalemia again.
Okay, sir. Just my question is, which one is first to be prescribed, that is ARNI or MRA?
No, nothing like that.
That is
There
nothing.
nothing like
Okay.
that.
Anyone
So,
can be prescribed.
Yes. And I think simultaneously also.
Okay, thank you, sir. Thank you.
So thank you so much,
Yeah.
sir. And now the time for felicitating our chairperson and speaker. So kindly, Dr. D.K. Gupta, sir. So audience, please give a round of applause at least for the nice session. Make some noise also. Some noise. So our next session is on imagine of non-alcoholic fatty liver disease. For that, I am requesting our chairperson to take the chair, Dr. Arnob Banerjee sir and Dr. Mafidul Islam sir. Our next session, imagine of non-alcoholic fatty liver disease. Over to you, sir.
Hello, good evening everybody. To imaging of non-alcoholic fatty liver disease or NAFLD, we have our senior resident BMCH, Dr. Shrestha Khan, to talk. Please come and start your lecture.
Good evening, everyone. Today my topic is imaging of non-alcoholic fatty liver disease. Fatty liver disease can be only fatty liver, it can be non-alcoholic steatohepatitis, NASH with fibrosis, and finally ending to cirrhosis. Prevalence of fatty liver is almost about 15% in general population, and it is more higher in people who consume large quantities of alcohol, almost more than 60 grams per day, 50% in hyperlipidemic patient, 75% in patient having obesity of a BMI more than 30, and 95% in people having both obesity and high alcohol consumption. For imaging, we can do ultrasound, 2D scan, computed tomography, MRI imaging, elastography, and fibroscan. In case of ultrasound 2D mode, generally normal liver is isoechoic to the renal cortex and to the spleen. Intrahepatic vessels are sharply demarcated and posterior aspects of the liver are well depicted. But in patients having fatty liver, the echogenicity is raised, and that is more than of renal cortex or spleen. We always compare the echogenicity of the liver with that of renal cortex and spleen. There will be poor delineation of the intrahepatic architecture and loss of definition of diaphragm. So in fatty liver, along with hepatomegaly, there will be posterior sound attenuation, but one thing that ecotexture will be homogeneous throughout. In contrast, in case of cirrhosis, the ecotexture, it becomes very heterogeneous, and surface becomes nodular, and there can be formation of regenerative nodules or other dysplastic nodules. But in case of only fatty liver, the echogenicity is raised, but it is totally homogeneous. On USG, based on echogenicity, we grade it in 3 forms: grade 1, 2, and 3. In grade 1, there is only increased hepatic echogenicity, but visible periportal and diaphragmatic echogenicity is maintained. In grade 2, there is increased hepatic echogenicity with imperceptible periportal echogenicity, but without obscuration of the diaphragmatic echogenicity. And in grade 3, increased hepatic echogenicity along with loss of periportal echogenicity and obscuration of diaphragm. So in the first image in grade 1, there is increased echogenicity, but the periportal along the portal vein, the echogenicity hyperechoic structure is maintained. So we can differentiate, that is grade 1. In grade 2, the periportal echogenicity is lost, but the diaphragmatic echogenicity is maintained. And in grade 3, both the diaphragmatic echogenicity and periportal echogenicity, it will be lost. There are certain limitations of 2D ultrasound. It is a qualitative imaging, and therefore it is subjective and variable to person to person. Its sensitivity is limited when there are few steatotic hepatocytes. The sensitivity and specificity of B-mode sonography decreases as the body mass index of the patient increases, and conventional sonography cannot differentiate steatosis and steatohepatitis or stage fibrosis. We can only say there is fatty liver, but in case of hepatitis and in case if it is associated with fibrosis, we cannot detect. On CT scan, fatty liver is generally we can recognize when there is the liver attenuation decreases more than 40 HU, it is less than 40 HU, or the difference between the CT HU of the liver and spleen, it is more than 10 Hounsfield. But in several cases, severe cases, when it is grade 3, the intrahepatic vessels also become more hyperdense and the liver parenchyma, it becomes hypodense. So normally, in case this is a normal patient, we measure the CTHU value of the spleen and in the CTHU value of the liver. So here it is 57 and 48. So the difference between the two CTHU values are less than 10. But in case of fatty liver, we can see that the liver has become totally hypodense. The intrahepatic vessels have become hyperdense to that of the fatty liver. And the difference between the liver and spleen CTHU, this is 51, this is -6. So it is definitely more than 10 Hounsfield. MRI sometimes also help us for detecting fatty liver. We generally use chemical shift imaging, also termed as the Dixon methods, in which we do two sequences, one out-phase sequence and one in-phase sequence. These are based on water molecule and fat molecule alignment. In in-phase image, in out-phase image, the two are aligned and the signal cross each other and it nullify each other. But in in-phase imaging, it adds up to each other. So in normal liver, the OP and IP image have the similar intensity, look similar. But if there is fatty liver present, the OP images show a relative signal loss due to signal cancellation. So we can see a patient with fatty liver, one is out-phase imaging, one is in-phase imaging. In in-phase imaging, we can see the signal intensity has decreased than that of out-phase imaging. So definitely there is fatty infiltration. The other modalities can be used are elastography. It is mainly used not for fatty liver but to detect the amount of liver fibrosis and NASH also possible. The rationale is that fibrosis acts as a parenchymal scaffold that imparts rigidity. It helps us to estimate tissue stiffness, therefore provides information on the presence and degree of fibrosis. There are two types. One can be strain imaging, in which we do strain elastography, and another is acoustic radiation force impulse strain imaging. In both the cases, we impulse some amount of pressure and the input and output is measured. Other is shear wave imaging. It can be of three types. One is point shear wave elastography, one is 2D shear wave elastography, and other is transient elastography, which is called as fibroscan. The ARFI technique, in which we choose a section on the ultrasound in which it involves the right kidney and a lowest portion of the liver, predominantly segment 6 of liver. Then one acoustic push pulse is given, which is perpendicular to the patient, or it is parallel to the sound of the ultrasound. So if this acoustic pulse pressure produces displacement, and this displacement causes shear wave formation that is perpendicular to the USG pressure, and that this displacement again is detected by a detection pulses, which is again parallel to the ultrasound pressure. In case of point shear wave elastography, the similar ARFI technique only is used, but there is no actual tissue displacement. Rather, the attenuation of the energy given from outside is measured, and then it is intra-converted to shear waves through the absorption of acoustic energy. In 2D shear wave elastography, it is based on the radiation force in the tissue to create the shear wave. First, in the ultrasound image, we select a box where outside pressure is given, and then point by point it forms a conical box, and then after that few colors will automatically created by the machine depending on the amount of rigidity that is present and fibrosis that is present. Within that box, we select few ROI, and on that, it gives us certain values which tells us which portion of the liver has the highest rigidity. Shear wave elastography. The acquisition takes only a few milliseconds, thus the patient or operator movement does not impact the result. A high-speed acquisition is done at a speed of approximately 1 to 10 meters per second. A comparison of the two ultrasound images are done, and then a movie is produced, and then the propagation of the shear wave is measured. We also can save the image and keep, and later we can also correspond and evaluate with 2D ultrasound. It is measured generally in meter per second or kilopascal value, and all this tissue density, it is assumptions are made that the measurement is done when the tissue density is 1000 kg per meter cube, no probes pressure or portal hypertension, that is no kind of other external or internal pressure is there, no nearby structures or boundaries that cause the wave to travel as a scatterer is present. And the patient should be also should be positioned properly. There should be a fasting of 4 to 6 hours. An intercostal approach to the right lobe of liver is preferred. Patient should raise the right arm above the head to increase the intercostal spaces. A supine or slightly lateral decubitus position is preferred. The patient should breathe slowly. ROI is placed in the right lobe of liver, typically in segment 7 or 6 or 7, and 2 centimeter beneath the Gleason capsule, and perpendicular to the liver capsule pressure is given. ROI is placed to avoid large vessels and bile ducts and rib shadows. At least 10 measurements should be done. So here like this we place the patient, and in the intercostal area we place the instrument, and preferably 7th and 8th intercostal space is preferred. Left lobe of liver is not used because it has more value because of the cardiac activity. So some values, normal range are like less than 2.4 meter per second or less than 17 kilopascal, and every diseases have their own decided range. Some imaging technique we should remember that if the patient, it is male patient, the values will be more. In older patient, the value is higher than the younger patient. High BMI patient, it is also again more. The imaging technique that we generally prefer is it should be totally perpendicular. The scan should be, the level should be horizontal and it should be perpendicular. No angulation should be there, otherwise the attenuation of the energy will be different at different places. Then forced inspiration or expiration result in reduced accuracy, and poor respiratory control also make acquisition a challenge. Next is fibroscan. The fibroscan, it is not done in ultrasound machine, it is separate machine we are using. In generally a transducer is there is no 2D imaging, we can't see any other thing as on ultrasound. Only here the transducer transmits a low amplitude signal to the liver which induces an elastic shear wave. A pulsed echo ultrasound acquisition is performed to follow the shear wave and measure the wave velocity, that is done in kilopascals. So here one vibrator will be present which will give cause a vibration, and a measurement will be done from 2.5 centimeter below the Gleason capsule and up to 4 centimeter up to the depth of liver. Validation will be only provided if 10 measurements at least are taken. Ratio number of valid measurements to be total number of measurement is more than 60%, and interquartile range, which reflects the variability of measurement, is less than 30% of the median value of liver stiffness measurement. Then grading is done at F0 to 1 if there is normal to mild fibrosis, F2 is significant fibrosis, F3 is advanced fibrosis, and F4 is cirrhosis. So this is the Metaway system which also correspond to the Ishak system. So in F1, the kilopascal range will be around 5.48 to 8.29. F2, it will be like 8.29 to 9.40. F3, 9.40 to 11.9. And in cirrhosis, F4, it will be more than 11.9 kilopascal. With increase of fibrosis, there will be also an increase in portal pressure as fibrosis increases, and that can also be measured. Which is, this portal pressure measurement is usually done in hepatic venous pressure gradient. The staging is important because it helps to assess urgency for the treatment, surveillance in cirrhotic patients, baseline for treatment response, tailoring for treatment algorithms, and drug reimbursement. The main clinical indication for liver elastography is to stage the chronic liver disease and the main objective of determining the presence or absence of advanced fibrosis. The most important question is if chronic liver disease is progressing to cirrhosis. So in no or minimal fibrosis, we can do no immediate treatment can be done. It needs a follow-up based on clinical factors. Mild to moderate fibrosis, based on other clinical factors, treatment can be done and follow-up can be done. And in severe fibrosis, we have to screen if the patient is compensated or decompensated liver disease, or screening for HCC should be done. Takeaway message: 2D ultrasound is qualitative assessment of non-alcoholic fatty liver disease. Quantitative ways of assessment are elastography and fibroscan. The aim is to assess the fibrosis and its progression to cirrhosis, and also for follow-up of patients. As non-invasive procedure, we can use it widely without painful experience for the patient. However, biopsy always remains the gold standard.
Thank you, Dr. Shrestha, for presentation. And due to paucity of time, we can allow only one questions, if there is any. Actually, this fibroscan is definitely better, but it is costly to the patient. And if we go for this shear wave elastography in patients, which is less costly, and we can get a good result with experienced radiologist. So that is the main theme of this lecture, to provide you the information. So thank you all for your patient hearing, and we are concluding the session.
One question. In clinical practice, which one is more convenient, that is the fibroscan or elastography, to measure the liver
Elastography
stability?
is better than fibroscan, because in fibroscan we are only getting a value and we are not able to see any other thing, like we don't have an ultrasound mode there. But in elastography, along with the values and stiffness and everything, we can also associate other findings, whether the liver ecotexture is normal, ascites is there or not, portal hypertension is there or not. So always elastography is better than fibroscan.
Thank you.
Thank you.
Thank you, ma'am. Just be there. So I'm requesting Dr. Sujun Sarkar sir for felicitating our speaker and chairperson. A big round of applause for the nice presentation, and make some noise also. Make some noise. Thank you, ma'am. Thank you for the nice presentation on imaging of non-alcoholic fatty liver disease. Moving towards the next session, it is precious insulin treatment, maximizing use of Gen 2 basal insulin across patient population. For that, I am requesting Dr. Dinobandhu Naga and Dr. Rakesh Kumar sir to take the chair. So, I am requesting Dr. Dinobandhu Naga and Dr. Pradeep Ganguly sir to take the chair for the next session. Precious insulin treatment, maximizing use of Gen 2 basal insulin across patient population. Over to you, sir.
Good evening to everybody. My dear student, my dear colleague, and respected and learned faculties in front of me. And thanks to 10th ABCDcons, we are getting very important day-to-day life using patient caring procedure today. Again, another interesting and very useful topics, precision of insulin treatment in and basal insulin in diabetic patient. As we know, almost 100 millions of diabetic patients in India. So, how important it is. So, we are using oral anti-diabetic drug as well as insulin, but by waiting the drugs and insulin sometime must use. So, during insulin use, we need some precision regarding insulin itself and patient's quality. And for this reason, these important topics, Dr. Subir Rai, sir is ready to deliver his important speech in this regard. Sir, please start.
Thank you very much. Good evening, everybody. Thanks ABCD for inviting me. It's homecoming for me. I belong to this place. Sorry for my voice. It's kind of good to get it back after 2 days. I could not speak last 2 days. Today's talk is about precision insulin management, and since it's a sponsored topic, I'll focus on insulin U300 glargine, that is 2GO, which you call. But I'll start with a bit of reality check. If you look at the landmark trial finding, landmark was a first large-scale longitudinal prospective observational real-world study to investigate the management and complication of type 2 diabetes across India over 3 years period, and I was a primary investigator of that trial, and what we could see was stark reality, the naked truth. So what we are sitting here discussing diabetes and all other things is actually hogwash. We are not doing good at all. Otherwise, 80% of our diabetic patients wouldn't be uncontrolled. So if we talk about ICMR in DIAB study to be true, then we are talking about 15 crore Indians suffering from diabetes, and 10 crore of them are uncontrolled. And not only uncontrolled, only 1 in 4, that is only 25% of those patients, despite being uncontrolled, only 25% of them are actually taking insulin. So who to blame? We are to blame, okay? We cannot just blame the poor patients, okay? They come to us with all kind of an expectation, and it is our responsibility to guide them through. And when you actually start insulin, the HbA1c is through the roof. It's 9.2%. So how does it go wrong? This is how it goes. When a patient comes to us, we give them all kind of, sermons, knowing that, I do not do exercise regularly. How can my patient do it regularly? Okay, so we have to bring something tangible on board. But unfortunately, we start with a anti-hypoglycemic agent 2. Many times, we are actually more courageous than our Western counterpart about starting combination medicine. Start early. We do it. We certainly do it early. Okay. You may debate whether the combination we start is a rational combination or logical combination or scientific combination. But believe me, I have worked in different parts of the world, and we are not bad. Okay. And we start with at least 2 oral hypoglycemics in majority of the situations. Now, after a few years, when the patient is seeing that the blood sugar is not staying down at all, then the patient comes back to the doctor, and we start a 3rd one and a 4th one, and many times a 5th and the 6th one. And then we run out of our weapons, and we believe that God allow this patient to go to another doctor. Let him start insulin rather than me starting insulin. Because we believe that insulin is a baggage. it should not be started by us, the holier than thou busy doctors, giving all kind of excuses of not starting insulin. But in the meantime, when somebody, unfortunate colleague of us, actually start insulin, around 8-9 years is gone, and in the UK it is 11 years. They're worse than us, okay? Because they follow a certain guideline. Start with one OHA, go to second and the third and the fourth and the fifth and the sixth, okay? And then they say, well, if you run out of third OHA, think about insulin. Many times they don't come back. Same to us. They don't come back to us for insulin. But if we think that, okay, fine, don't blame each other, let's start insulin. What kind of insulin do we start? We start with the easiest insulin. And what is the easiest insulin? Basal insulin is the easiest insulin. It's not a fact that I am in favor of basal insulin because I'm a basal man. I grew up with basal insulin. I learned diabetes not in India, in the UK. So I did not have the influence of premix insulin on me. So I started learning insulin as a basal insulin. And what do we expect as a patient? What do we expect from a basal insulin? It has to be effective. It has to be at least 24 hours working. It should not give us fluctuation, that is the glycemic variability. It gives us less hypoglycemia. It does not give us too much of hyperglycemia, that is, it keeps the blood sugar in range most of the time. It can be used in a dicey situations like elderly patients, like younger patients, like pregnant patients, like patients with renal impairment, like patients with hepatic impairment, etc., etc. So a patient wants this kind of, a wholesome package in the insulin. And I believe that despite calling insulin glargine U100, which is still today, it's a gold standard insulin, we were lacking a few things from Gen 1 basal insulin analogs, that is insulin glargine as a prototype. So the scientists have been looking for a better insulin, and we have got Gen 2 basal insulins, okay? And we have got insulin U300 glargine and insulin degludec at our disposals. And very soon we'll be having once in a week insulin as well. So what did insulin U300 glargine as a Gen 2 basal insulin brought on board? It brought on board a robust glycemic control as good or probably better than Gen 1 basal insulin glargine. And in the run, we are getting less of hypoglycemia, okay? So what the patients were asking from us are actually being ticked by the Gen 2 basal insulin. If you look at this part, does it work? It doesn't work. It should work actually. So if you look at the right-sided cartoon, whether we can start it safe without too much of hiccups, yes. Minimal weight gain, yes. Flexible dosing, can I take it at 8 o'clock today and 10 o'clock tomorrow and 7 o'clock day after tomorrow? Yes, you can. Does it cover me the whole day? Yes, it does. Does it give me too much of fluctuation? It gives less fluctuation. You cannot say it does not give any fluctuation. Everything gives fluctuation. It gives less fluctuation. Does it give me sustained sugar control? It does, like Gen 1 basal insulin if you use it properly, if you do not default. And does it scare me with hypoglycemia in the middle of the night when nobody is around, not even you, doctor, you do not take phone calls, your assistant is as a BCom. Yes, it does give you less of nocturnal hypoglycemia. So you can see that Gen 2 basal insulin is actually ticking all the boxes. Now, do you have any evidence? Is it all big talks? Let me just quickly go through the evidence. What's been generated over the years by Gen 2 basal insulin Toujeo or U300 basal insulin? You can see that it has ticked all the boxes of pharmacokinetics and pharmacodynamic study to show you the fluctuation level in type 1 diabetic patients, where you do not get the influence of de novo insulin secretion or de novo de novo insulin resistance and secretion, C-peptide levels, etc. Etc. is a pristine situation. Then you have pitted the insulin U300 glargine against its own sibling U100 glargine in addition trials. Then you've got the real-world studies like ATOS. Then you've got the type 1 diabetic patients to see whether the evidence of infection. Then you've got few studies where it was pitted against his own peer, that is insulin degludec or Tresiba insulin. Is another second-generation, brilliant second-generation basal insulin. This talk is not to blame any other insulin. This is to see that insulin 2G-U300 itself is a great insulin. It doesn't need to blame any other insulin to get the merit. Okay, so we have got all kind of studies, right from pharmacokinetic, pharmacodynamic studies to head-to-head studies, comparison with the other Gen 2 basal insulin in vulnerable population. Coming to the vulnerable population that I was trying to say, CKD and elderly patients, you can see that in elderly patients, there are several studies. It's not dedicated towards elderly patient, but in all those studies, you had a pool of dedicated patients, a cohort. You can say elderly cohort or geriatric cohort. In addition studies, in head-to-head studies with insulin glargine U100, you can see there is equal HbA1c reduction with almost 20% less risk of hypoglycemia, which is immensely important. In elderly patients, we are not really worried about hyperglycemia control. We are worried about hypoglycemia prevention. Because if you remain the patient in a decently controlled blood sugar, the patient will live with us till late 80s. But with a bad hypoglycemia, with a bad atrial fibrillation or arrhythmia, the patient will be off in 5 years' time. Okay. In 2 studies, there is robust HbA1c reduction of around 1.76 in 1 year time with less hypoglycemia. In BRIGHT study in the elderly cohort, it can say a greater HbA1c reduction in comparison to insulin IDEC 100. And in DELIVER studies, there is 48% lower event of hypoglycemia compared to glargine U100. In the renally compromised patients, you can again see that in addition trial, there is almost 20% less hypoglycemia with equivalent HbA1c reduction. You can see in DELIVER studies, where it's a high-risk DELIVER study. Actually, in patients with renally compromised patients, there is 27% lower risk of inpatient or ED-associated hypoglycemia. So hypoglycemia has consistently been addressed by the Gen 2 basal insulin glargine U300. BRIGHT study is a renal cohort of the BRIGHT study, which is a head-to-head study between Tresiba and 2GO. You can see that Tresiba did very well, actually, even in patients with less than 60 eGFR. You can see the HbA1c reduction is better than Tresiba. Okay. I'm not going to getting into the detail of a BRIGHT study. It's another talk altogether. If you look at the ATOS renal, ATOS is another study. I was as a primary investigator there. You can see that if you look at the comparison between the with normal renal function and patients with compromised renal function, you can see insulin 2GO actually did better in patients with compromised renal function. You can see the HbA1c drop. And on the right side, if you look at the secondary endpoints, after 6 months and 12 months, you can see it did better, if not equally, in patients with a renal compromised state rather than patients with normal renal function. Really, European pool data analysis is again to see the performance, both the HbA1c reduction and hypoglycemia events in patients who have switched from one basal insulin towards insulin U300 glargine. It's the European data, and it showed that after 24 weeks of insulin U300 glargine therapy, there is decrease in HbA1c reduction from the baseline was better, and they had a less hypoglycemia overall. The total insulin requirement in the insulin U300 glargine was 0.07 unit per kg per day. That equates to around 6 units per day. So that was what the really pooled data suggests. This is DELIVER high risk in real-world studies. Again, in a real-world studies, a high-risk renally compromised population. As a retrospective observational cohort study of around 2,500 patients with type 2 diabetes who have switched from other basal insulins to insulin 300 glargine. And what we saw is a better HbA1c, similar HbA1c reduction with a better hypoglycemia profile. This is ATOS elderly study coming to the elderly population from the renal population. Again, you can see that patients with age of more than 70, they did equally better compared to patients who were less than 70. So not only they did better, they had less hypoglycemia as well. This is the DELIVER-3, again is in the elderly patients. Again, you can see that insulin U300 glargine did better with less hypoglycemic events in elderly population. So the conclusion of the DELIVER-3, which is a high-risk population trial, results that demonstrate that switching to insulin U300 glargine in older patients more than 65 years with type 2 diabetes, as well as similar glycemic control. And nowhere in those studies it tried to show that it is a better insulin HbA1c wise. Majority of the time, the basal insulins, they do not try to see whether we are getting better HbA1c, because we can get equally good HbA1c with insulin U100 glargine. It is to see whether you get the hypoglycemia events less than what it used to be before. And the potential implication of the real-world study is that the improved glycemic control and lower hypoglycemic risk could lead to better treatment persistence, improved treatment satisfaction, and lower healthcare cost. That is the most important part. If a patient gets admitted in the hospital with hypoglycemia, the whole costing goes out of the window. One hospital admission in ICU is anywhere, it's 25,000 to 2 lakhs in different hospitals. So that is equivalent to 1 year cost of insulin therapy. So any hypoglycemic prevention is wonderful. In senior study, this is the open-label senior RCTs, and insulin glargine 300 was effective in more than 65-year-old persons with lower rates of anytime documented symptomatic hypoglycemia versus insulin 100 glargine. You can see the points falling on the left side of the line of neutrality favoring insulin 300 glargine, whether it is hypoglycemia at any time of the day, confirmed or severe, or documented or symptomatic, and nocturnal hypoglycemia. All of them are favoring insulin 300 glargine when compared to insulin 100 glargine. Same for patients who belong to more than 75 years age group. Coming to last bit, type 1 diabetic patients, again you can see that compared to IDEC 100, the fluctuation is slightly less. Well, you can get a similar type of trial with the different types of result from the Novo Nordisk group, but that was on insulin IDEC 200. Mind it, it's not 100. This is against IDEC 100, and you can see there's a 25% lesser risk of day-to-day variability with insulin U300 glargine. This is a one-care study, it's a real-world study in adults on type 1 diabetes CGMS. Again, you can see that it says the more time spent in the range, time in range is a new metric you use nowadays. We want the patient to stay more time between 70 and 180, and insulin 2G has shown that the patients stay having more time in the range and less time above range and less time below range. More stable glucose profile compared to time and less glycemic variability and reduced nocturnal hypoglycemia versus U100 glargine. Again, it's a variability profile checking, and it showed that it is certainly better than insulin U100 glargine as far as day-to-day and intraday variability is concerned. Glargine is a flat insulin mostly, but it has got a small peak 6 to 8 hours after the injection, which you cannot avoid. This is the Orion study on patients who are actually going into Ramadan, and it showed that both in global Orion and South Asian Orion, you get less of hypoglycemia with U300 glargine. We always have a fear of having hypoglycemia when you treat people with insulin and they go into Ramadan. Many Muslim patients of ours are devout Muslim, and it is very difficult for them to skip Ramadan. So we have to make their life easier so that they can continue insulin without really getting into bad hypoglycemia. And insulin U300 glargine can solve that problem to some extent. I'll just skip this one. This is the detail of the study. Coming to the last bit, IPD and pregnancy. This is the trial to show the efficacy and safety of insulin glargine 300 and insulin IDIC in glycemic control using CGMS in hospitalized patient. And again, you can see that the incidence of time below range is markedly lower with insulin U300 glargine. It's not a fact that you cannot use Gen 2 basal insulin in the hospital. I do use, all of us nowadays use it. You can probably change the dose almost every day without bothering because you are checking every day. So you can use it and you expect lesser hypoglycemia with Gen 2 basal insulin. This is U300 glargine in pregnancy. We do not have huge data, but whatever data we have is around 1,000 people who were given U300 glargine, and it was not associated with any specific adverse pregnancy outcome and was as safe as Gen 1 basal insulin, Levemir, and insulin 1 U100 glargine. So if it is indicated, you can certainly go ahead and use it. You know, having a good device makes life easier for the patient. So probably you have seen this device. So it's dedicated cartridge. It cannot be used with anything else. Clear dose display and simple dose delivery makes it easier to deliver. So insulin U300 glargine has ticked all the boxes in type 2 diabetes and type 1 diabetes, especially in different settings with oral hypoglycemics, with GLP-1 receptor agonist, as basal-only therapy or basal bolus therapy in type 2 and in type 1 patient in different trials like Edition Junior, in older patients, in CKD patients and other patients. It has shown to be effective, safe, durable, and easy to administer Gen 2 basal insulin, which tick most of the boxes and addresses the expectation of both the patient and the doctors equally. Thank you very much.
Thank you, Dr. Rai, for your very lucid presentation for glargine 300. Actually, glargine 300 is very, as you already said, that is very safe for hypoglycemia. It doesn't cause hypoglycemia, safe for renal compromised patients, safe for elderly patient, and you have compared with the deglutec with the glargine 300, and you have proved safety, better safety in renal compromised patient. But glargine actually attacks, controls the fasting first. Later on, the postprandial to some extent is controlled. In our clinical practice, we often see the patient's fasting is well controlled, but PPG level is quite bit high, even with higher dose of glargine. In that case, do you suggest any bolus or any oral medications?
Well, I mean, I believe in fixing the fasting blood sugar first, unless right from day one the PP sugar is out of sync. So unless you control fasting, you cannot control PP, because if your day starts with 200, your blood sugar will be 300 after meal anyway. So you'll have to start the day with 100. So they expect the PP sugar to be less than 200. Of course, once your basal insulin requirement is more than 0.4, 0.5 unit per kg body weight, you have to have bolus insulin on board. And then you start with a basal plus or basal 2 plus or basal bolus therapy. Or you can switch to premix insulin if you're comfortable with it.
Thank you. Any question from the audience?
Changing from glargine 100 to 300, I am asking the question. You are giving the same amount of insulin, except in a lesser volume.
Yeah.
So why does this incidence of hypoglycemia is less?
Yeah, because the absorption is slower.
Much slower than
whenever you reduce the surface of the insulin, the volume of the insulin is the surface, okay? So if you reduce the surface of the insulin, insulin inject, the absorption it slows down. Larger the surface area, larger the absorption surface area, faster the absorption. So if something is getting absorbed slowly, the chance of having hypoglycemia is much less. Like if your shower is trickling 1 drop of water every second, the chance of you getting drenched at one go is less. Simple as that. Dose modification. You start as... No. If you suppose somebody is getting say 40 unit of insulin glargine EU100, your pain will inject only 40 unit. The volume will be less. The cartridge is calibrated that way. That's why this cartridge cannot be used in insulin EU100 pen. It's unique. It cannot be used with any pen whatsoever. So if you shift from insulin EU100 glargine to EU300 glargine, it is almost dose to dose shift. You might feel that the patient will require a little more insulin in some situation, but you switch from dose to dose. Okay. If a patient is getting 20 units of EU100 glargine Lantus and you want to give 2-0, you start with 20 units of 2-0, not 16 or 1/3 dose. No, you don't, because the pain is calibrated. The volume will be less, but unit will be given same.
So thank you.
300 ml মধ্যে 450 ইউনিট থাকে.
So thank you so much, audience, and thank you, sir, for the nice presentation. Sir, 1 minute hold. Just I will request Shuma sir to felicitate our respected speaker, sir. A big round of applause, please, everyone, and a little more noise. Sir, a big round of applause, please. Thank you so much, sir, for the nice presentations. Now we are standing on the last session of the day. Recent updates in tuberculosis management. For that, I am requesting our chairperson, Dr. Tushar Kanti Botobal sir and Dr. Shubroto Kundu sir to take the chair and initiate the session. Our last session of the day, recent update in tuberculosis management, and chairperson Dr. Tushar Kanti Botobal and Dr. Shubroto Kundu sir requesting to initiate the session. Ahead. Over to you, sir.
Thank you. Audible? Hello. আমরা যখন স্টুডেন্ট তখন একটা কথা ছিল, ডক্টর অবনী রায়চৌধুরী আমাদের ছিলেন, হেড অফ দ্য ডিপার্টমেন্ট, উনি একটা কথা বলতেন যে তুমি সারাতে পারবে সেইগুলোই যেগুলো ইনফেকশাস ডিজিজ, বাদবাকি আর তুমি কিন্তু কোনো ডিজিজই কিওর করতে পারবে না, দে উইল বি আন্ডার কন্ট্রোল। সো রূপম টিউবারকুলোসিস নিয়ে বলবে, যেটাকে অ্যাকচুয়ালি সারানো যায় এখন, কিন্তু আর যে ক্রনিক ডিজিজ আছে যেগুলো বলে লাইফস্টাইল ডিজিজ, এটা কোনোদিন সারবে না, যতদিন বাঁচবে ততদিন ওষুধ খেতে হবে। বাট ফর টিউবারকুলোসিস or other infectious disease, you have to take a short course of drug, and that time the disease will be cured, not controlled, it will be cured. So let's talk about some disease which can be cured. Where is Rupam? You come and Rupam give an overview of the recent trends in tuberculosis.
আচ্ছা, বয়স হলে একটু মানুষের বকবক করার ইচ্ছা হয়, আমি একটু বলি দু একটা কথা, যে আমাদের মাস্টারমশাই বলতেন যে if you know tuberculosis, you know medicine, because tuberculosis can affect each and every part of the body. আরেকটা কথা কি, যে এই রোগটা যে কত ইম্পর্টেন্ট এখানে আমাদের সব ডাক্তার বন্ধুরা রয়েছেন, তাদের বুঝিয়ে বলার দরকার নেই। গোটা পৃথিবীতে যত টিবি রোগী আছেন তার 27% আমাদের দেশে বাস করেন। আর এই রোগটা যদি ঠিক মতন নির্ণয় না হয় বা ট্রিটমেন্ট না হয় তাহলে 50% মর্টালিটি, এটা খুব কম কথা নয়। এবং ইভেন টুডে দ্য মর্টালিটি in India out of tuberculosis every year near about 5 lakhs. সুতরাং the need of diagnosis and treatment of tuberculosis can never be overemphasized. With these few words, I would like to invite Dr. Pomta to throw some light on the recent updates in tuberculosis management. Dr. Ta.
Respected Chairperson, sir, and dear colleagues, this is the last topic and recent updates in tuberculosis management. So we'll go through the history of the disease, basic facts, evaluation of the TB control of India. Government declared tuberculosis is an emergency. Fight against TB, ups and downs, present strategy control, TB control program and the TB preventive therapy. Now we are looking towards those who are infected but not disease, also we are looking, that is a latent TB. And adult BCG vaccination. This vaccination has now again come back after Chengalpat trial reassessment. And shorter MDR TB. Now we know that MDR TB treatment is around 2 years. Now it has come down with the good drugs, it is 6 months only. So who is C? This is Kamala Nehru. Why C is important for us? Kamala Nehru died due to tuberculosis. Former First Lady of India, Kamala Nehru died due to tuberculosis at the age of 1936, and in Switzerland, where at that point of time the treatment was, there is no chemotherapy. Treatment was sunlight, rest and nutrition. So in sanatoria-based treatment was available at that point of time. After the death of Kamala Nehru, that was the eye-opener for us, what is the situation of tuberculosis in India. 1950 to 1960, government launched one study that is called National Sample Survey by TRC Chennai and NTI Bangalore. They decided that TB is everywhere it is present, not the age, sex, religion, caste, color, nowhere, everywhere it is there. And government started one program on the fact of the NSS, National Sample Survey, one of the biggest survey, that National Tuberculosis Control Program or National Tuberculosis Program in 1962. In 1992, after 30 years, government reviewed the situation, what happened for these last 30 years. They have seen that only 30% patient diagnosed and out of them, only 30% successfully cured. So the large amount of patients are not cured or anywhere they are going. And they are spreading the infection everywhere. Then 1993, government started another program that is called RNTCP, Revised National Tuberculosis Control Program, that was scaled up. 2004, 80% of the covered in India is covered by the RNTCP, that is DOTS therapy, directly observed treatment short course. That is our drug will be delivered by our health personnel and everything jumped on us, that responsibility on us. Then 2010 DOTS Plus program, that is for the MDR patient. Now the PMDT, programmatic management of drug resistant TB came. Then in the meantime one revolution come of the genetic study of the TB bacilli, that is CBNAT, Curtis based nucleic acid amplification testing. Then from the DOTS, that is a thrice weekly treatment, converted into, due to some reason, converted into daily regimen and fixed drug combination. In 2017, government declared all through the program, that is National Tuberculosis Elimination Program, and end TB by 2025. So now in 2024, we have now in this era, the implementation of the Psi-TB intradermal test instead of MANTU test, the Psi-TB test, government rolled. Then adult BCG program, re-evaluation of the Chengalpat trial, that is the re-evaluation for the adult vaccination. and introduction of the 6 months B-PAL-M regime. This is the government's program, B-PAL-M regime for the MDR and XDR TB patient. Facts, it is highly infectious, and the bacterium, Mycobacterium tuberculosis typically affect lung, but all the organ could be involved. Transmission to the airborne infection, droplet nuclei and droplet infection, person's cough. Cough is very high speed velocity of the air is coming to that. It is a 3000 droplets and its speed is around 50 miles per hour. And each droplet contains 3 AB bacilli. Bacilli can stay for at least 7 to 10 days in the dried air also. So whenever the patient comes, whom we will see that is a TB patient, whom we will suspect that is a presumptive pulmonary TB. Any patient who is having the symptoms and signs suggestive of TB, including cough for more than 2 weeks, fever, significant weight 2 weeks, and weight loss, hemoptysis, any abnormality in the chest X-ray, we can consider him as a presumptive pulmonary tuberculosis and send for the sputum examination. And presumptive extrapulmonary organ-specific symptoms along with the constitutional symptoms like fever, night sweat, and the weight loss, loss of appetite. Presumptive pediatric, not weight gaining. Cough is there, fever is there, not weight gaining, and history of contact is present. That is a presumptive pediatric TB when we suspect and send the sample for the examination. Presumptive DR TB means those drug-resistant TB, those who are taking the first-line drugs, not responding, you should consider them as a presumptive DR TB. Detection test, MANTU nowadays is getting fading away, MANTU, because there is a cross-resistance with the BCG. Our population is already BCG vaccinated, so MANTU will be positive. So it will not give any idea. The PSI-TB new intradermal test has come up to eliminate that particular part. And sputum smear examination by Jill Nielsen, and nowadays fluorescent microscopy, culture by the solid media, and automated media by the MGIT, Mycobacterium growth indicator tube, and drug sensitivity by the modified proportionate sensitivity testing by liquid culture, and LJ media also is there. And now we are having rapid molecular diagnostic testing by the gene of the TB bacilli. That is by means of line probe assay. It will first line probe assay will give you the INH rifampicin. Second line probe assay it will give you the fluoroquinolone, second line injectables and other drugs. And last is that for the immediate getting the result of the NAT, it will take hardly 2 to 3 hours to get the NAT result. CBNAT will give you the idea regarding the TB bacilli is present or not, and it is resistant to rifampicin or not. So CBNAT will within 2 hours, our patient will get the idea bacilli is there or not. If low is as much low as 15 bacilli per ml of sputum. Sputum smear microscopy require 10 to the power 4 bacilli per ml of sputum, but CBNAT require only 10 to 15 bacilli, and moreover that you will get the idea regarding the rifampicin resistance pattern. So it will be more and more helpful. So this is the diagnostic algorithm. We will presumptive TB case, those who are suspecting, go for the smear as well as X-ray, and according to that we will classify the 2 type of case. One is microbiologically confirmed TB, that is this sputum A, B, CBNAT, whatever that is positive, and another is the clinician can decide the thing that is clinically diagnosed tuberculosis. They also perform all these tests, but still his clinician is thinking that patient might have tuberculosis. So he can give the drugs and the full course drug, and suspicion should be quite good enough that he is diagnosing. So 2 type of TB patient nowadays. One is microbiologically confirmed, another one is the clinically diagnosed by the physician with good suspicion. So our regimen, drug sensitivity regimen is 2 HRJD in intensive phase 2 months, 4 drugs, INH rifampicin, ethambutol pyrazinamide, and 4 drug HRE. And you can extend the drugs if required. Some textbook in neurology, orthopedics, they have given the skeletal TB, neurological tuberculosis, and difficile tuberculosis. You can increase the dose, increase the duration of the treatment. That NTP is flexible. They can give the drug according to your suspicion. They can increase the dose and increase the duration also. So we used to give the drugs, all the drugs are there because of their fixed dose combination. So we are having 5 weight band from the 2 tablets to 6 tablets according to their body weight. This is called weight band preparations. It is available. TB is a notifiable disease. You can treat, but you should have to notify. This is our fixed dose combination. All the drugs are there. If you can give the drugs individually, you can give it, but it is not very much not available in the market. Isoniazid 5 milligram, rifampicin 10 milligram per kg, pyrazinamide 15, ethambutol 15, and streptomycin 15. Pyrazinamide is 25. Okay. Then another trial has come, that is called truncate TB trial. Cut-chat kore dao, TB drug take cut-chat kore dao. Truncate TB trial with the new advance of the drug like bedaquiline, linezolid, and clofazimine. Linezolid is a very good anti-TB drug, but very toxic drug. So you can, they can reduce the duration up to 2 months. There are very good data are available of the truncate TB trial. Most probably next 2 to 3 years we will get this 2 months regimen of this particular trial drugs, various combinations. And that will be cured if the patient, pura course pakka ilaj, patient has to take the full course of anti-TB drug, the disease will be cured. Our success rate with the 2 HRJD plus 4 HRE is around 96%. Patient has to take the full course of anti-TB drugs. If the patient if the sputum is available, then we can say consider this cure. If the sputum is not available or sputum is negative, we can say sputum is not available. At that point of time, patient can be treatment completed. Then failure means not responding. We have to go for the MDR TB treatment. Defaulted, taken, somewhere he has gone, died due to any cause, lost to follow up, not evaluated. This is our outcome, final outcome. Regimen change from the one regimen to other regimen because of some toxicity. So we can go the nephrosafe regimen, hepatotoxic drugs are there. So hepatosafe regimen, we can change it. So this resistance pattern could be isoniazid resistance, that is called isoniazid resistant, monoresistance, any drugs. Polyresistance means more than one drug other than HNR. Rifampicin resistance is the only rifampicin along with the ethambutol could be there, but the rifampicin resistance can be considered in the programmatic purpose as a MDR treatment, like same as MDR. RR resistance means rifampicin resistance considered MDR. MDR is the isoniazid and rifampicin along with that maybe additionally fluoroquinolone and SLI. Another one terminology has come up, that is pre-XDR, means MDR plus fluoroquinolone resistance is called pre-XDR, and XDR is extensively drug resistance, means MDR isoniazid rifampicin has gone. Now again another one levofloxacin or moxifloxacin gone. Another one first this drug of bedaquiline or linezolid, that is group A drug. This is the grouping of the drug which are available with us. Group A are very, very important drugs. We have to give all three if possible. Moxifloxacin, levofloxacin, bedaquiline and linezolid. Group B drugs should be added. At least 3 to 4 drugs is required for MDR treatment. One is clofazimine, very good drug. Cycloserine, teridone. Group C drugs under evaluation. They are going on ethambutol, delamanid, pyrazinamide, imipenem cilastatin, meropenem, and amikacin, ethionamide or prothionamide and PAS. Other few drugs are there for the extrapulmonary tuberculosis or atypical mycobacteria for them. So our H monopoly regimen, only INH resistance pattern, so the INH will be taken off, 6 to 9 months regimen, levofloxacin, rifampicin, ethambutol and pyrazinamide. That is called H monopoly regimen. Longer regimen, 18 to 20 months. Now we are shifting back. Levofloxacin, bedaquiline for 6 months, linezolid, clofazimine, cycloserine. Shorter 9 months to 11 months, that was shorter MDR regimen, that was the levofloxacin, clofazimine, pyrazinamide, high dose INH, ethionamide. 5 months continuation phase is the levofloxacin, clofazimine, pyrazinamide, ethambutol. High dose INH is taken off, bedaquiline for 6 months only, and the ethionamide due to hepatotoxicity we have taken out. So these are the regimen which are available till date. But new development is the BPL-M regimen. Government roll over this regimen for the 6 months regimen, bedaquiline, pritomanid and this derivative of delamanid and linezolid and moxifloxacin. This is a very good combination and is only 6 months therapy. These are now what is the status of this BPL-M regimen for MDR cases above the age of 40, microbiologically confirmed TB, not very severe tuberculosis, no QT prolongation, AV block, nothing is there. So you can continue the BPL-M regimen which government is giving for the 6 months only. No significant non-lactating mother, not severe case, because it is running fast. So we are giving this particular regimen for the selective group of patients. When we will get some more information, then we can start more and more with this regimen. So adult BCG vaccination. After Chengalpat trial re-evaluation, that is 50 years ago we have given the Chengalpat trial of the BCG. So now they are evaluated that those who have taken the BCG after 60 years ago, for 50 years ago, now they have a reduced chance of tuberculosis. So from that study, many countries they are giving the repeated BCG. Government of India has given the BCG vaccination in adult BCG vaccination program. That is, again, it is coming up. So inclusion, all the patients, those who are taking the medication, after completion of the medication, those who are household contact, diabetic patient, at the age of more than 60 individual, smokers, they are included in the study. This regimen, particularly BCG, adult BCG vaccination. So individual who receive BCG vaccination and after eligible for TPT means TB preventive therapy, after 4 weeks, patient is taking the TB preventive therapy. So after 4 weeks, they can get the BCG vaccination. So contacts, TB patients contacts are there. There are two types of contacts. Contacts mean individual who are exposed to a person with active TB disease. Household contact, close contact. Household contact means same, they are taking from the same kitchen, they are staying in the same roof. And close contacts means in the office area, or in the parking area, or in the other areas, that is called close contact. Household contacts and close contact. Your high TB, these are for the contact detection, and they are having the positivity or not to see the infection is there or not to high TB test. That is intradermal test, same like of MAN2, but it is not with not like MAN2 fully because of it is not interfered by the BCG vaccine. 5 millimeter and above is the induration, not the erythema, is considered as a positive that is infected by TB bacilli. This is Government of India's data. And antigen which they are detecting for this antigen, our MAN2 is for the PPD, purified protein derivative, our gamma IGRA is the gamma interferon assay, and CFT, culture filtered protein or early secretory antigen for the 6 for the psi TB detection. Psi TB is very, very sensitive. When the sputum is negative, everywhere negative, but you are suspecting, you go for psi TB. If psi TB is positive and you are suspecting, you give the full course of therapy. If you see the contacts or this thing, you can give the TB preventive therapy also. It depends, clinical judgment should be there. So what is the treatment for the contacts? For DSTB, drug sensitive TB patient in the house, so contacts will get the 6 months of INH 10 mg per kg body weight with pyridoxine or 3HP, rifampicin and isoniazid 3 months we will give them weekly once for 3 months. That means total 3 months you will get the 12 doses of isoniazid and rifampicin. Rifampicin has a good sterilizing drug. And for the DRTB contacts, having patients in the house, there is a DRTB patient, drug-resistant TB patient. For IH monopoly patient, you will get the 4 months of rifampicin. For rifampicin resistance patient, get the 6 months of fluoroquinolone if fluoroquinolone is sensitive. Or the 6 months of INH if the fluoroquinolone resistance, INH sensitivity is there. For the DRTB contacts, government is getting all these areas now. The contacts as well as outside population who are all the latent TB infection by which they can cure, they can sterilize the community. So TB is a notifiable disease. It is notifiable because you are supposed to notify. IPC 269 and IPC 270 is incorporated. Act of omission, negligent act to likely to the spread of the disease and dangerous to the life. Act of commission, you not perform this particular treatment procedure which are government given. 270, that is a punishment. But they have given incentive. That is we used to say carrot and stick. For the private provider, get 100,000 rupees. For the TB notification, 1,000 rupees from the any laboratory, any private practitioner, hospital, chemist can get the amount, and patient will get the 500 rupees per month, daily, every day for the direct benefit transfer for the nutrition and journey. And also the DOTS provider who is giving the medication, he will also get the drugs. So let's join hand together. The TB Harega Desh Jitega campaign. So take home message, one of the oldest disease, few years of the primary infection, early diagnosis and the universal drug sensitivity by the CVNAT. EPTB diagnosis is challenging. All from the TB is treatable, including EPTB, and it is curable. Vaccines against tuberculosis was rolled over now. The treatment of the contact and vulnerable population and treatment of latent TB is also available. So everything is in your hand. The choice is yours. Give the benefit to all these anti-TB benefits to the patient to take our program that end TB by 2025 and eradication of 2036. Thank you.
I got one question, Dr. Ta. Is this high-TB skin test
High-TB test
available in Bardhaman?
Bardhaman it is available. Bardhaman it is available. Now they have stopped the intradermal test, this Mantu test. Previously Mantu test we used to do, but nowadays it is available, the High-TB test. It is the same type of that culture filtered protein 10 we used to detect. And IGRA is available. IGRA is costly. Interferon, gamma interferon, same type of antigen we used to get the gamma interferon amount, because when the TB bacilli is infected with this WBC, so they used to release the gamma interferon. Yes.
Another question: how to manage total drug resistant tuberculosis?
Total drug resistance. Total drug resistance is terminology is not available in our books and our guideline. Government used to say not to utter this total drug resistance because the drug number is huge, and you cannot say. Some physicians are there, they have done all these things, and they have mainly Mumbai people, they are the sets of doctors are there, they have published the data that regarding the TDR. But government is saying that our list is very long. There's a lot of drugs are in the pipeline. The pretomanid, which is available, but you have no sensitivity testing. You do not know whether the pretomanid is reactive. So they now come down. The TDR, the total drug resistance, is not available in our book, not available in our guidelines. So I cannot utter the TDR. But TDR, but we are not supposed to say that. If you have any idea, you can share. Yes. Yes. Sci-TB.
Sci-TB যে টেস্টটা আছে,
yes,
intradermal test extra pulmonary tuberculosis জন্য ইম্পর্টেন্ট,
অ্যাপ্লিকেবল। তোমার কি হচ্ছে একটা অ্যাবডোমিনাল টিবি, তুমি ডিটেক্ট করতে পারছো না, যে তোমার টেস্ট করেও কিছু আসছে না, তোমার কিন্তু সাসপিশন ইজ দেয়ার যে সাই-TB might have tuberculosis. So you can ask for the relevant investigations and go for the Sci-TB. If the Sci-TB is positive, then you can say the my patient is infected with the TB bacilli and go for the medicine that will be clinically diagnosed extra pulmonary tuberculosis.
Okay.
And you have to give the full course of anti-TB drug. Full course of anti-TB drug.
As Sci-TB test along with the IGRA, this yields much.
Actually, what is the Sci-TB? Sci-TB is basically just two antigen detection. And IGRA is the two antigen giving in the intradermally and see the gamma interferon. Antigens are same, releasing gamma interferon. Gamma interferon detection is little bit costly. Government আমাদের 140 কোটি পপুলেশনে এই টেস্টটা ইন্টারফেরন গামা ইন্টারফেরন আছে is not possible because of cost as around 5,000, 4,000, 3,000 to 4,000, and Sci-TB is hardly 10 rupees or 5 rupees. So same antigen, we are seeing the gamma release as the same antigen, only the antibody we are testing. That is the molecule that interferon gamma.
Other than hospital, Sci-TB can be done in the private.
I do not know. I have no idea regarding the private. They are definitely they will come out. Definitely by PPV model anyway they will come out with the Sci-TB. But they are doing the gamma interferon assay. But it is costly, 2,500 to 3,000 up to 4,000 rupees. But Sci-TB, it is a government role. So it will come definitely. Definitely it will come.
There is no role for the TB gold?
TB gold is basically the same. That is the gamma interferon, IGRA test. IGRA and TB gold are same. It's a quantiferon TB gold. Quantiferon. Gamma interferon. Same. There is no difference. Yes. One question. Yes, sir. Yes. মায়ের টিবি হয়েছে, কোশ্চেন মায়ের টিবি হয়েছে, তো মা এখন টিবির ওষুধ খাচ্ছে, বাচ্চা ডেলিভারি হলো, প্রথমে গাইনোকোলজিস্টকে বলবো যে যখন আপনি অবস্টেট্রিশিয়ানকে বলবো যে আপনি যখন ডেলিভারি করছেন দেখুন প্ল্যাসেন্টাতে টিউবারকুল পড়ে আছে কি না। যদি টিবি পড়ে থাকে তাহলে বাচ্চাকে তার পরের দিন থেকেই আইএনএইচ দিতে হবে। কারণ আইএনএইচ দিতে হবে কারণ হচ্ছে বাচ্চার টিউবারকুলোসিস চলে গেছে। সব থেকে আগে পড়ে কিন্তু প্ল্যাসেন্টার উপরে। প্ল্যাসেন্টার যে পেছন দিকে সারফেস, সেই সারফেসে টিবির মানে ডিটেক্টেড হয়েছে, টিবি মানে মানে তোমার নোডিউল, প্রাইমারি নোডিউল পাওয়া গেছে, তাহলে বাচ্চাকে সঙ্গে সঙ্গেই দিতে হবে তোমার ড্রাগস। এবারে যদি তোমার পাওয়া যায়নি বা অবস্টেট্রিশিয়ান দেখেনি, তাহলে বাচ্চাটাকে আমরা প্রথম বলবো যে তুমি করো, তুমি আইএনএইচ 600 মিলিগ্রাম বাচ্চাটাকে খাওয়াও, খাইয়ে 1 মাস বা 6 মাস খাবে বাচ্চা আইএনএইচ প্রোফাইল্যাক্সিস। মা কিন্তু টিবির ওষুধ খাবে, বাচ্চার ব্রেস্ট ফিডিং বন্ধ হবে না। কয়েক মাস ওয়েট করবো, মিনিমাম 1 থেকে 2 মাস ওয়েট করবো, দেন উইল গো ফর দ্য বিসিজি ভ্যাকসিনেশন। ঠিক আছে? অ্যান্ড অ্যানাদার ওয়ান সোর্স, আম্বেলিক্যাল কর্ডে তোমার গ্র্যানুলোমা পাওয়া যেতে পারে। আম্বেলিক্যাল কর্ড, ফার্স্ট ইজ দ্য প্ল্যাসেন্টা, দেন cut down the umbilical and send for the examination, because transmission through this umbilical cord. So the most of the time we have seen the congenital tuberculosis affects the liver of the baby. So the breastfeeding continued, INH prophylaxis continued. After 1 month you give the BCG vaccination.
Thank you. And
after BCG vaccination, there is a chance of there is abscess as well as lymph node. There is BCGosis. We used to give the INH powder, but there is no much role in the INH powder. It will automatically subside, because BCG is not the Mycobacterium tuberculosis. BCG is the Mycobacterium bovis. So it is a self-limiting disease most of the time after drainage and giving the INH powder, so that will subside. If required, we can give the treatment, but 99.9% আমি এখনো পর্যন্ত আমাদের ডক্টর মুখার্জি অনেক পেশেন্ট পাঠায় আমাকে বিসিজি অ্যাবসেস, আমি বলি স্যার ড্রেনটা করে দিন আর আইএনএইচ পাউডার দিন, ঠিক হয়ে যাবে। তো বেশিরভাগ ক্ষেত্রেই আমাদের ঠিক হয়ে যায়। এটিটি দিলেন, আমরা আমাদের স্পুটাম কখন করাই, প্রতি 2 মাস অন্তর অন্তর স্পুটাম করাই। পেশেন্ট জেনারেলি ইনফেকশাস হতে গেলে যা ব্যাসিলাই নাম্বার লাগে 10 to the power 5, 10 to the power 5 ব্যাসিলাই পার ml অফ স্পুটামে লাগে। তো সেটা 2 মাসের ভেতরে মোটামুটি একটা পেশেন্ট স্পুটাম নেগেটিভ হয়ে যায় 80%, অ্যান্ড 4 মান্থে মোস্টলি 90%। আমরা 6 মান্থ তাহলে দিই কেন? দিই হচ্ছে সাম ব্যাসিলাই উইল বি ডরমেন্ট, they will spurt once upon a time, sudden spurting. So for that reason we used to give the drug for the 6 months, but till date we do not have the treatment for the dormant bacilli. That the bacilli population are different. There are some are rapidly multiplying, some are slowly multiplying, some are intra cavitary, some are extra cavitary, some are intercellular. So various type of bacilli is there. For the dormant bacilli, we are supposed to give the 6 months of therapy. For that reason, it is 6 months. For 4 months, কদিন পরে মেলামেশা করবে? কতদিন পরে? তুমি দুজনে যদি মানে মুখের কাছাকাছি না যাও, যদি মাস্ক পরে থাকে, টিবিকে আমরা বলি কফ হাইজিন মেনটেন করতে, মাস্ক পরে থাকলে 2 থেকে 3 সপ্তাহ পরেই ব্যাসিলাই নাম্বার কমে যায়, কারণ সাসেপ্টেবল ব্যাসিলাই নাম্বার কাম ডাউন ভেরি ফাস্ট। দ্যাট ইজ কল ফল অ্যান্ড রাইজ। তুমি যদি ওই 2 মাসের মধ্যে বন্ধ করে দাও আবার ব্যাসিলাই বেড়ে যাবে। দ্যাট ইজ কল ফল অ্যান্ড রাইজ।
Thank you.
2 থেকে 3 মাস হয়ে গেলেই হয়ে যাবে।
Thank you all. Thank you, Dr.
Thank you so much, sir, for the nice presentation.
Dr. Ta, for your brilliant deliberation. We are very much enlightened with your prudent lecture, and I think we'll call it a day, isn't it?
So thank you, sir, for the nice presentations. I would request Dr. DK sir to felicitate our speaker, sir, and our chairperson. So make some noise. Thank you. A big round of applause for the nice event, whole day event, mind-blowing, completely learning, interactive sessions, one after another, and everyone requesting a big round of applause for all our leaders. Now I would request DK sir and Shubhamoy sir to give our last vote of thanks part. Over to you, sir.
So, শেষের বেলা চলে এলো সুম্মা স্যার So, good evening, one and all. Okay, sir wants to make an announcement, please.
So I have a special announcement. We have so many sessions, and there were so many audiences, learned audiences, colleagues, seniors, everyone. I have seen that Dr. T.K. Mondal was constantly present in every session, and he enlightened us with his questions in many topics, almost all topics. So please, I would request Dr. Tusharkanti Botobal to please felicitate Dr. T.K. Mondal for his wholehearted participation. Please come, sir. Dr. Mondal, please. A big hand, please. Now over to Dr. D.K. Gupta, our organizing secretary.
Thank you, sir. So, once again, good evening, everyone. It's my pleasure to deliver the vote of thanks on behalf of the organizing committee of 10th ABCDCon. First and the foremost, I would like to express my heartfelt gratitude to our esteemed chief guest today, Dr. Satyajit Ray, Amitabh Vishwas, Dr. Rakesh Kumar, and our beloved Dr. Pradeep Ganguly sir, for gracing this occasion and sharing their invaluable insights with us. Their presence has truly elevated the significance of this event. I extend my sincere thanks to our keynote speakers for their enlightening presentation and for shedding light on the recent advancements in the field of medicine, including cardiology, diabetes, respiratory medicine, psychiatry, radiology, and more. Their contribution have greatly enriched the academic value of this conference. Along with this, I would like to pay my regards to senior executive members of ABCDCon, like our president, Dr. Subrata Bhattacharya sir, our academic head, Dr. T.N. Banerjee sir, our senior most committee member, Dr. B.D. Chatterjee sir, Dr. Subhamay Chatterjee sir, Dr. Sujan Sarkar sir, Dr. Arnab Banerjee sir, Dr. Rana sir, and my colleagues Avinavo and Mafidulda. And also, I would like to extend my thanks and gratitude to Dr. Snengdu Ghosh sir and Dr. Rupam Ta sir and Dr. Dinbandhu Naga sir for their extended support. Without their supports and guidance, it was not possible to meet up this Herculean task. I would also like to thank all our distinguished guests, panelists, and moderators and chairpersons who have ensured that each session is engaging, informative, and interactive. Your expertise and dedication have made this event really a successful one. A special thanks to our sponsors and partners whose support and collaboration have made this event possible. Your contribution
have not only enabled us to organize this conference, but also to maintain its standard, which we have been trying to elevate year by year. I am deeply grateful to our organizing committee members, volunteers, and support staffs for their tireless effort and meticulous planning for over last 3 months to making this a single day a successful one. Without your hard work behind the scenes, this event wouldn't have been as seamless as it seems to be. To all the delegates, attendees, and participants, thank you for your enthusiastic involvement. Your presence and active participation have made this conference a meaningful platform for learning, collaboration, and exchange of ideas. Lastly, I would want to thank the members of WABCD, that is Welfare Association of Bardhaman Cardiologists and Diabetologists, for their vision and commitment in continuing this tradition of excellence, which we have been continuing with the ABCDCon series. As we conclude the 10th ABCDCon, let us carry forward the knowledge and inspiration we have gained and strive to make meaningful contribution to the field of medicine, to our patients, and to the society. Thank you, and I look forward to seeing you all at our next edition of ABCD with more grandeur and much of your contribution. Thank you once again. Thank you.
We have just two small, it's not really program, but the end of the valedictory session. So please bear with us.
So, as you all know, that without the support from different sectors of industries, conducting a program like this is not possible. So to begin with, I would name the official partners. Firstly, I would invite one of the representatives from the respective pharma companies to please come on the dais and just have a token of appreciation from our organization. At first, I would like to call upon a member from Novo Nordisk. Please, come on the stage. Anyone from the Novo, Team Novo? Okay. Team Bayer? Sun Pharma, Team CBD? Sun Pharma, Team Gastro?
Please come forward.
Please come forward.
Quickly.
Sun Pharma, Team Acute Cluster? Intas Aquila? Sanofi? USB? Boehringer? Sun Pharma Classic? Novartis? Intas Ultima? Abbott? বলা আছে তোমাদের একজন রিপ্রেজেন্টেটিভকে ভেতরে পাঠাও ভোট অফ থ্যাঙ্কসের জন্য সম্রাটটাকে পাঠিয়ে দাও Ipca 3D, Torrent Pharma, Corona Remedies, Cipla Vitalis, Sinox Division of Lupin, Natco CND, Cipla Team Nebulization, Ipca Dianova, Tasmed, Alchem, Zydus, Cipla Team Inhalation, Team 4, Ajanta, Cipla Supracare 1, Anthem, Altius, Sanatra, হলে মেট্রো এসো তোমার ফেলিসিটেশনের জন্য ঝট করে হলেতে দীপুদাকে ফোন করে ডেকে নাও না বাবু কর্মা দীপুদাকে ঝট করে Frisco Hill Pharmacia, if I'm missing any names from our pharma colleague house and if they are present, I request them to please come on the stage. It may be my mistake that I'm missing someone. If someone has been missed by me from pharma house, I'm requesting to please come on the dais. If not, moving forward, I will request Samalda and Tanmay from team Move It On to come on the dais, please. Deepuda, please. On behalf of BB Caterer, our beloved Deepuda, please come on the stage for felicitation. Your essence of food is now part of our ABCD. And I would now request any team member from Team Sinclair's, Hotel Sinclair's to please come on the dais because their support, their cooperation had made a great difference the way we used to organize our conference previously. There are countless number of members who have made this event possible, but with the paucity of time, it's not possible to ask everyone to come on the dais. But we have a special guest, Somali, whose anchoring has always made a difference. And please, Somali, come on the stage for felicitation. Thank you for your gracious presence. Thank you. So, as the tradition goes, I would hand over the mic to Sir. We know that we end our session with National Anthem. Sir, please.
Okay, I would request all our organizing committee members to come to the dais, please, as per our tradition. And please, other delegates and the pharma executives, please don't leave the hall. As per our tradition, we will conclude our 10th ABCDCon with our national anthem. Please, all delegates come to the dais. Please. Come, please. Quick. Come. Start.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल गङ्गा उज्जल जलधितरङ्गा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
So one last announcement from the whole organizing committee of ABCDCon to our pharma colleagues. As previously we used to arrange a get-together with you guys, this year due to the prevailing situations we have postponed it, and we will in the due course we will inform you the date and venue of our get-together. Please bear with us. Thank you.